we were able to get 61 patients diagnosed as adrenal insufficiency, of which 53 were secondary adrenal insufficiency patients. The study during the study, after the 2-hour cortisol cutoff, we were able to see that the saliva as well as the serum cortisol were taken. First the serum cortisol followed by passive, and then the salivate was then taken to the lab. So the assay used in the study was a Cobas E602 analyzer using Ecleus cortisol 2 kits. Coming to the results, the correlation between the salivary cortisol methods, that is the passive as well as salivate technique. Here we can see the Pearson and Spearman correlation of 0.966 and 0.981, showing excellent correlation with each other. But when you are comparing the both the salivary cortisol methods with the serum cortisol, we can see there is a slightly marginally better correlation with the salivate, 0.84 versus 0.819. So how far apart are these two techniques? To determine that, we had used a Bland-Altman method, and here the mean bias of 0.13 was noted, salivate showing more than the passive rule. So this is implying that both methods cannot be used interchangeably, and particularly when assessing diagnostic cutoffs. So different methods need to have a different cutoff based on the technique. This was again mentioned with the Wilcoxon-Steinrank test as well. So comparing both diagnostic cutoffs for assessing the ROC curve, here we can see there's an excellent AUC for both salivate as well as the passive rule, and based on this we were able to get a cutoff of 1.23 for salivate and 1.04 for passive rule method for diagnosing adrenal insufficiency with a cutoff of 19 micrograms serum cortisol cutoff. So we had mentioned earlier 6 samples got rejected, and all the 6 were there in the passive group. So this is similar to the previous literature that had done in unstimulated salivary cortisol studies, where all the samples, the passive rule had a higher handling issues, whereas the salivate was better, and our study closely correlated with the Paul et al. Study, where the salivate showed better correlation with the serum cortisol and had lower viscosity issues. So the strength of my study is basically this is the only study that compared salivate versus passive rule, and we have used a more commoner actin prolongatum in a resource limited setting, as well as the commonly used Ecleus Cobas 2, which is also commonly available across India. Our limitation is also we have not used the LCMS in our study, and so just concluding, salivary cortisol cutoff of 1.23 and 1.05 were used in salivate as well as passive rule as a cutoff in our study. Thank you.
So after the study, have you routinely started using salivary cortisol in your clinical practice?
Only in adrenal insufficiency patients. We have not started in the Cushing's as of yet. In adrenal insufficiency, we have started.
So you are taking, which method are you using there routinely in clinical practice?
Madam, we are depends on the patient, ma'am. If at all the patient is in most of the settings we use the salivate, but whenever we feel that the patient wants to take the sample home, etc., and they may come back in example, so we'll give them the passive rule. That's basically our urine sample bottle itself. Sometimes still salivate bottles we don't want to give it at 2-3 samples, etc., to home. So but they use the different cutoffs for individual technique. That's it.
Is there a cost difference between these two techniques?
Not much, sir. When we have procured the salivate devices in bulk actually. So individually it is coming to just 2 rupees. So it's fairly same. We are not charging the patients for the device.
Okay, but there is a lot of sample loss in your drooling method.
Yeah, yes, but yeah.
Why do you think so?
So the Ecleus Cobas 2 is basically they have to centrifuge it, and then they have to pipette it out for the salivary cortisol. So whenever we ask the patients to give the samples as a drool sample, sometimes they have this habit of getting some regurgitating and getting some cough also. I'm assuming that is the issue with what is happening. And we have discussed with the lab anyway whether we can remove this, but that has not been achievable. So every time this handling issues has been seen in our study as well as in the prior studies.
Congratulations, a good study. To practical questions, what are the you used synthetic material?
Yes, sir. Because the cotton material has been shown to not have a good recovery.
Good.
So synthetic is the one we have specifically selected because that's got a better cortisol recovery compared
Yes.
to the cotton.
Synthetic is better than
Yes,
cotton. The plant fibers actually they have asymptoms.
Yes.
What instructions will you give to the patient before collecting salivary cortisol?
So the common advice is whenever they ask them to come fasting and try not to brush if possible. So, but if at all the patient is coming, we'll just ask them to wait. No fluids for 1 hour, that is coffee, tea, those kind of things. And up to 10 minutes prior, we have asked them to take water if they want. But for 10 minutes, absolutely nothing should be there. We examine the oral cavity to just see that there is no bleeding, etc. in the dental cavity, in the oral cavity. And the good dental hygiene is also a prerequisite for this. And smoking also, we strictly advise them not to.
Good. No deduction of marks if you don't know. Why no brushing?
So I'm assuming there's a serum, there's always going to be some blood that is going to come out. Yeah.
Very correct. There might be microbleeding. If the blood gets mixed in the saliva, there will be false high cortisol levels. Excellent. Good.
Thank you.
Now I am inviting this fifth presenter, Dr. Anuj Ban.
Good morning, faculty. I am Anuj from KM Hospital, Mumbai, and I'll be presenting our center's data on the utility of Pentixafor PET in subtyping primary aldosteronism. So let's start off with a case of a 32-year-old young lady with hypertension and hypokalemia, biochemically unequivocal hyperaldosteronism, and CT showing a right adrenal nodule with an hyperplastic left adrenal gland. As we all know, CT is considered as inaccurate for lateralization, hence, and AVS is considered as the gold standard. We went ahead with an cositropin stimulated AVS. As we can see, the lateralization index is 2.3, suggesting bilateral disease. But if we look closely towards the A by C ratios in the adrenal veins, they are much lower than that in the iliac veins. This suggests apparent bilateral aldosterone suppression, making this AVS results uninterpretable. Other limitations of AVS are its invasiveness, cannulation difficulties, variable cutoffs and protocols, complex interpretation, and limited availability. Pentixafor PET has come up as a novel alternative as a functional scan to AVS. It targets the CXCR4 chemokine receptor, which is demonstrated to co-localize with aldosterone synthase enzyme, and multiple prospective studies from China has shown promising results. So we aim to study this scan in PA. This was a retrospective study conducted at our center, and records of over the last 2 years were analyzed. Adult patients with biochemically confirmed PA who underwent this PET CT were recruited. Concomitant cortisol excess, suspicion of ACC, and incomplete data patients were excluded. We recorded the demographic clinical details, biochemical details, functional and morphological imaging data, and management and outcome data. For PET CT, 3 to 5 millicurie of the compound was injected, and dynamic and delayed imaging were obtained. For lateralization, a lesion to contralateral adrenal SUV max ratio of 1.65 was used to define lateralization, and individual lesions were considered avid if the SUV max was more than 7.65. Our AVS was a cosintropin stimulated one with a selectivity index cutoff of 5 and a lateralization index cutoff of 4. For classifying the patients on CT, an adrenal gland enlargement of more than 7 mm, either nodular or hyperplastic, and a normal contralateral adrenal gland led to a classification as unilateral. Rest are all the combinations, including bilateral normal adrenals, were considered to have bilateral disease. For PA diagnosis, an ARR cutoff of more than 1.6 nanogram per DL upon micro IU per ml was used with a post-saline loading LO cutoff of 6. For final subtyping, a complete biochemical success defined as per PASO consensus post-unilateral adelectomy was used for defining unilateral, while patients showing partial biochemical success or bilaterality on both the modalities, that is AVS and PET CT, were considered to have bilateral disease. Serum, ALDO, and DRC were measured via CLIA. So we had 30 patients who underwent the scan. 20 were males and 20 showed hypokalemia, that is severe PA. 13 showed unilaterality on PET based on the LCR cutoff, and but the rest 17 showed bilaterality. So among this, 15 patients achieved final subtype confirmation based on surgical outcomes for AVS, and the Pentixafor accuracy turned out to be 14 out of 15, that is 93.3%. When we subclassified these patients as per the CT and PET-CT concordance, we found out that the patient showing concordant lateralization on CT and PET-CT had 100% accuracy, that is 10 by 10 patients showed 100% accuracy, while out of the 5 patients who showed discordance on these two modalities, only 4 were accurate, that is 80% accuracy. Similarly, based on avidity patterns, on unilateral patients showing unilateral avidity, the accuracy was 90%, while patients showing bilateral avidity or non-avidity, the accuracy was 100%. When we analyze the current literature based on this classification, we can see a stark distinction between the accuracies. The accuracy was significantly lower in groups where there was CT PET-CT discordance, wherein the CT was unilateral but PET was showing bilaterality. Similarly, patients with bilateral non-avidity on PET-CT showed a lower accuracy of PET-CT. This is probably due to weak expression of CXCR4 in a subset of aldosterone producing nodules, which has been demonstrated histopathologically as well in around 20%. So we propose that in this two subgroups especially, we could triage the AVS and prevent AVS use in the other subgroups. This is the first data from India, and final subtype classification was based on stringent criteria, which is our strength. This was a retrospective study with a small sample size, and CYP11B2 staining was not available routinely. This preliminary analysis shows that Pentixafor PET-CT demonstrate higher accuracy in certain subgroups, potentially guiding the triage for AVS. Coming back to the case, this case showing ABAS on AVS, we did her PET-CT, showed right avidity on the right nodule, which was 27 SUV max. She underwent surgery, became normotensive and normocalamicous right adenectomy. Thank you.
Propose that you could do your functional scan
Yes, sir.
in a select group of patients, but this is primarily you get after histopathology you come to the conclusion. How would you propose that?
No, sir. So we'll be going ahead with, we'll do a Pentixafor PET-CT at baseline for everyone after CT scan. And then based on the PET-CT results which we are getting, we'll look at the CT and PET-CT concordance and the avidity patterns, and based on that we'll decide whether we need to go ahead with an AVS. If the patient is falling in one of these two subgroups, we'll then advise AVS. If the patient is having any other pattern, we can...
No. My question is,
yes,
how would you find out who is not expressing your CXCR
So
expression?
to predict that, we'll be looking at this pattern, sir. So if you are having a patient with a CT unilaterally, he's having a nodule of 2 centimeters, suppose, a severe PA, but still the Pentixafor is bilateral, that is, it is showing non-avidity, we can suspect that that nodule is not expressing CXCR4 and hence the patient will fall into this category. We'll then prescribe an AVS to him, in which, so that we should not go wrong. In the rest of the patients will be almost 95 to 100% accurate. So this is what we have seen retrospectively, actually. We'll have to confirm in a prospective validation trial, sir, definitely.
If CT is showing a definite lesion, are you still doing Pentixafor in your?
So according to that ES guidelines, ma'am, we'll be not doing, when lateralization is not required, like in a young severe patient with a typical unilateral adenoma, we'll not be doing anything. We'll just go ahead with the surgery. But if the age is, if the patient is not severe, is showing bilaterality, or any one of the criteria, many patients are stuck in any one, especially the age. Patients come at the age of 40, 45, and then the ES guidelines says 35, 40. So then we are stuck there. So that this can actually help in that subgroup also. So we can prevent AVS in those patients where it is actually not that necessary, but just because of the guidelines says that we are stuck with the AVS.
So whenever there is an indication for AVS, you are doing the Pentixafor.
Yes, sir. Whenever lateralization is indicated, we are doing Pentixafor.
A small data, but it's long way to go.
Yes, definitely.
Yeah, it's again a very good study. So where do you suggest to place this investigation in the diagnostic algorithm?
After CT, before AVS. Yeah.
Say there are 2 lesions into both the adrenal glands, 2 bilateral nodules which are picked up, both are picked up by this nuclear scan. So what is your next plan?
So as per our data, sir, we mostly 100% accuracy has been seen in bilateral avidity. So when there is bilateral avidity, all the patients have been correctly classified as bilateral, and they have turned out to be bilateral on AVS also. Now patient preference will be taken, sir. If they are ready with medical management, we can advise medical management. If they still want to confirm on AVS, then we can go ahead. If the patient is severe, has hypokalemia, then we can go ahead and AVS for actually prescribing a non-curative non-curative adenectomy as well, if there is some lateralization, which can help for AVS. But the overall classification will remain as bilateral, most probably on AVS as well.
Yes, correct. Following out with the AVS, I think it will be a good thing if there is any declaration.
Yes.
what is LAR and LLR? Did you calculate the
Yes,
LAR?
sir. Yes, sir. LLR is lesion to liver ratio, and LAR is liver to adrenal. Lesion to adrenal. We have taken a surrogate marker that is LCR, lesion to contralateral adrenal. Some studies have taken that. LLR we had done, sir, but it was a very wide overlap in those two, and it did not help at all in our patients. So we did not classify based on that. LCR turned out to be a very good marker for classification, and hence we had used that, sir.
Good.
Thank you. So moving with the last presentation, Dr. Archana Rao.
Good morning, I'm Archana from KEM, and I'm going to be presenting our data on serum steroid metabolomics in predicting adenocortical carcinoma in indeterminate adrenal masses. So to start off with the case capsule, this was a 43-year-old lady who presented to us with an adrenal incidentaloma. She was a known hypertensive in the background, and she had no other features of cortisol excess or androgen excess. She had a large lipid-poor, poor washout adrenal mass. On evaluation, her PRA was suppressed and ODS was unsuppressed, and her LCMS steroid profile showed multiple raised precursors. So with this, we were thinking that a diagnosis of ACC was reasonable. Now, adrenal incidental-lomas, we know, can be characterized based on their CT characteristics, as these are those with really characteristic radiology like myelolipoma, lipid-rich adenomas, cysts, and hemorrhages. Or they could be indeterminate in the form of lipid-poor adenomas, pheochromocytomas, and importantly, adenocortical carcinomas. So the utility of urine steroid profiling has been known. However, it's quite cumbersome and less available. And in recent times, we are therefore shifting towards a serum LCMS steroid profiling. There are only 2 large studies which include more than 30 ACC cases in their serum steroid profiling analysis. So our aim was to see if LCMS steroid profiling helped distinguish ACC from other indeterminate large lipid-poor adrenal masses. So it was a retrospective study in which we included adult patients, that is more than 18 years, with unilateral large lipid-poor adrenal masses, that is masses more than 3 centimeters and with an HU of more than or equal to 10. We excluded anyone with bilateral masses and anyone with anything with distinct radiology like myelolipoma, cysts, and hemorrhages. We processed this in a central lab using a QTRAP 4500 machine where 13 steroids were analyzed, and statistical analysis was performed by a logistic regression, wherein anything that was significant on univariate analysis with a p-value of less than 0.1 was considered for multivariate analysis. So out of 62 patients of ours, 37 had ACC and 25 were non-ACC. That is pheochromocytoma, lipid-poor adenomas, metastasis, schwannoma, ganglioneuroma, and lymphoma respectively. So the baseline characteristics with regard to the age, the male to female ratio, the presentation, and the basal HU was comparable in the 2 groups. Only the size of the ACCs was significantly larger. Coming to the steroid profile, the androstenedione, cortisone, 11-deoxycortisol, DHEA, DHEA-S, 11-deoxycorticosterone, 17-OHP were significant in both sexes in ACC, and progesterone was significant in males, while testosterone was significant in females. So we excluded testo and progesterone from further analysis due to their physiological variability. We further did a univariate analysis wherein 6 steroids out of these 7 were significant with a p-value of less than 0.1. And further, multivariate analysis by backward method showed 3 significant steroids, that is 11-deoxycortisol, androstenedione, and DHEA, wherein an AUC of 0.928 was achieved. So we had one sensitive cutoff of 0.12, which was 97% sensitive, and 0.65 was a highly specific cutoff with 100% specificity and 83% sensitivity. So just to sum up, 62 patients, 60% ACCs, 7 significant steroids, multivariate logistic regression showing 3 important steroids or discriminatory ones, 11-deoxycortisol, androstenedione, and DHEA, and a probability score of 0.65 deriving 100% specificity and 83% sensitivity. So coming to those 2 studies which had more than 30 ACCs, the German group, their comparator group was only adenomas, and that too lipid-rich and lipid-poor, making this distinction less relevant. They analyzed 15 steroids and had a similar sensitivity and specificity as our study. The more recent study in the USA group, wherein their non-ACC comparator was more relevant, wherein it was diverse, and they had included a subgroup analysis where they included masses more than 4 centimeters and more than 20 basal HU. However, the steroids they analyzed were only 17 OHP, 17 hydroxypregnenolone, which is not as widely available here, and 11 deoxycortisol. Their specificity was also 100%, however, it compromised their sensitivity at only 48%, probably because they did not include any androgens in their analysis. So the false negatives in our own study were probably non-secretory masses, that is truly non-secretory with no steroid precursor elevation, or pure aldosterone or aldo and cortisol producing ACCs. And false positive at a lower cutoff was in a pheochromocytoma which had a raised 11-deoxycortisol. So the strengths of our study is that we focused exclusively on unilateral lipid poor large adrenal masses, in which it's very relevant to diagnose ACC. And it's the first study of its kind from India. The limitations include that it's retrospective in nature and the higher proportion of the more advanced ACC, which might contribute to higher steroid levels. And the findings may not always be applicable in pediatric cases and in PCOS. Coming back to our case in the beginning, we developed a probability predictor tool wherein her score came as 0.042, which was unlikely to be ACC, and she turned out to have an adrenal adenoma on histopathology. Therefore, in conclusion, LCMS steroid profiling is a useful tool in distinguishing ACC from other indeterminate lipid-poor adrenal masses. Thank you.
Good. Congratulations for finishing on time. Again, a very practical question. Where do you would like to place it in the diagnostic algorithm? Will do it in all patients you suspect for adrenal ACC?
So generally the larger adrenal masses, that is anything we wanted to be sensitive, so we included more than 3 centimeters, which are lipid poor on baseline and have a poor washout, that is less than 60% absolute and less than 40% relative washout. So if they're lipid rich, we're not going to consider doing LCMS steroid profiling in such patients. We would consider lipid poor larger masses. We would definitely not want to miss an ACC in such patients. We would recommend LCMS steroid profiling along with ODS cortisol, renin levels, and ACTH levels, and FEO panel as well.
Say if you're allowed to see only one steroid, which would you suggest?
Androstenedione is very significantly elevated, sir, and also 11-deoxycortisol. So this is the secretory ones in which androstenedione comes significantly elevated. The non-secretory gang turns out to have 11-deoxycortisol raised in quite a few, at least 90 to 100% has been reported in other studies.
I think is the most
11-deoxycortisol is very commonly elevated even in non-secretory.
So Archana, you told you will do the steroid panel in a lipid poor adenoma along with the metanephrine, metanephrine. So in clinical practice, do you do everything together or you will go one step at a time?
Ma'am, generally FEO panel, we advise the patient to come fasting, morning sample. They lie down for 20 minutes and then we send it. But there's no harm in sending a morning concurrent sample of LCMS steroid profiling also at the same time, because the timing is important in that.
So in clinical practice as well, you are taking both the panel together?
Not in all patients, ma'am. We see the washout patterns and the adrenal enhancement pattern. If we think that it's very arterially enhancing and as in more to an absolute value of 100 HU or 100% enhancement, then we might consider staging it. We might do FEO panel in the radiologically suspected masses first. If that turns out to be negative, then maybe we'll proceed with a LCMS steroid profiling.
The FEOs will stand out and
yes, ma'am, radiologically.
Profiling may not be required.
Yes, ma'am.
I was wondering why FEOs were included in that non-ACC.
So 2 of them are non-secretory, ma'am, and so it's just like real-world data to see that when you get a large mass sometimes, especially if they're non-secretory, then we would have to end up ruling out ACC as well.
Just interested in what your primary case was showed on the CT washout.
So she had a washout of 30%, a relative washout of 30%, and a basal HU of 25. So that's significantly large. Anything more than 20 has to be looked at for ACC, and a relative washout of around 30, which is less than the defined 40% for good washout.
With the size criteria, we would anyway operate on this lady.
Yes, sir. We would. But the thing is that we were suspecting an ACC, so it does not matter about the route of surgery or anything, but the prognostication and the fact that we might be able to predict that and allay anxiety of the patient also. And so obviously, it's not a very foolproof method, and we're yet to confirm it with larger numbers.
Thank you.
Thank you.
Thank you all the presenters for the excellent presentation, and also lots of thanks to the judges for the excellent questions and discussions. No, they are absent. Yeah. The absent presenters are Dr. Manashwini Bhatt and Dr. Emil Judge. They were absent. So we will again conclude the session, and we will again meet here for the presentation on bone at 11:15 a.m.
Pause your talk.
First of all, I would like to uh, call out the names of the presenters. Dr. Ayush Agarwal, Dr. Ayush Gupta, Dr. Vivek Jha, Dr. Indira Priyadarshini, Dr. Piyash Gargari, and Dr. Duraira Jarjuman. We will call upon the stages in this order only. And we also have with us our respected judges, Dr. Asha HK Madam, Dr. Lakshmi Madam, and Dr. Rajan Palui sir. And we are also very glad to have Dr. Varada sir with us. So the rule is the main presentation time of each presenter is 6 minutes, followed by 4 minutes of Q&A. Kindly stick to the time limits. So I am going to invite on the stage Dr. Ayush Agarwal for his presentation.
Good morning, everyone. I am Dr. Ayush Agarwal from IPGMR. My topic for presentation today will be primary hyperparathyroidism, a study on its clinical genetic and proteomic profile. As we know, primary hyperparathyroidism, the most common cause is an adenoma, which comprises of 85% cases. Apart from that, the Western literature says most of the patients of PHPT are generally asymptomatic, while in India we beg to differ because most of our patients are actually symptomatic with bone pains, fractures, and nephrolithiasis. The most gene mutations are present in actually 10% of the patient, MEN1, CASR, and CTC73 being some of them, while substantial amount of PHPT cases have no genetic etiology. Knowledge gap. There is a sparse data on genetics and proteomics of primary hyperparathyroidism from India. There is limited data on the pathogenesis of sporadic PHPT. So the objective of our study will be for clinical and biochemical profile of patients with PHPT, the assessment of genetic profile, that is the detection of mutation from tissue samples as well as from the preoperative obtained blood, that is plasma as well as whole blood, and their association with clinical and biochemical parameters. We are also looking for the proteomic signature of the patients with PHPT from plasma as well as the tissue. Given the paucity of genetic and the proteomics data on primary hyperparathyroidism, we have adopted a convenient sampling approach, which includes a number of 27 cases and 27 controls. What are our inclusion criteria? The patients who had a biochemically and a HPA confirmation was taken as the cases. For the control part, we have taken patients who have undergone thyroid surgery for any reason, and there was incidental removal of the normal parathyroid tissue in such patients. Our exclusion criteria were the hypercalcemia of malignancy, CKD stage 3, 4, and 5, HP negative cases, and a history of drug intake of lithium, thiazide, or cinacalcet, drugs that could interfere with calcium or PTH metabolisms. What is our workflow? So we took detailed history, biochemical investigation, which was followed by radiological modalities, which was appropriate as per situation. Then we drew the pre-op blood samples, and the patient underwent surgery. The resected tissue was then sent for the histopathology and determination of the lesion that was there. And then the samples were obtained for the genetics and the proteomics part. So first we did a Sanger sequencing, which has the following steps. There is the first step is a DNA extraction, followed by the quality and the quantity of DNA has to be checked. This was done by a biospectrometer. Then we had designed primers, and there was PCR amplification cycle which was obtained. And finally, there was analysis of the mutation. For the proteomics part, first we separated the plasma from the blood. Protein was isolated by ethanol precipitation, and the gel was prepared. This gel underwent reduction, alkylation, trypsin digestion, and peptide extraction. And via LCMS, then we obtained the specific protein with differential peptide content. And the significant altered protein was then validated from these samples. So what we found in our 27 samples, 21 patients actually had adenomas, 4 patients had hyperplasias, while we had 2 patients for parathyroid carcinoma. Around 20% of our patients were actually asymptomatic, but if we see the symptoms, the most common symptoms was bone pain as well as abdominal pain. association that we got, but pancreatitis was present in 18% of those patients. Osteoporosis was present in 33% of the patient, while nephrolithiasis was present in 33% of the patient. When we compare the hyperplasia group with the non-hyperplasia group, we see they have a lower calcium and a PTH value in comparison to the non-hyperplasia group. When we underwent the genetics of these patients from the tissue as well as the whole blood, MEN1 mutation was actually present as a germline mutation in all the 4 patients. This was also present in the tissue as well, while CASR was obtained from the tissue only. So finally, we went for the proteomics part. We identified 18 proteins which were unique to the hyperplasia groups and 17 proteins which were unique to the adenoma group. So we did a string analysis for this protein. These were the 5 proteins that we obtained in the hyperplasia group which had connection to the known genes. These were protein 33, protein zeta, tyline 1, S100A8, TRAP1, and actin 4. While similarly for the adenoma group, we again obtained 5 proteins. These were anthrax toxin type 2, cystatin C, platelet glycoprotein 1b in the alpha chain, macrophage stimulating protein, and the tubulin 3. So what did we obtain? We have found genetic mutation in 6 of our patients, 4 being MEN1 and 2 being the CASA mutation from tissue, plasma, and whole blood. We have also isolated 5 proteins in the adenoma as well as the hyperplasia group, which could be possibly linked to its tumorigenesis. But we have not validated the proteomics part in the tissue now. So we need to validate this protein in the tissue samples. The further research integrating clinical data with multi-omics analysis will be essential in advancing personalized medicines for PHPT management. So this project has been funded with the help of Endocrine Society of India and the Endocrine Society of Bengal. I would also like to thank my college, IPGMR Kolkata, for the help. Thank you.
Thanks, Dr. Ayush, for the good presentation. You said you had 4 patients with hyperplasia.
Yes, ma'am.
How was hyperplasia differentiated from adenoma?
Ma'am, it was differentiated on the basis of histopathology. Generally, on histopathology, when there is an adenoma, we have a normal rim of parathyroid tissue that is present. Also, there is presence of capsule which is there. While in the hyperplasia, no such features are generally there. So that's how we were able to distinguish. We have taken HP as gold standard. All the previous studies that have been also done in the similar manner, ma'am.
And why do you think the calcium levels were lower among the hyperplasia cases as compared to the adenoma cases?
Ma'am, parathyroid tissue volume correlates with the amount of the hormone as we have seen. So the hyperplasias generally are of low weight. The mean weight of adenoma in our study was 2.4, while in the hyperplasia group it was around 0.8. So that's why the hyperplasia group have lower PTH values and hence the less calcium values.
Was this hyperparathyroidism picked up on screening for MEN1 in these patients when they presented with some
most common presentation in our study of MEN1 was primary hyperparathyroidism.
That's true, but was it a symptomatic hyperpara?
Yes,
ma'am.
They
picked up on screen?
No, ma'am, it was picked up on screen. It was not significant. They had no complaints as such.
How many of them have multinodular disease? Any of?
Sir, all the hyperplasias patient, MEN1 patient had multinodular disease. But in the adenoma group, we didn't find any patient with multinodular disease, sir.
So in the string analysis, you have shown that in proteomic study, there are some proteins which is linked with hyperplasia or adenoma.
Yes, sir.
So any specific to the multinodular thing you have also searched for?
Sir, no. Currently, we have not obtained, but there have been studies in MEN1 syndrome. There is a paper from CMC Vellore which has shown there is a specific mutation, C326, which has been linked to hyperplasia. And also there have been papers in proteomics in the, which has shown there is specific genes like heat shock protein 60, which has been linked to multinodular disease and ATP5H. But we didn't find those in our studies.
So the incidence of osteoporosis was 33%.
Yes, ma'am.
So what do you what is the incidence of osteoporosis in other primary hyperpara cohorts from India?
Ma'am, bone disease as such was present in different studies I'm talking about. The last one I saw was an trending change in parathyroidism. In that Asia-specific bone studies were present in 70%. Generally, patient had bone symptoms, out of which 15 to 16% patient almost had osteoporosis.
Only 15 to 16. Are you sure?
I'm not very sure, ma'am.
So what is it? Where did you do proteomics from? Which center?
Ma'am, we isolated the protein, checked the quality of protein, and then we had referred to an external source for the proteomics. Mid-genome.
Okay. And what do you think is a clinical implication here from your proteomics results?
Ma'am, if we are able to search for this protein in the tissue as well and find a biomarker beforehand, or find a marker which can distinguish the hyperplasia and the adenoma group, maybe before the surgery we can be able to tell the surgeon that this is an hyperplasia or this is an adenoma, so that the surgeon can go for bilateral neck exploration or maybe go for minimal invasive parathyroidectomy in the adenoma group.
Thank you.
Thank you, ma'am.
Now, calling our second presenter, Dr. Ayush Gupta.
Good morning, everyone. I will be presenting my study on bone health assessment in transfusion-dependent thalassemia patients. Bone disease in thalassemia is multifactorial, and we know that fracture risk may persist despite normal BMD. DEXA is limited by its two-dimensional nature, and HRPQCT is an upcoming modality which gives an 3D insight into the bone strength along with microarchitectural assessment, which helps it in aiding in disease and fracture risk assessment. Thalassemia studies which have been done in the past report low bone mass and fragility fractures, but prevalence varies and comparisons have been difficult due to heterogeneous evaluation criteria. The primary objective of our study was to assess the prevalence of fractures in subjects with transfusion-dependent thalassemia in comparisons with healthy controls. We also evaluate the bone microarchitecture and measure bone turnover markers in this subject population. It was a cross-sectional study, and all transfusion-dependent thalassemia patients aged 16 years and above who were under follow-up in the clinic or newly registered in Department of Endocrinology and Medical Genetics at our institute over a span of 1.5 years were recruited. So after applying the exclusion criteria, all those patients who had already received anti-resorptive therapy were excluded, and all those patients who had any chronic illness other than spectrum of thalassemic osteopathy were excluded. And in total, 68 transfusion-dependent thalassemia patients and equal age and sex match controls were enrolled. So after checking for normality, appropriate parametric and non-parametric tests were applied. So coming to baseline demographic study, our age and cases and controls were age and sex matched. Thalassemic patients were significantly shorter, they had low weight and lower BMI as compared to control subgroup. Calcium intake and sunlight exposure was comparable in both the subgroups. Most of the patients in our study were thalassemic major compound heterozygous, followed by homozygous, and few patients were E beta and only one patient was alpha thalassemia. Coming to biochemical profile, our patients had significantly higher phosphorus levels as compared to control subgroup. Vitamin D was more in cases as compared to controls, probably because they were on continuous supplementation. And PTH was significantly lower, and bone turnover markers, both resorption and formation markers, were significantly higher in our cases as compared to controls. Coming to endocrine dysfunction, most common endocrine dysfunction was hypogonadism, seen in 41%, followed by hypoparathyroidism, hypothyroidism, diabetes in 21 patients, and few patients were hypocortisolemic. Some patients had multiple endocrine dysfunction as well. Coming to a primary objective, every 1 in 5 patients had a history of fractures. Most were long bone fractures, and few were vertebral fractures as well. 3 patients had asymptomatic vertebral fracture. We found it on VFA analysis, and all these fractures was after trivial trauma. Coming to BMD by DEXA, all the parameters were significantly low in cases as compared to controls in all the sites: lumbar spine, hip, neck of femur, and distal 1/3 of radius. 62% patients in cases had low bone mass as compared to only 15% patients in the control subgroup, with maximum with lumbar spine being affected the most, followed by total hip and the neck of femur. TBS, though not a very validated criteria for young adults, was also significantly lower in cases as compared to controls. Coming to HRPQCT parameters, the total volumetric BMD and cortical volumetric BMD was significantly lower in the cases as compared to controls, and with significant disruption of microarchitecture with decrease in trabecular number, increase in trabecular separation, and more heterogeneity in the bone. And similar findings were also found at tibia region. When we apply univariate analysis for risk factors for associated with presence of fractures, only age and trabecular separation at tibia was found to be associated with high fracture risk. And similarly for low bone mass, trabecular separation at tibia was found to be associated with low bone mass. So comparing our study to previous studies from India, there was one study from PGI Chandigarh which was published last year. We had similar HRPQCT findings as theirs. However, we had a difference in bone turnover markers. We found that in our cases, there were higher cross laps as compared to, and also higher P1NP. This difference might be due to because we had taken treatment naive patients, and in that study, they have included patients who had already received anti-resorptive measures. And also, we did not find any significant association of any endocrine dysfunction, including hypogonadism, with either low bone mass or fracture risk. This probably could be due to because the patients were already on follow-up from the beginning and were on continuous treatment. So the strength of our study is that we have age and gender match, although we did not have BMI match controls. Calcium intake and sunlight exposure data was taken. VFA assessment was done in all patients. Patients were treatment naive, and we had done microarchitectural assessment using HRPQCT. However, we had a modest sample size, and IGF levels were not assessed, and we know that IGF-1 levels are important for bone health, and bone-specific markers like osteocalcin, bone-specific LP were not assessed. So to conclude, transfusion-dependent thalassemia patient has showed lower bone mass and altered HRPQCT parameters compared to controls, but only trabecular separation tibia was a predictor of fracture risk, though large sample size is required to validate the data. The absence of association with endocrine dysfunction may be due to prior treatment. Small sample size limits generalizability of results, and these findings highlight the importance of comprehensive bone assessment and timely interventions to lower fracture risk in these subject population. Thank you. And this study was supported by research grant from Endocrine Society of India.
Thank you, Dr. Ayush. Good presentation. The BMI was lower among the thalassemia patients. As you're aware, the bone density directly correlates with the BMI. So without BMI matching, it is difficult to draw conclusions with regard to the BMD, which was lower among
yes,
the
I agree.
cases. When were the bone turnover markers measured in relation to the fracture?
Ma'am, we assessed the patient. It was a cross-sectional study, so we enrolled the patient when they came to us in OPD, but they had not received any osteoporotic therapy prior to that.
Even if they had fractured a week ago, you've taken their samples for BTMs.
Yes, ma'am.
How does that affect the interpretation of your results?
Ma'am, because if fracture risk is, if recent fractures are there will be increased resorption and for bone formation markers at that time during.
If you were to redo this study, what would you change in that?
I would let the fracture to heal and then take the turnover markers.
After how many months?
Mostly 3 to 4 months.
What is reported in literature with regard to the bone turnover markers following fracture? When do they actually come to baseline?
I'm not sure.
May I ask one question? Yes. Because we did a similar type of study under the guidance of Dr. Badhada. So I would like to ask you, we had actually compared them or taken controls which were BMI and age and gender match. That is most important actually. What do you think? The hypogonadism in them because of the functional hypogonadism, because of the low body fat, because of the low leptin, because if you have a low body fat you can have a low leptin also. It is because of the structural hypogonadism. Both of them can be there. Therefore matching the body mass index is very, very important. And body fat, if it is there, then it will be more important actually and more useful. Secondly, if somebody is on chelation therapy, they will cause actually not only low bone mass or low bone turnover marker, they create a state of osteomalacia actually. So it's very difficult to differentiate osteomalacia from osteoporosis, and most of the time we give them calcium, iron and zinc to them. So normally there is a divalent cation exporter actually of protein which is there in the intestine, and they compete with each other actually. Therefore, even if you give calcium, that may not be very effective actually, whatever we give to them.
Yes.
So these are the things which should be noted.
Is there any difference in this chelation therapy wise, like all these patients in your group, they are properly chelated, or maybe some older patient who doesn't receive any chelation therapy for transfusion was there, or it was?
All the patients were on chelation therapy. Most of them were on desferoxamine, and desferoxerox was also there, and some had combination therapy as well. So it is.
Sorry, last question actually, sorry to come back again. Actually, ideally, the blood sample should be taken just one day or on the day of transfusion.
Yes, so we had.
Otherwise, there will be fallacies.
Yeah, we had taken the samples on the day of transfusion, prior to transfusion.
Can you show the baseline characteristics again? Sorry. So height was lower. Was the BMD height adjusted?
Yes, ma'am. It was height adjusted.
How did you adjust for height?
Ma'am, we had from the standard deviation charts, we have taken, first we have to calculate the height age, then the BMD at that height age, our BMD at of the patient subtracted by BMD at that height age divided by the standard deviation S score, SDS.
What are the implications of HRP-QCT findings on the choice of therapy? Are there any implications?
Ma'am, right now, since it is an upcoming tool, it has not been validated for to change. It's not the data is not enough to draw any conclusion whether we should change any therapy or that.
What conclusion would you draw from your HRP-QCT findings here? How does it help? What are the clinical implications?
The clinical since DEXA does not predict fracture risk, HRP-QCT could be a tool, and in those patients who had increased trabecular separation where microarterial destruction is there, along with the increased heterogeneity of the bones, we can give anti-absorptive therapies to those patients.
Okay, thank you.
Thank you.
The next presenter is Dr. Vivek Jha.
Good morning everyone. In this session of oral presentation, I will be presenting on my original work titled Personalizing Denosumab Therapy, Predictive Roles of Bone Turnover Markers and BMI in Post-Menopausal Indian Women with Osteoporosis. Before proceeding further, I would like to thank my mentor Sanjay Bharada sir for designing the concept of this study and giving me this opportunity. So these are the list of authors who have contributed significantly throughout the study. So regarding rationale, Denosumab's fixed 6-month schedule is based on Western data that may not suit Indian women with a smaller bone size, lower BMD, low calcium intake and high vitamin D deficiency, lower bone turnover and lower BMI. In Indian women may allow safe extension of dosing intervals without increasing fracture risk. BTMs are validated for treatment monitoring and may guide personalized Denosumab dosing. BMI may influence drug clearance. And to our knowledge, till now there is no prospective Indian data evaluating predictors for safe Denosumab delay. Hence, we hypothesize that in post-menopausal Indian women with osteoporosis, lower baseline beta CTX and lower BMI may predict prolonged Denosumab effect, enabling safe dosing beyond 6 months without added vertebral fracture risk. The aim of our study was to identify whether baseline beta CTX and BMI can predict safe Denosumab dosing beyond 6 months in post-menopausal Indian women. The primary objective was to determine the median delay in Denosumab administration guided by BTMs, and the secondary objectives were to identify the predictors for safe dosing delay and to assess the safety in the form of incidence of new vertebral fractures with VF assessment. This was a prospective observational study carried out in Department of Endocrinology in PGIMR over 1.5 years. 56 post-menopausal women aged 50 years or more with DEXA-confirmed osteoporosis were recruited in this study, and all the subjects were treatment naive. So as I've told, it was a prospective observational cohort study, and all 56 patients were initiated on subcutaneous Denosumab at the dose of 60 mg, and the decision on further dosing were based on BTM assessment, which was first done after 6 months of first dose. Those participants with beta CTX 300 or more were given next dose of Denosumab immediately. However, with those with low beta CTX, that is less than 300, they were followed 6 weekly with repeat BTM testing up to 12 months post first dose or until beta CTX crosses 300 limit. Post hoc retrospective classification was done into 2 groups, that is standard group and delayed group based on the timing of Denosumab injection. Standard group in each with 28 participants, and standard group included those participants who had second dose of injection at or near 6 months, and another delayed group who had second dose at 6 months based on BTMs, beyond 6 months based on BTMs. So this is a table showing the comparison of demographic and baseline demographic and biochemical characteristics between the 2 groups, and to note the baseline parameters are those parameters which were noted just before the first dose of Denosumab injection. And from the table we can see that the delayed group had comparatively lower BMI and lower because of technical issue it is not being. Basically, the delayed group had lower BMI and lower beta CTX level, and the cutoff of beta CTX in the delayed group was 497 picogram per ml. Because of technical issue, it is not being seen. This is a table showing comparison of DEXA characteristics between the 2 groups, and from the table we can see that the delayed group had comparatively higher lumbar span BMD compared to the standard group, which was statistically significant. So coming to the primary outcome, the median time to Denosumab dosing in standard group was more or less 6 months, and in delayed it was 9.5 months with IQR of 8.25 to 12 months. So our secondary objective was to identify the predictors for delayed dosing, and the multivariate analysis identified low baseline BMI, that is cutoff was 23, and low baseline beta CTX. The cutoff was nearly 500 to predict safe delay in Denosumab dosing in postmenopausal Indian women with accuracy of 70%. ROC analysis for baseline beta CTX showed optimal cutoff of 497 with sensitivity of around, with modest sensitivity of around 70% and poor specificity 33%, making baseline beta CTX as unsuitable as stand-alone predictor. However, in combination with low BMI, it may be useful for safely delaying Denosumab dosing. We have also assessed new vertebral fracture at baseline just before giving second dose of Denosumab and 1 year follow-up, and we can see that neither of the group had any new vertebral fractures at 1 year post follow-up after the first Denosumab injection. So regarding the strength, it was a prospective standardized study utilizing uniform BTM assays. To our knowledge, this is the first South Asian study focusing on novel insight into BTM and BMI guided Denosumab dosing for postmenopausal Indian women. And in our study, biomarker guided delay showed no vertebral fractures, supporting short-term feasibility, which may be safe and practical in the future. However, long-term study focusing especially on rebound-associated fracture and long-term BMD gain should be carried out before applying in day-to-day clinical practice. Our study has certain limitations as well, which are being acknowledged. One of being a small single-center cohort, limiting a statistical power. The short follow-up of approximately 1.5 years under power to capture long-term BMD changes and non-vertebral fractures or late rebound. Non-randomized post-Hawking group based on BTM may introduce selection bias and unmeasured confounding. Concluding my study, lower baseline beta CTX and lower baseline BMI may help identify women suitable for safe delay of Denosumab dosing beyond 6 months. No vertebral fractures observed during short-term follow-up support safety of modest delay, and findings are preliminary. Basically, it is a proof of concept study. Larger multi-centric trials with longer follow-up are needed. Thank you so much.
Thank you for that good presentation, a relevant study for clinical practice. So what is your message from this study? What do you want to?
Basically, in some low-risk post-menopausal Indian women, since our study was carried out in single center only, and with low BMI, especially less than 23, and low beta CTX at baseline before first injection, that is approximately less than 500. In those selected individual, we can defer or we can plan the Denosumab dosing at 9.5 months interval. But longer data are needed because we don't know the longer fracture risk. Studies have shown with the delay in more than 16 weeks, there are rebound associated fractures.
Did you look at the association of BMI and BMD alone, which would be available in most places? Some places may not have BDM measurement.
Yes, ma'am, and that will not be cost effective also. But if we'll plan, if we'll go for directly extended dosing, then no need to do BTMs in the patient.
So the question you're trying to answer is that whether it is safe to extend the dosing for all?
For short term, ma'am. For short term and not for all. For if we apply the predictors from my study and not single, both should be present.
So, I might have missed it. Was fracture risk low in all of these patients?
Yes, ma'am. No new vertebral fractures.
No, as in baseline fracture risk. Like, have you calculated fracs in these patients? Because lower BMI is associated with a higher fracture risk, right?
Yes, ma'am. But BMI was relatively low. It was not low. It was 23, ma'am.
Okay, lower compared
that
to.
Was yes, relatively low.
What do you think is the pathogenesis behind this? Why should lower BMI have delayed? Be good predictor for.
Yes, ma'am. Basically, if we go through the pharmacodynamics of Denosumab dosing, then we see that there is a linear relationship between Denosumab clearance and body weight. So, in lean individual, the clearance will be low. There will be a sustained systemic availability of Denosumab and prolonged action.
Do you think it will be relevant to calculate the fracture risk between delayed group and standard group if the baseline fracture risk was different between the two groups?
Yes, ma'am. I have not. I'll do that. Thank you for the suggestion.
Thank
you. Even in the delayed group, the low BMI is still not in the normal range. That is in the over range in the South Asian cutoff. So do you think we can say like low BMI? So if you see the mean, it is 23.2 in delayed group.
It was compared to the SRS standard group. That's why relatively low. I'm not telling it is low BMI, but relatively low. So the cutoff I have shown that around 23. It means 18.5 to 23 will be better candidates for short-term safety.
Last question. They were all treatment-naive patients, right?
Yeah.
They had not received any.
All the secondary causes, CKD, all were excluded from the study. And treatment-naive. Everyone were treatment-naive.
Okay, thank you.
Now our next presenter is Dr. Indira Priyadarshini.
Good morning everyone. Today I am going to present a prospective study that is validating an AI tool AstroGo for fracture risk management in glucocorticoid induced osteoporosis. So the prevalence of glucocorticoid use in various population ranges from 0.9 to 1.2%. Among them 21% to 30% develop osteoporosis or fracture. We all know that early recognition and treatment will prevent this fracture, but there is no universal consensus for the intervention threshold for glucocorticoid-induced osteoporosis. So, our main objective was to develop a AI tool for fracture risk prediction and clinical decision making in treatment for glucocorticoid-induced osteoporosis, and to compare its performance with the existing guideline-based strategies. And our secondary objective was to develop a bedside AI tool for aiding this clinical decision making. The study was conducted in Sabdagiri Medical College, Bengaluru for 3 years period, and adults more than 45 years with the following connective tissue disorders were included who were presently taking glucocorticoids or exposed to it for at least 3 months, and the dose of glucocorticoid being more than 2.5 milligram per day of prednisolone or its equivalent. And after consent and ethical clearance, baseline demographic details and history of falls and fracture risk factors were taken, and GC adjusted fracs was calculated, BMD was done, and X-rays were done at baseline and at 3 years follow-up. And we intended to see the ability of Astrago in predicting new onset fractures in this 3 years follow-up period. And we also wanted to compare the treatment decision making of Astrago with the already existing protocols like ACR and IOF ECTS. And all the data were fed to the AI model, which is Astrago, which is a stacking ensemble model. And these data were analyzed by the model, and final prediction was made. After that, the AI tool was trained and testing was done. Statistical analysis was done using the following tests. Coming to the results of the 490 participants, 80% were allocated to the training set, and 20% were assigned to the testing set. This slide compares the baseline variables between the fracture group and non-fracture group, and there was a significantly higher age, previous history of fracture and osteoporosis in the fracture group, and the BMD was significantly reduced in the fracture group when compared to non-fracture group. Comparing the glucocorticoid dose, daily dose and exposure alone is not associated significantly in the fracture group, whereas cumulative dose over a month of 6 months was significantly associated with the fracture group. And the frac score was significantly higher in the fracture group. This slide shows the superior accuracy of the stacking ensemble model with a sensitivity of almost 85 to 90% and specificity of 97%, area under the curve of 0.9. Being a stacking ensemble model, our model uses the individual baseline model to give the final prediction. Hence, the accuracy and precision is higher when compared to the individual models. We did SHAP analysis to see how much each variable contributed to the fracture prediction, and we found these following variables to be most important. Those are osteoporosis, BMI more than or equal to 24.5, prior fractures, age more than 60 years, postmenopausal state, and cumulative glucocorticoid dose more than or equal to 750 milligram over 6 months. We calculated the Astrago score by using the Lasso L1 regression, which determines the weighted coefficient for individual predictors, and we did the Astrago score for the validation set, and we plotted the calibration plot. So this Astrago score was used in the validation set for seeing the sensitivity and specificity, and it was compared with the existing guidelines, and it was showed that our Astrago score is having significantly higher sensitivity and specificity when compared to other guidelines. So summarizing, ours is one of the first AA model capable of predicting and aiding clinical decision making in fracture risk management in GC osteoporosis. It has good sensitivity and better specificity, and we also found cumulative glucocorticoid dose and higher BMI being an independent risk factor for GC osteoporotic fractures. Slide comparing the GC fracs and Astrago. GC fracs is predominantly based on Western cohort. It uses only the steroid use, not the dose, and it is not including the fall history and the postmenopausal state, and here fixed regression model is used, whereas in Astrago it is based on Indian population. It uses cumulative dose and duration. It includes fall history and is based on the stacking ensemble model. Concluding, ours is Indian population specific. It is comprehensive, including fall history and stacking ensemble model, and SHAP analysis enhances accuracy, and Astrago score being a bit simple tool can be used at bedside for clinical decision making in treatment of GC fracture, GC osteoporosis. We also acknowledge we did the study for only 3 years, and we are planning to extend our study, and we are also planning for external multicentric validation. We thank all our participants and institutional grant and research grant for funding. Thank you.
Thank you for that good presentation and novel idea in this field. How many patients had baseline fractures? Vertebral or not?
Actually, we are over the 3 years period, we were seeing the fractures, ma'am. Like whenever they develop the fracture, we feed the system with the incidence of fracture.
Yeah, that I agree. Baseline fractures?
Baseline, no, ma'am. 490 patients we included. Over the time, we see the fracture, and we included in the study.
So when you apply the model will give you an output as whether this patient needs treatment or not.
Yes, ma'am.
For osteoporosis.
Yes, ma'am.
And based on that, you would have started treatment.
Yes,
and despite that, the patient's fractured. Is it?
No, ma'am. We trained the set down. So we used 392 training set. Then remaining were used as the testing set. So based upon the training, we then in the testing set, we used the training for predicting the fracture, and we treated the patient.
What else could be a confounding factor here for osteoporosis assessment, which you could have included in this tool? Because this tool was developed by you.
Yes, ma'am.
What else would affect the risk of fracture in patients with autoimmune rheumatological conditions?
Actually, glucocorticoid itself is protective for this thing, because it decreases the inflammation and reduces the risk cytokines, and can be preventive. But here we have calculated that cumulative dose over longer period is affecting the BMI and higher fat mass, and it is making the patient prone for fracture.
Was the disease activity a parameter in this scoring system? The disease activity of the primary rheumatological
could have been included, but we found there is no significant association with the disease per se in our model.
That's why it was not included. Fine.
Did you note down the baseline subjects? You had 400 some. How many of them had previous fractures? Because that could have resulted into your prediction.
Yes. Almost 40% of the patients had previous fractures.
So what was the difference in the prediction between those who had baseline fractures and those who did not have baseline fractures?
So in the previous patients who were having previous fracture history, those were having higher risk for GC-induced osteoporosis and fractures. So this is there is significant association.
So you compared it with FRAX. Are you aware of FRAX Plus?
Yes, ma'am.
So what does FRAX Plus account for the dosage of glucocorticoids?
Actually, for a dose of up to 7.5 gram of glucocorticoids per day, we are not adjusting. For dose more than 7.5, we are adjusting the FRAX.
No, my question was FRAX. There is FRAX Plus now, and FRAX Plus adjusts for dose of glucocorticoids. So maybe good to compare with that as well, because that's the newest available over FRAX. And if you had to summarize your guidance in 2 lines, how does Astra-Go help in clinical decision making in osteoporosis? How would you summarize it?
Because it is a bedside tool, it is a AA-based bedside tool, we can use it anywhere, like in OPD and IPD.
What are the cutoffs, and what is the guidance for osteoporosis? For example, cutoff of 3, you have to do this, cutoff of this.
If the Astra-Go score is more than 3, we have the scoring system. We have 6 predictors. In that, for 4 predictors, we have 1 as the score, and 2 predictors 2 scores. Total is 8. So if there is a score of more than 3, we can use this preventive osteoporotic preventive treatment for this patient to prevent further development of fracture. Score. Okay. Thank you.
So our 5th presenter is Dr. Priyash Gargadi.
Thank you. Thank you to the organizing committee, the respected judges, and this august gathering to allow me this opportunity to present our study, that is total body less head bone density in Turner syndrome, which is the cross-sectional study. Myself, Dr. Priyash Gargadi, presenting on behalf of my team. This has been my sequence of our study. So we know that bone health has been an area of concern, right? So there is scarcity of information, and we always know that Turner syndrome patients are postulated to have low BMD. But we often forget the BMD is an aerial measurement. Like in this cube, you can see despite having the same volumetric bone density, that is the 2 gram per centimeter cube, the BMD is significantly different. So, in what the guidelines say, that BMD should be assessed at lumbar spine or total body less head, that is from the pediatric positions, and in children with short stature, this should be adjusted by either BMAD or height Z-score, and for TBLH using height Z-score. But for India, there is scarcity of data in the same. Our previous works have shown that lumbar spine aerial BMD and the forearm BMD after volumetric correction does not stay the same, right? So for our objective was to assess the aerial BMD, based on which the power was calculated, followed by these two are the exploratory endpoints. So this is a hospital-based cross-sectional study done for a duration of 5 years, which is a study population of 85 patients of Turner syndrome and 80 age and sex-matched control. This has been our inclusion criteria, and this has been our exclusion criteria. So I found only one study to calculate the sample size, which was from this Suganuma et al., which showed that these were the baseline data based on I calculated the sample size. The sample size is obviously very low, so I taken the primary power of the study, that is the 30 patients. So these patients were undergoing DEXA by a single operator whose CV is with machine is 1.2%, followed by statistical analysis. After that, for the TBLH, the BMD Z-score was adjusted for age, followed by height Z-score adjustment from this calculator, where we can see that despite having a TBLH for age Z-score being a 3.83 minus, it is coming down to minus 0.86. So this has been our flowchart, where the patients were categorized into cases and controls, followed by BMD assessment. After that, we also took the challenge of assessing bone turnover marker by ECLIA, by the streptavidin biotin technique, where this has been our the respective CVs, right? The total P1NP, osteocalcin, and beta cross labs. So sample size, as I have told, calculated, followed by parametric data were analyzed, and as well as the non-parametric data were analyzed using the standard statistical tools. So you can see in the baseline characteristics, there has been no significant difference regarding the age, regarding the weight, regarding the BMI. But obviously, the height is significantly shorter. So if you, as customary, TBLH bone mineral content is significantly lower in patients with Turner syndrome, as well as TBLH bone mineral density, as well as bone mineral density Z-score. But lo and behold, when we went for the height Z-score adjusted BMD Z-score as customary, as recommended by pediatric physicians, there is no statistical significance. Also, there is no statistical significance for TBLH, BMD, height Z-score adjusted BMD Z-score. And when we straight away analyzed these bone turnover markers, there was no significant difference between osteocalcin, between P1NP, or the CTX, that is the C-terminal telepeptides, or some say beta cross labs. So in this study, although TBLH, BMC, and the BMD is significantly low in Turner syndrome patients, but if we go by the guideline, if we go for the height adjustment, the same finding does not hold true. And there has been replicated in some previous studies from Bakalov et al. Or Nadim et al., but the sample size was very low. And these P1NP and CTX, these two parameters were chosen because these are recommended by the previously NOF, right? Now called BOHOF. So after that, the same path, the same results are replicated by the Japanese group, that is the Kawai et al., who showed that skeletal characteristics of children and adolescent Turner syndrome group did not have any low bone density after having the height adjustment. And yes, so this is the result. And there is another study that is coming up from Brazil, which showed there is the low difference in bone mineral density despite having a significant difference in BMD. But these all studies were solely concentrating on either lumbar spine BMD or forearm BMD, but not comprehensively. But our study with TBLH Z-score adjustment and bone turnover marker adjustment, just like that, stands unique. So our one and only conclusion from my study is straight away committing low bone mineral density in patients with Turner syndrome might be an overstatement. So before committing patients of Turner syndrome having a low bone density will not be a very good option. So probably the study from the India, probably the largest Turner syndrome cohort is ours, and the BMD assessed by a single observer, so no inter-observer variability. However, I had calculated my primary objective in terms of what I had, because the other objectives are exploratory endpoints. So adult populations are currently being evaluated for the same, and the cohort is expanding. I would like to acknowledge Endocrine Society of Bengal for funding, and for further acknowledgement to Professor Sujay Ghosh and Professor Pradeep Mukhopadhyay, sir. And thank you. I know miles to go before I sleep. Thank you.
Thank you for that good presentation and getting into the crux of where the problem lies.
Yes.
How many of these patients actually were not yet started on sex steroid replacement before doing this?
Yes, sir. Ma'am, yes, ma'am. As for paucity of time, I couldn't explain that slide. So all those patients who had Turner syndrome were naive of growth hormone as well as any pubertal induction therapy. And those patients who are having spontaneous puberty, they were straight away excluded. So we tried to analyze whether without the effect of growth hormone or the estrogen therapy, how is the bone health of these patients with Turner syndrome. So those patients were straight away excluded. And that's why the subject number was 85. Actual number is very big, actually.
So what formula you used to
yes.
height adjusted Z-score?
Yes, ma'am. So there are two formulas actually. For the lumbar spine, there is this study called BMDCS, where the L1 bone mineral content plus L2 bone mineral content plus L3 bone mineral content plus L4 bone mineral content divided by L1 volume, L2 volume, L3 volume, L4 volume is employed for calculating BMAD. Now, there is a software called pediatric children-based BMD Z-score calculation, where you have to fit all these you have to fit all these BMD Z-scores, which gives you and the respective machines, and which gives you back the height Z-score adjusted BMD Z-score. So that's actually recommended in the ISCD position statement for both the lumbar spine. And unfortunately for TBLH total body, I didn't get any volumetric assessment because that was not recommended any. So I employed that formula for Z-score calculation for the TBLH, ma'am.
And how do you diagnose osteoporosis in the pediatric age group? What are the
Yes, ma'am. Yes, ma'am. So as the guidelines go, the diagnosing pediatric osteoporosis doesn't only require only the bone mineral density assessment, but it also requires inclusion of fracture rate. So presence of fracture rates of more than 2 fractures in the age group of less than 10 years and more than 3 fractures in the age group of less than 19 years, along with the low bone density, actually classifies it to have to call it pediatric osteoporosis. Else only BMD we cannot call it pediatric osteoporosis. So that's why that term it deliberately.
So your study says that there's no difference in cases and controls. What
Yes.
about the fracture incidence?
Yes, yes, ma'am. So that thing is in my entire 100 in our actually 100 to 120 cohort, we have found only one single incidence of fracture, forearm fracture. That too, the child was run over by a car, like that.
So what does the literature say about fracture incidence
Yes, ma'am.
in Turner?
The literature says Turner syndrome fracture incidence is 1.6 to 2.2 times higher. Some says 1.6, some says we are 19 times higher risk for fracture. But all those studies were pretty heterogeneous, and they are mostly concentrated on the elder population age groups. Yes, sir, the TBS was done in our previous study, but it was at exploratory endpoint. TBS did not show any significant difference. However, we have to take it with a pinch of salt because that was not exactly primary endpoint. That's why I was trying to go at my primary endpoint, but that's the exploratory endpoint. TBS did not show any significant difference. Thank you.
So our last presenter of the session is Dr. Duraira Jarjuman.
Good afternoon. It's my utmost privilege to present my work here, and I thank SECON 2025 for the opportunity. So I will be talking on the assessment of cortical and trabecular bone microarchitecture in patients with hypophosphatasia using high resolution peripheral quantitative computed tomography, which is HRPQCT. Hypophosphatasia is a rare genetic disorder caused by mutation in ALPL gene, resulting in reduced tissue non-specific ALP activity. And this enzymatic deficiency leads to elevated levels of inorganic phosphate, impairing mineralization and causing skeletal and dental abnormalities. So with this background, so what was our objective in this study was to compare the bone health in adults with genetically confirmed hypophosphatasia with age, sex and BMI matched healthy controls. So we assessed all these parameters: aerial BMD using DEXA, trabecular bone score, bone microarchitecture using HRPQCT, and bone strength parameters were also measured, but those are apparent parameters using micro finite element analysis. And this is a cross-sectional observational study done at Department of Endocrinology in PGH Chandigarh. And inclusion criteria is age more than 18 years, adults diagnosed with hypophosphatasia based on genetic confirmation of ALPL gene mutation, and age, sex and BMI matched controls were used, and we excluded all other causes of low ALP. And total of 6 patients with hypophosphatasia were included with 30 age, BMI and sex matched controls, and they underwent all these studies. And coming to the results, this is the demographic parameters. The median age was 45.5, and the height, weight and BMI, they were matched. And among the 6 patients with hypophosphatasia, 5 were females and 1 was male. And this is the biochemical parameter. So when we look at the biochemical parameters, except for the ALP, all the parameters were matched, but the CTX that was low in patients with hypophosphatasia, but they were within the range. And coming to the bone mineral density parameters, and patients with hypophosphatasia, the BMD across all the sites like lumbar spine, femoral neck and radius, they were comparable. However, patients with hypophosphatasia, they had a low TNZ scores. Coming to the trabecular bone score, patients with hypophosphatasia, they had significantly low trabecular bone score compared to the controls. And this is the bone structure. We have the cortical bone and we have the trabecular bone. And in trabecular bone, we have this outer and inner trabecular bone. So the inner trabecular bone is less dense compared to the outer trabecular bone. So all these parameters we can study using the high resolution QCT. So that I will be showing in the next slide. So this is the second generation HRPQCT which we have in our center. So we have 2 generations, the first and second generation. The second generation HRPQCT, most of the parameters are directly measured. And so we can measure the bone geometry and the BMD parameter, which is volumetric, and third the microarchitectural parameters, and fourth the apparent strength. So these are all the volumetric BMDs that we can measure. So we can categorize the volumetric BMD as total, and then we can separately measure the cortical and trabecular. In trabecular bone also we can measure the outer and inner trabecular bone parameters. So coming to the volumetric BMD, patients with hypophosphatasia, they had lesser trabecular volumetric BMD, both in the outer and inner region that we can see. So not the cortical volumetric BMD, which was comparable. Similarly, the microarchitectural parameters, we can measure the microarchitectural parameters of both cortical and trabecular bone separately. So in cortical bone, we can measure the thickness, porosity and the diameter of the pores. And in trabecular bone also, we can measure the trabecular number, trabecular thickness and trabecular separation. And this heterogeneity that is given by this inverse standard deviation of trabecular number. So the greater the heterogeneity, the worse is the skeletal strength. So this is the representative HRPQCT image. So you can see the first image shows the control one. The next is the patient with hypophosphatasia. You can see the trabecular numbers, thickness, everything is low in patients with hypophosphatasia. So these are all the parameters. Patients with hypophosphatasia, they had lesser trabecular number, more trabecular spacing, lesser trabecular thickness, and more trabecular inverse standard deviation of trabecular number, which means the bone strength might be low. So these are all the cortical parameters. However, all the cortical parameters were comparable. And coming to the bone strength estimation, patients with hypophosphatasia, they have reduced stiffness and failure rate. And these are the strength and limitation. So this is the first study on bone microarchitecture in Asian cohort. And we have also performed the microfinite element analysis, which will give information regarding the bone strength. Limitation being a small number of sample size due to the rarity of disease, and also bone biopsy. So few parameters which we can study in bone biopsy, we cannot study in HRPQCT, like dynamic parameters and also nanoindentation techniques. Concluding, hypophosphatasia demonstrated significantly lower trabecular volumetric BMD and impaired microarchitecture compared to the controls. So I would like to acknowledge the entire PGI department, especially Dr. Sanjay Barada, for the opportunity. Thank you.
Thank you for the good presentation, a relevant study to understand bone architecture and bone strength in this rare disorder.
Thank you.
None of these patients had any fractures?
Ma'am,
Hypophosphatasia.
so all these patients were asymptomatic. Only one patient had fracture. That was the patient had asymptomatic vertebral fracture. So most of the patients had presented with multiple skeletal complaints, but one patient had asymptomatic vertebral fracture.
All of them had genetic testing?
Yes, ma'am. All were
It was
genetically.
genetically proven hypophosphatasia?
Yes, ma'am. All patients.
Did any of them had any of them received anti-resorptive therapy before they came to you?
Yes, ma'am. None of the patients received anti-resorptive therapy, but one patient received teriparatide for symptomatic management. Like that patient had the patient which I was talking about, the patient who had vertebral fracture. But that was teriparatide was given after doing the HRPQCT. 1 year the patient received.
How would you treat these patients?
Ma'am, the best form of treatment is the enzyme replacement therapy, but it is not available here. So symptomatically we manage these patients. One patient we tried teriparatide also, ma'am.
So same, what are the current guidelines to manage bone disease in these patients, and how does your study add on to the information on what are the clinical implications from your study?
Yes, ma'am. Ma'am, in this study we can see, because in DEXA we cannot compartmentally analyze the BMD. So we cannot, like, definitely the trabecular bone is concentrated around the vertebra, and on this other skeleton we say it is cortical bone. But however, in a single bone we can't separately study trabecular bone and cortical bone. So what we can do in HRPQCT is we can analyze trabecular bone separately and cortical bone separately. In this patient, we have this trabecular parameters because the bone, the trabecular bone is the metabolically active bone. So there we have all these abnormalities. In our study, what we demonstrated is like trabecular bone is more involved, but we do not know whether the enzyme replacement therapy will correct all these changes. So for that, we need a longitudinal follow-up. So that is what, like, in future, if it is available, we have this baseline data, and with follow-up, whether this will improve the bone strength that we can show later on.
What is the current guideline on management of bone disease in these patients?
Ma'am, it is predominantly symptomatic management because short of this enzyme replacement therapy, so we do not have much to offer for these patients. But teriparatide, that has been tried with like limited success also, but mostly it is symptomatic management only, ma'am.
Thank you.
Thank you. Sorry, sir. Yes, sir. We did CTX and P1NP. They were comparable among the group. Yes. Thank you.
Thank you to all the presenters and judges. So we are going to start our next session on gonads. For this, I am just reading out the names according to the sequence. Dr. Amit Bagga, Dr. Arvind Kumar, Dr. Rajni Sharma, Dr. Nidhi Sheth, Dr. Niragi Mehta, and Dr. Arjun Singho. And to judge the session, respected judges are Dr. Beatrice Anna Madam, Dr. Ajit Roy sir, and Dr. Kishore Kumar Behera. So just to remind the rules, there are total 10 minutes, out of which first 6 minutes will be the presentation of the from the presenters, followed by 4 minutes of Q&A. So the first presenter is Dr. Amit Bagga.
Good morning, good afternoon everyone. I am Dr. Amit Bagga from Department of Endocrinology, SGPGIMS, Lucknow. I will be presenting a study on clinical spectrum and etiology in patients of 46XY DSD. DSD are defined as congenital conditions in which the development of chromosomal, gonadal or anatomical sex is atypical. There are limitations associated with biochemical investigations, and genetic analysis promises to be a useful adjunct. Our objective was to study the clinical and etiological profile of patients presenting with 46XY DSD. This was an MB-spective descriptive observational study, and given the rarity and unpredictable referral patterns, we have enrolled all consecutive eligible patients presenting within a defined time window rather than fixing a target. We included all patients with atypical genitalia and a 46XY karyotype, while patients of DSD with other karyotypes were excluded. Thorough clinical history and detailed clinical examination was done. Relevant radiological investigations and hormonal workup as depicted were also performed. We used Roche-Aclia assay for measuring different hormones. A total of 105 patients were screened, out of which 1 patient did not give consent, 27 patients had 46XS DSD, and 26 patients had sex chromosomal DSD. Out of 51 patients who were recruited, 1 was lost to follow-up. So clinical details and investigation details of remaining 50 patients were recorded. 31 patients underwent surgery and 22 patients underwent genetic testing. The data were analyzed using appropriate statistical tests using SPSS software for Windows version 23. A p-value of less than 0.05 was considered significant. Results. The median age at which patients were first noticed by parents was 2.5 months. The median age of presentation to hospital was 50 months, and 76% of patients belonged to urban area. The different etiologies included biosynthetic disorders followed by gonadal development disorders and androgen action defects. The definite diagnosis in gonadal development disorders was based on histopathological examination and or genetic testing. Similarly, in biosynthetic disorders and androgen action defects, the definite diagnosis was based on genetic testing. We divided the total number of patients into 3 groups based on the age at which they were first noticed by parents, that is less than 6 months, 6 months to 13 years, and more than 13 years. Less than 6 months is the period of mini puberty, during which there is transient activation of hypothalamic pituitary gonadal axis, and during this period we can assess for different hormonal levels. So the clinical presentations included atypical genitalia, hypospadias, cryptorchidism, and primary amenorrhea. In some patients, salt wasting, hyperpigmentation, hypertension, virilization, and gynecomastia were also seen. Salt wasting and hyperpigmentation were common in age group of less than 6 months, while virilization and gynecomastia were more common in prepubertal and peripubertal age group. 62% of patients were reared as males. Since gender identity and gender role behavior comes into play after the age of 3 years, so it was applicable to a total of 36 patients, out of which 66.6% of patients identified themselves as male and 33.3% of patients identified themselves as female. One patient underwent change of sex of rearing from female to male. On ultrasonography, Mullerian structures were seen in 16% of patients and gonads were present in 80% of patients. A number of patients underwent surgical procedures, out of which hypospadias repair was the most common, followed by orchidopexy, gonadectomy. One patient underwent feminizing genitoplasty and 2 patients underwent breast reduction surgery. So in patients of gonadal dysgenesis who had definite diagnosis, the AMH levels were low compared to other groups. In patients having biosynthetic groups, the AMH levels were normal with low testosterone levels, and in patients who had action defects, the testosterone level and LH levels were raised, as can be seen. So a total number of 22 patients underwent next generation sequencing, out of which 10 patients had pathogenic or likely pathogenic variants, 6 patients had variant of unknown significance, and 6 patients had no pathogenic variants. Likely pathogenic or pathogenic variants were seen in genes like SRD5A2, 17-beta HSD3, CYP17A1, HSD3-beta2 and androgen receptor gene. Some genes also showed variant of unknown significance, thus highlighting the challenges in interpretation and role of clinical correlation. While 6 patients had no pathogenic or likely pathogenic variants, which again underlines the diagnostic gap and the need for ongoing research in this field. The genetic yield in patients of gonadal dysgenesis was 80%, 40% in action defect group and 53.8% in biosynthetic defects group. Discussion. The incidence in genetic yield in our study varied significantly when we compared it to other national and international studies, like we took into account cohorts from Brazil and Japan. The incidence in genetic yield, it was seen on comparison that it varies across studies and regions. So strengths of our study were it was a large and rare cohort with diverse phenotypic presentation. We did comprehensive clinical evaluation with multimodal investigations and integration of genetics. However, we also acknowledge few limitations like prolonged HCG stimulation tests in prepubertal children are yet to be performed, and we did not use LCMS for hormonal evaluation. So to conclude, XYDSD patients present with diverse phenotypes, genetic testing identified pathogenic variants in approx 40% of those tested. Clinical hormonal diagnosis do not always match, highlighting discordance, and integration of clinical hormonal genetic evaluation provides most accurate diagnosis. Thank you.
So what was the percentage of clinico-pathologic or clinico-genetic correlation in your cohort?
Ma'am, it can be seen that in the genetic yield in, we have mentioned the genetic yield in different groups. So 80% of patients of the gonadal dysgenesis group had positive finding on genetic testing. Similarly, 40% of patients in action defect group and 53.8% in biosynthetic group.
So you about the salt losing, one or two cases presented with DSD with salt losing condition, right?
Yes, sir.
So what was the diagnosis?
Sir, in those patients who presented with salt wasting crisis and hyperpigmentation, the diagnosis was 3-beta HSD2 deficiency.
Okay. So this is the only one case?
This was only one case, sir. Okay. One case which had definite diagnosis of 3-beta HSD2, sir. There were other 2 patients whom we could not make a diagnosis because genetic testing is yet to be done in the remaining patients. We have done genetic testing in only 22 out of 50 patients. This is an ongoing study, sir, and we will be doing genetic study in the remaining patients and also prolonged HCG stimulation test in the prepubertal age group.
So if what are the other differential diagnoses could have been done if it is not 3-beta HSD2?
Sir, most likely the precursor defects present with like salt wasting and hyperpigmentation, and most likely is 3-beta HSD2. Other diagnosis can be like star deficiency. So that can also present with similar findings, sir.
Very good. Is regarding the spectrum of the diseases, you mentioned that the only hypospadias is also included in your study.
Okay, sir.
So only distal hypospadias, how can be possible as a diagnosis of ambiguity?
Actually, sir, we included patients having mid-shaft or perineal hypospadias, and they too had features like micropenis or unilateral absent testes.
So that it does mean that there are some other abnormalities too.
There were other abnormalities, sir, because isolated hypospadias, we cannot include them in DSD, sir. Yes, sir.
You could, but if it is absolute proximal, it could have been.
It could have been, sir.
So anything regarding dysmorphic DSD in your case series?
No, sir, we did not find dysmorphism in our patients, sir.
So when you think about dysmorphic DSD?
Sir, if there are syndromic DSDs, we can...
So without any syndrome, just looking at the level of genitalia.
Yes, sir.
But with the local examination, you could mention that it is probably dysmorphic DSD. I am not dealing with any other congenital anomalies or any other common form of DSD. It's a clinical acumen you can think of. What's about penoscrotal transposition?
Penoscrotal?
Transposition.
Okay, sir. Sorry, sir, I don't have.
Okay.
I don't.
Are not palpable, so you did what is the investigation you've chosen to confirm that gonads are not palpable, or only you have done the SCG test to say whether the gonads are there or not there?
Sir, as I said, we haven't done prolonged HCG stimulation test, and in all the patients we did baseline hormonal investigations which included LH, testo, AMH, and cortisol and ACTH were done wherever applicable, sir. Since this is an ongoing study, we are in the process of doing, and we will be doing prolonged HCG stimulation test in our patients who belong to the pre-pubertal age group. Thank you, sir.
The second presenter is Dr. Aravind Kumar.
Good afternoon, sir. I am Dr. Aravind Kumar, Senior Resident in Endocrinology from Madurai Medical College. I am going to present a short case series on pubertal virilization, unmasking the etiology of 46XY DSD. Virilization is a severe form of androgen excess in females. In 46XY individuals reared as females, pubertal virilization point towards either androgen biosynthetic defect or androgen resistance or gonadal dysgenesis. Timing of gender reconstruction surgery and hormonal therapy is complex in these patients due to socio-legal issues. There is paucity of Indian data about 46XY DSD with pubertal virilization. Our aim was to study the clinical, biochemical, genetic profile and gender identity pattern in 46XY DSD who are presenting with pubertal virilization. Our objective was to find the etiological diagnosis and correlate with gender identity and gender dysphoria. We have included 6 karyotypically proven cases of 46XY who were initially reared as females. We include detailed clinical examination of the patient with basal and stimulated hormonal profile along with imaging, and genetic analysis was done for all these 6 patients by whole exome sequencing. Quantification of androgen precursors were made by LCMS method and ratios were calculated accordingly. A total number of cases who presented with pubertal virilization was 6. The age of presentation were between 14 to 21. All these 6 cases were assigned as female since birth and they were reared as female. The most common presentations were hirsutism, voice change and phallus enlargement. We observed gynecomastia in 2 of our cases and gender dysphoria in 4 of our patients. This is the first patient who's an 18-year-old presented with pubertal virilization and gender dysphoria. He had a phallus of 2 cm with perineal hypospadias and bilateral testes palpable in labioscrotal folds. Basal profile showed high testosterone levels with T by DST ratio of 34.5, suggestive of 5-alpha reductase type 2 deficiency. Genetic analysis confirmed our biochemical diagnosis. He had gender dysphoria from female to male for past 2 years, and he identifies himself as a male. He was reassigned as male sex, and hypospadias repair was done. Second patient is a similar case presenting with similar complaints. He had phallus of 5 cm with penoscrotal hypospadias, and bilateral testis was palpable in labioscrotal folds. His T by DST ratio was high, suggestive of 5-alpha reductase type 2 deficiency. Genetic analysis confirmed the diagnosis with classification being pathogenic. He had gender dysphoria and gender reassignment was done, and hypospadias repair was done for this patient. Case 3 of our cohort is a 14-year-old who presented with pubertal virilization with breast development. She had clitoromegaly of 3 cm with 2 separate openings, and gonads were not palpable. Gonads were palpable in the inguinal region. T by A ratio of 0.2, suggestive of 17 beta HSG3 deficiency. Genetic analysis confirmed our biochemical diagnosis. In spite of severe virilization, she did not have any gender dysphoria, and she identifies herself as a female. So she was treated with GnRH agonist leuprolide and anti-androgens for pubertal suppression till establishment of definitive gender identity, and we have planned for irreversible gender affirming surgeries after 18 years of age. This another 20-year-old presented with pubertal virilization and gender dysphoria. He had a phallus of 8 cm with penoscrotal hypospadias and undescended testis. His LH levels were high with high testosterone, suggestive of partial androgen insensitivity syndrome. Genetic analysis for this patient was negative. He underwent gender reaffirming surgery with bilateral orchidopexy and hypospadias repair. Case 5 is 21-year-old who presented with pubertal virilization with Mullerian structures. He had a phallus of 2 cm with penoscrotal hypospadias with gonads, non-palpable gonads. Imaging showed a rudimentary uterus with small testis-like structure at the deep inguinal ring. Karyotyping showed 45X with 46XY, suggestive of mixed gonadal dysgenesis. His hormonal profile showed high gonadotropins. In this patient also no pathogenic mutation was detected. He was planned for right gonadectomy with Mullerian structure removal. However, this patient was not willing and lost follow-up. Case 6 is a 19-year-old presented with pubertal virilization and primary amenorrhea. She had phallus of 3 cm with 2 separate openings. Bilateral gonads were not palpable. However, in the imaging, gonads were testis-like structures were visualized in the intra-abdominal region adjacent to the external iliac vessels. She had very high gonadotropins with low testosterone levels, suggestive of gonadal dysgenesis. We found a mutation in DHH gene suggesting a partial gonadal dysgenesis. However, the classification was of uncertain significance. She underwent bilateral gonadectomy and clitoroplasty, and she wanted to continue as female. This is a 6-patient cohort in which genetic analysis was negative in partial androgen insensitivity syndrome and mixed gonadal dysgenesis. All other patients had a positive genetic analysis. As far as gender identity and gender dysphoria is concerned, 4 of our patients developed gender dysphoria with male gender identity. 2 patients respectively with 17 beta HSD3 and partial gonadal dysgenesis wanted to continue as female, in which one of them was treated with GnRH analog therapy and other was treated with bilateral gonadectomy with clitoroplasty since she has completed 18 years of her age. Genetic analysis warranted in all cases of 46XOE-DSD. T by DST and T by ratio are valid in puberty and are used in conjunction with molecular testing. Multidisciplinary approaches to avoid inappropriate, premature and irreversible gender affirming surgeries. We have a multidisciplinary DST committee in our college which has conducted 13 meetings in the past 3 years, and decisions are taken as per the committee. Thank you.
It's been good presentation. So I have one clinical question. How you will distinguish this clinically in the 3 conditions bearing that genetic test may not be available everywhere? So yes, how will you have a diagnosis in the preference?
Yes, sir. Gynecomastia will be a usual clue, sir. Gynecomastia will be present in 17 beta HSD3 and partial androgen insensitivity. It is usually absent in 5-alpha reductase type 2 deficiency, sir.
Why so?
LH surge is present, high levels of LH is going to stimulate aromatase activity. High LH is present in both 17 beta and partial androgen, but LH levels are not that high in 5-alpha reductase, sir.
In the patient with the partial androgen insensitivity,
Yes,
where were the gonads?
Gonads were in the inguinal region, ma'am.
Okay. So what is the malignancy risk and how would you follow up these patients for malignancy, and what would you do about the fertility potential? Is there any fertility potential? Would you do anything for these two aspects, the malignancy and fertility potential?
Malignancy potential for a partial androgen sensitivity is intermediate risk, ma'am. We have to gradually follow up the patients with tumor markers, and any development of other feature, rapidly enlarging mass, we have to see, ma'am. Clinically we have to see, and tumor markers we have to see, ma'am. Fertility potential, usually because of long-standing gonads, it is very low, ma'am, fertility potential, and we have to explain it to parents and the patients.
So you have mentioned about the validity of testosterone and DHT ratio
Yes.
in puberty.
Yes, sir.
So why you are emphasizing on the puberty, it is not important in case of mini puberty period?
Yes, sir. Both. Yes, sir. Both in mini puberty and puberty, there is activation of other backdoor pathways and other isoenzyme activity is going to be increased, sir. So the ratios may get altered in both these conditions, sir. So even with the false, even with a low insignificant ratio, we have to consider the diagnosis. But if the ratios are significant, it adds more sensitivity, sir, in pubertal and mini pubertal age groups.
So will it be possible that testosterone by DHT ratio above 10 or above 15 in case of partial androgen insensitivity?
Yes, sir.
How? In PIES, it will be elevated?
Yes, sir. PIES, it can be elevated. T by DHT can be elevated, sir. Androgen receptor action is needed for the induction of 5-alpha reductase activity, sir. Secondary 5-alpha reductase deficiency can happen in partial androgen sensitivity, sir.
Very good. So testosterone is required.
Required, sir.
Okay. So in these 6 cases, the 2 cases are not defined properly.
Yes, sir.
The diagnosis was not done.
Diagnosis was based on biochemical profile only. Genetic diagnosis was not available, sir, for these 2 cases.
So one point, one patient is mixed gonadal dysgenesis.
Yes, sir.
So in case of mixed gonadal dysgenesis, again you send a sample for genetic testing. So is there any necessity to go for any further genetic testing when you got the karyotype reports?
Yes, sir. We have to send for genetic testing, sir.
Why? Is there any rationale behind that? It is the wastage of money, maybe.
Okay.
So
no, sir.
XY-DSD mixed gonadal dysgenesis, they can present like that.
Yes, sir.
So any rationale behind it?
No, sir.
I do not know. Just I am asking you.
No, for research purposes, we have done, sir.
Thank you.
Thank you, sir.
Good.
Our next presenter is Dr. Rajni Sharma.
The slides. Uh, 371. Good afternoon, esteemed judges and the audience. The topic for my study is liquid chromatography mass spectroscopy and anti-Mullerian hormone in healthy Indian school-going adolescent girls in various phases of the menstrual cycle. So the diagnosis of adolescent PCOS is based on the presence of menstrual irregularity and clinical or biochemical hyperandrogenism. However, the definition of normal testosterone levels remains unclear. Moreover, LCMS is recommended as the standard for steroid measurements. However, reference ranges for androgen profiling by LCMS for Indian adolescents is not available. Also, serum AMH is currently not recommended for the diagnosis of adolescent PCOS due to lack of clarity on normal values in adolescents. In this study, we measured the serum testosterone levels and AMH and its relation to the menstrual cycle phases and BMI. So methods This was a cross-sectional study in North India among girls studying in private schools. Apparently, healthy girls with regular menstrual cycles were included in the study and as defined by the consensus guidelines. The main outcome measure was serum testosterone measured by LCMS and AMH by Access AMH, Beckman-Coulter automated immunoassay. The study was approved by the ethics committee. So this is the flow diagram of the study. Schoolgirls who underwent clinical history and examination, a total of 1,469 girls, out of which 1,068 were postmenarchal and 837 consented for blood. Those with irregular menstrual cycles beyond 1 year of menarche and or hirsutism were excluded. A few were excluded due to incomplete information or chronic medication. So the final cohort consisted of 641 girls with regular cycles. Coming to the results, the mean age of the patients was 14.3 plus minus 1.99 years, and the age of menarche was 11.6 plus minus 1.1 years. Around 26% were overweight and 22% were obese. This is showing the mean and SD values of serum testosterone based on the gynecological age, as is the post-menstrual age, from 1 year to 5 years gynecological age, and these are the mean values and the range. So as we see, the mean value of testosterone is increasing from 0.269 nanogram per ml progressively to 0.368 nanogram per ml, and this was significant, p less than 0.0001. Coming to the smooth percentiles of serum testosterone, these are the percentiles according to the gynecological age, and we have given the 3rd, 50th, and 97th percentile. Again, we can see that the values are progressively increasing with age. So I'm sorry, there's some the serum testosterone by gynecological age, the median and interquartile box and whisker diagram is shown here. As we can see that in a gynecological age less than 3 years and more than 4 years, there's a significant difference in the testosterone levels. Now coming to the smooth percentiles of serum AMH in nanogram per ml according to the gynecological age and the percentile values, that is the 3rd, 50th, and 97th percentile. So what we see is that the AMH values are progressively increasing with age, and this was also significant. This is a similar graph which is showing the AMH levels in relation to the age, and we can see it is increasing progressively with age. These are the median and interquartile range of testosterone in various phases of the menstrual cycle. So we have seen in the early follicular phase, the mid-cycle, and the luteal phase, and we can see that the testosterone levels are higher in the mid-cycle phase, and it was significant in almost all gynecological age groups. AMH was also measured in the various phases of the menstrual cycle, and here we see that the values are not much different and it is insignificant. Then we measured the relation between AMH and serum testosterone. So we can see that there's a positive correlation between the AMH and the testosterone with an R square of 0.545, which is highly significant. And this relation existed even in girls with normal menstrual cycles, and this was independent of age. Now this is showing the, so as we know that we define PCOS based on the testosterone in the follicular phase. So we have measured testosterone in the follicular phase in various gynecological ages, and here we see the 95th percentile, which is 0.421 nanogram per ml in gynecological age less than 3 years, from 1 to 3 years, and it is 0.52 nanogram per ml in gynecological age more than 3 years. We also measured the various testosterone levels in various categories, and we found no difference in the overweight, normal, and obese categories. So discussion, most of the data on testosterone and AMH is based on older women, and there's hardly any data in adolescents. Bai et al. Have published the median and interquartile ranges by LCMS in 10 to 15 years and 15 to 20 years. However, they did not classify what was the menstrual phase of the cycle. Fenelli et al. Have studied 159 Italian schoolgirls aged 16 to 19 years, and they've given an upper reference range of follicular phase testosterone to be 0.438, which is slightly lesser than our cutoff, that is the ethnic cutoff for our population. However, this was a small sample size. The strengths of the study is that the serum values of testosterone was measured in girls who had regular menstrual cycles and as per the menstrual cycle phase and gynecological age, and it was a large sample size. The limitation would be that we did not measure sex hormone binding globulin. So coming to the conclusion, we have generated ethnicity and menstrual phase specific reference ranges for serum testosterone by LCMS and AMH for Indian adolescent girls, And our study results are useful for defining cutoffs for hyperandrogenism for Indian adolescent girls and for the diagnosis of PCOS. Thank you. I would also like to thank the Society of Endocrine Health for the funding of the study. And yes.
Thank you. It's a nice presentation. So I have two questions. One is how this serum testosterone will help in clinical setting. And second one is we expect there may be some changes in the testosterone level in overweight and obese patient, and if it is not there, how to explain?
Yes. So the second question, basically we did not find any difference in the age groups, and these were girls who had normal menstrual cycles. So there may be a difference in the girls who are obese and actually have PCOS. And secondly, the obese girls, they may have low sex hormone binding globulin. That may lead to lower, that may lead to higher free androgen index. In our study, we've not measured the free androgen index, we've measured the total testosterone, which was similar. So that shows that the ovaries are producing equal amount of testosterone in all these weight categories.
Well, the testosterone is measured in the fasting stages, in the early
Yes,
morning.
yes, it was in the fasting stage.
It's a very good study because firstly to do all these blood investigation in normal school-going children is extremely difficult. So I want to appreciate you for this study first.
Thank you, ma'am.
And do you have any, you said you have derived cutoffs. So what are the cutoffs that you would give for testosterone and for AMH?
So the cutoffs actually I've shown here.
So you said the AMH did not vary with...
Yes. So cutoffs for AMH are, these are the cutoffs for AMH. So we see that the values even go up to 9 in normal children who have normal menstrual cycles. And so we do have some girls who have PCOS, so we are yet to analyze that in them, what is the difference between the two groups. So this is just the normal.
Some overlap, especially
Yes,
in
yes.
the higher ranges.
Yes.
And
So
that holds good even for testosterone?
testosterone there would be, but this is all the normal girls. This is the upper level of the normal girls.
Because your inference was that it be used for the diagnosis of PCOS,
Yes, yes.
but these are all normal children.
Yes, so this
you've
is,
not really
this is to,
studied it in PCOS, so that inference cannot be made.
okay, so this is for the reference
probably
data.
normal, and then when you study it in PCOS, you can
Yes.
say that if it is more than this,
Then it is
probably
higher,
you can
yes.
make a diagnosis of PCOS.
So here the 50th centile would tell us the normal values for AMH at that age.
Can you keep this slide only here? And wonderful presentation. But I want to say, what was the number in each group actually? Could you
Actually,
mention?
I've given the numbers here.
No, in the same slide actually you could have written
Yes,
N.
yes, sir.
What is the number
Yes,
in
number
each
in
age
each
group
group, yes.
actually? And you could have done actually both by LCMS and both by chemiluminescence, because chemiluminescence day-to-day practice we use more often, and you
Yes.
could have calculated the R value or what is the
Yes,
conversion factor, then it would have been more useful actually for future.
Yes, so thank you so much. Actually, we have done by chemiluminescence also, and that is another study comparing both the values,
Okay.
the correlation between them.
Okay, thank you, thank you.
Like why you were interested?
Yes.
Yeah. So why you were interested in checking free testosterone rather than total testosterone?
Total testosterone is used for the diagnosis, but it is found that sometimes even the free testosterone levels may be increased, especially in obese girls.
So as
But that
sir
is not
already
the,
said that
yes, yes.
we can check SHBG and we can check total
Yes,
testosterone.
yes.
And by that way we can go for free testosterone index.
Yes.
And it is usually available.
Yes.
But
Yes.
there should be some rationale behind to check free testosterone,
Yes.
particularly with the LCMS. So what's the rationale behind that?
So we have measured the total testosterone.
Yes.
Yes.
Total testosterone by
Yes, sir.
LCMS.
Yes, sir.
So
What is the rationale for measuring? So it is more valid compared to the levels that are measured by immunoassay. Immunoassay can be false. I mean, the levels may not be accurate by
why
immunoassay.
not accurate? Is the testosterone structure?
Yes. Okay, sir.
So is there any other
So there's a lot of,
androgens?
yes, so there are a lot of androgens and there's a lot of cross-reactivity with other androgens.
Okay.
So this is very specific.
But the study is very good.
Thank you, sir.
Okay, sure.
The next presenter is Dr. Nidhi Sheth.
Good morning, everyone. So my topic is metabolic dysfunction in PCOS, a transcriptomic view among MBBS students. PCOS is the most common endocrine disorder in reproductive age group. Insulin resistance is the key mechanism in pathogenesis of PCO. Yet the transcriptomic signature of PCOS remains underexplored in young adults. What is transcriptome? It is a complete set of RNAs. Majority of it, 98%, consists of non-coding RNAs, while only 2% consists of protein-coding transcripts, that is mRNA. PCOS has a two-hit hypothesis, that is genetic predisposition followed by insulin resistance. On literature search, most of the transcriptomic studies in PCO has focused on tissue, that is ovarian granulosa cell and endometrium, while only a few studies have focused on PBMC. The novelty of the study is it is an integrated clinical imaging and transcriptomic approach in young adults and identify molecular signatures in PCO. My objectives were to study the clinical parameters and possible transcriptomic signatures specific to PCOS. So we have enrolled voluntarily consenting MBBS students from 3 medical colleges from Calcutta after screening out exclusions like secondary PCOS, PCOS on occipitals, and diabetes and dyslipidemia. A complete clinical, biochemical, hormonal parameters, hormonal workup was done. Using Rotterdam criteria 2003, we got 36 PCO cases while 51 non-PCO cases, and excluding the 15 at-risk PCOS. RNA was extracted from PBMC from 5 PCO samples and 15 non-PCO samples, and total RNA sequencing was done. Then we compared the data of transcriptomic signatures between PCO and non-PCO using appropriate bioinformatics and statistic tools. Coming to results, the 36 PCOS cohort, in this cohort, most common parameter was oligoanovulation, around 88%, followed by PCO morphology in ultrasound, 75%, and least common seen was hyperandrogenism, 58%. Comparing the clinical and metabolic parameters, BMI, insulin, HOMA-IR was statistically significantly elevated in PCO as compared to non-PCO group. SHBG was low, and comparing the DEXA body composition parameters on DEXA, fat percentage and fat mass index was higher in PCO as compared to non-PCO group. Coming to the methodology of total RNA sequencing from PBMC, so we had extracted RNA from PBMC at our lab. A quality check was done. Library was prepared by reverse transcriptase to complementary DNA. Then sequencing was done using Illumina technique, followed by quantification, alignment. After data pre-processing, differential expression analysis and pathway analysis was done. Coming to the results, we got 73 differentially expressed LNC RNA, as we can see on volcano plot on the left and heat map on the right. We got 111 mRNAs, that is protein coding genes, in PCOS group, out of which 27 were upregulated and 84 downregulated, as we can see on the volcano and heat maps. So out of the total 73 LNC RNA, we selected only the 15 LNC RNAs whose targeted mRNA was found. This was done using RNA Inter database, followed by which enrichment analysis was performed using Enrich-R software for these targeted mRNAs and all the rest mRNAs. So pathway analysis was done using KEGG database. So the top 10 pathways upregulated in PCOS as shown in the screen, out of which the 4 highlighted, that is arachidonic acid metabolism, ferroptosis, age-rich signaling pathway, and pathways in cancers. These were the pathways associated with metabolic dysfunction and the genes related to this pathway as shown on the right side. So on literature search, we found that LOX15 gene was upregulated in granulosa cell in animal model, and it positively correlated to the lipid dysfunction. While in our study, that is we did transcriptomics from PBMC, LOX15 was downregulated, and we did not get the lipid dysfunction significant worsening in PCO group. Coming to interleukin 1A, it was upregulated in granulosa cell, and in literature search, it was found that higher levels of interleukin 1A was also seen in lean PCO, while in our study interleukin 1A was downregulated. Coming to fibronectin 1, on literature search, it was found to be downregulated in follicular fluid and skeletal muscle and upregulated in plasma, and this fibronectin 1 was correlated with insulin resistance, and it can be a possible biomarker for disease presence. In our study, what we found was fibronectin 1 was downregulated, and we had significant increase in the insulin and HOMA-IR parameters in PCOS compared to control. My future plan would be this LOX15, interleukin 1A and fibronectin 1 genes will be validated in future using RT-PCR. So in summary, we got 73 differentially expressed LNC RNAs and 111 mRNAs. And 4 pathways which we found was associated with metabolic dysfunction, and out of 19 differentially expressed genes, 10 were novel. So the implications and way forward would be this differentially expressed genes will be validated in future on a larger cohort. On validation, these molecular signatures could help in better understanding of pathophysiology and may serve as early marker for diagnosis of PCOS. I would like to thank Endocrine Society of India and Endocrine Society of West Bengal for funding this research. Thank you.
It's a good study. I know
Thank
it's
you.
a small sample size, but
Yes, ma'am.
did you find all this genetic dysregulation in both obese as well as lean PCOS in your cohort?
Actually, ma'am, this is a part of a study. In future, my plan would be to differentiate the genetic signatures and transcriptomic signatures between obese PCO and lean PCO. So a targeted approach and individualized approach can be done for both obese and lean PCO.
And do you intend to follow up these patients?
Yes, ma'am. This is a part of a 6-year long study. So actually, this is the 2nd year follow-up study.
How much is the cost if you will implement this microRNA to diagnose this PCOS? How much is the cost to analysis of this in a, you can do it in research center, but some of the periphery, or you want to implement in the medical college in the periphery, how will do that and what will be the cost?
Yes, sir. So this is just a pilot study, a starting step. So for each transcriptomic study of 1 sample costs around 30,000. So maybe in future, if it is implicated on a larger base and validated after RT-PCR, the cost might reduce after the RT-PCR only, if we pick up just 1 gene out of it.
See, the PCOS is completely a clinical diagnosis. So
Yes,
you do
sir.
this and you spend a lot of money, then what you will get extra benefit?
No, sir. It's not only PCO. Actually, we wanted to see the metabolic health, how early the metabolic health in female appears. So, because PCOS is a forerunner of metabolic syndrome in future, like diabetes, dyslipidemia, cardiovascular morbidity, everything. So I chose for PCOS. Sir.
It's a good study, definitely.
Thank you, sir.
But I can say that you are doing such a big work here, but a few patients with PCOS, they are not responding to conventional treatment. Few patients are responded to the conventional treatment. So the rationale behind this study could be to find out some other pathways by which it could be the answer, Sarah, it could be the. And second is, if we want to do any study regarding metabolic syndrome or polycystic ovarian syndrome, so we have to, we do not know the exact pathway of why PCOS is occurring in case of, in this age group particularly. So, and sometimes patient present in a very later stage. So if we want to find out some early biomarker, that could be helpful from your study possibly.
Yes, sir. The main thing was, yes, sir. So after transcriptomic study, we'll get different pathways. So the pathways which are associated, which are linked with metabolic dysfunction, we can particularly target that pathway and that genes which are associated with metabolic dysfunction. So individual based approach in future can be a standard for PCOS management.
All these studies, at least in this present moment, could you find anything that if I do for a particular patient, it could be helpful to early diagnosis of polycystic ovarian syndrome?
Yes, sir. Yes. So these 3 genes which I could found, which are actually downregulated in the transcriptomic study in PBMC. So this can work, like interleukin 1A. I have not gone for the interleukin 1A level in my thesis, but if interleukin 1A is elevated in any PCO female, that is lean PCOS, so we can target that pathways which are upregulated in lean PCOS patients.
Sure. Thank you.
Okay. Thank you. Thank you, sir.
So our fifth and penultimate presenter is Niragi Mehta, Dr. Niragi Mehta.
Yes, yes. Okay.
Orijitda, are you ready to present? Oh, please. So just a shift. Yeah. Do. Okay.
Good afternoon, everyone. Sorry for the delay. Today I will be talking on ovotesticular DSD, a single center experience from KM Hospital, and systematic review of occurrence of germ cell malignancies. So as we all know, ovotesticular DSD is a rare disorder where ovarian follicles and testicular tissue are present in the same individual. The incidence of OTDSD is quite low and it's more common in the African population. The anatomical types of OTDSD include unilateral, bilateral or lateral, with unilateral showing ovotestis on one side and a testis or ovary on the other side. Most common karyotype in literature is 46XX, followed by mosaic and 46XY with ethnic variations. Looking at the molecular aspects, 46XX individuals may have SRY translocation leading to OTDSD, or SRY negative 46XX individuals may have increased expression of pro-testicular factors like increased SOX3, SOX9 and reduced expression of pro-ovarian factors leading to the development of an abnormal gonad. And coming to the malignancy risk, it's reported to be about 2.6 to 4.6%, but there is insufficient data reported in literature. So in our study, we aim to describe histologically proven OTDSD patients and conducted a systematic review of literature of malignancy in OTDSD. We included patients from 2005 to 2025 and also included their hormonal profile, peripheral blood karyotype, FISH for SRY and genetics by NGS. Systematic review of literature was done from 1990 to 2025. So we had 15 patients in our cohort. Out of these, 14 were male and 1 was female. Median age of presentation was around birth, but the median age of evaluation was 8 years. Most common presenting complaint was genital atypia. Most common karyotype was 46XX in 14 patients with a mosaic karyotype in 1 patient. As we can see here, on examination, male predominant genitalia were seen in 10 patients, followed by ambiguity and female predominant genitalia. Mullerian structures were seen in all our patients on imaging or intraoperatively. So the hormonal profile showed a unanimously low testosterone level across all age groups and a low HCG stimulated testosterone level as well. AMH levels were available in 4 patients, which were lower than the male reference range but higher than the female reference range. Inhibin B was also low in our patients. So the most common type was lateral, most common gonad was ovary. Ovaries were usually abdominal in position. Ovotestis was also commonly abdominal, whereas testis was scrotal. Ovarian tissue was commonly seen on the right side. So we did FISH for SRY in 9 patients, which was negative in all, and we did NGS in 12 patients. Only one of them had an RSPO1 heterozygous mutation, but this was of uncertain significance. Median follow-up of 5 years where there was cyclical hematuria, abdominal pain, gynecomastia in the male patients. They were all given testosterone replacement therapy. One patient who was female had primary amenorrhea and was found to have dysgerminoma arising from ovotestis. There was no gender dysphoria in our patients. Coming to the malignancy review, we had 44 patients with gonadal tumors, out of which 32 were included, and then we had 25 patients with germ cell tumors. So the median age of malignancy was 25 years, with a common Y cell karyotype in these patients in 14 out of 22 patients. Most common tumor was dysgerminoma. Gonads involved were ovotestis commonly, and the position was abdominal. So on follow-up, most of the patients remained in remission, while 2 patients had progressive disease. So this is the largest series from India. Our karyotype was in keeping with other Asian studies. Ethnic variations have been observed where mosaic karyotype is more commonly seen in North America. And lateral OTDSD was more common in our cohort, like the Chinese, but in literature, unilateral is more common. Ovary was the most common gonad in our cohort, again similar to China. We had low testosterone, AMH and inhibin B, all signifying dysgenetic testicular tissue, whereas there were signs of functional ovarian tissue in the form of gynecomastia and cyclical hematuria. So our genetic yield was low. This was in keeping with other few published reports. Malignancy review showed that 63% patients had a Y cell line. Most common malignancy is dysgerminoma. Older age and bilateral gonads in situ may be a risk factor for malignancy. And intra-abdominal ovotestis had a higher risk of malignancy as compared to other descended gonads. So this was the first case series with FISH for SRY and NGS. Our limitations were a small sample size and retrospective nature of study. I would like to conclude that ethnic variation in Indian OTDSD is observed. There is a poor testicular function across all age groups, low genetic yield, malignancy risk is low, and the risk factors for malignancy include presence of Y chromosome, older age, intra-abdominal gonad, and ovotestis. Thank you. I would like to acknowledge Dr. Manjari Karlekar and the whole department at KEM Hospital for giving me this opportunity.
Study definitely along 2005 to 2025.
Yes, sir.
It's a very good cohort here. So, why the malignancy risk is low in case of ovotesticular DSD?
Sir, the ovarian tissue and the ovarian tissue is functional, and the testicular tissue is dysgenetic. But the risk is observed with even in spite of the dysgenetic gonad, the risk is quite low because of the functional ovarian tissue being there. So predominantly in gonadal.
This is always dysgenetic. That means I want to say, how would you differentiate between the mixed gonadal dysgenesis and ovotesticular DSD?
Sir, in mixed gonadal dysgenesis, there will be a streak gonad on one side, and there will not be a functional ovarian tissue in terms of follicles. But in ovotesticular DSD, there will be a follicles which will be differentiating.
Okay, so why the malignancy risk is different between the MGD and the ovotesticular DSD? In both cases, there are maybe there is mature follicle in case of ovotesticular DSD, but why the malignancy risk is low?
Sir, the testicular tissue in these patients over a period of time undergoes hyalinization, and there is poor spermatogonia. But the ovarian tissue is functional, and I think that the presence of the functional tissue makes the malignancy risk lower.
Actually, what happened, the undifferentiated germ cells
yes,
occurs in case of mixed gonadal dysgenesis. The undifferentiated germ cells are more, there is more chance of epigenetic
yes,
reprogramming.
Yes, sir.
And there is a chance of demethylation.
Yes,
It
sir.
is the reason why they will be susceptible to mutations.
Yes, sir.
But in this case, they are a little bit mature. So it
Yes,
is the
sir.
reason why they are
Yes,
not
I
going
was
forward.
trying to say that. Yes.
Anyway, it's good.
This is a very good study.
Thank you, ma'am.
So this patient that you had mentioned with malignancy.
Yes, ma'am.
So the gonads were intra-abdominal.
Yes, ma'am.
At one side there was a.
So she came to us at 20 years of age. She came with primary amenorrhea and abdominal pain. Then she was found to have a left-sided mass, and then it was found to be a dysgerminoma arising from an ovotestis. After that, we diagnosed her as having ovotesticular DSD. Post-operatively, she was given chemotherapy, and patient is now having regular menses on oral contraceptive pills. She has an ovary in situ. The other gonad is ovary. It's biopsied. Okay, thank you. Thank you.
So the last presenter of the oral paper session is Dr. Orijit Singh.
So thank you. My topic is harnessing novel anthropometric and ultrasonographic data to develop predictive AI modeling in male hypogonadism, a novel Praman from India. We all know that Klinefelter and congenital hypogonadism are the important causes of hypogonadism, but there is limited data, particularly in terms of second to fourth digit ratio and testicular or epidermal ultrasonography, and there is no previous predictive AI model incorporating this accessible data to CHH. This is the usual workflow or machine learning study. I will skip that. Our primary objective to assess and compare the novel anthropometric and ultrasonographic features of testis and epididymis among patients with male hypogonadism. The secondary objective to develop indigenous machine learning model. The CHH was diagnosed by a combination of clinical and biochemical findings, and every Klinefelter syndrome patient was diagnosed by clinical as well as karyotype findings. The study was done across the 5 years, and the age group was more than 18 years, and these are the exclusion criteria. So we have included the demographic profile, clinical features, second to fourth digit ratio, and that was measured manually. And also we have included the biochemical parameters and scrotal ultrasound. The scrotal ultrasound was done by linear array, and the testicular volume was measured by ellipsoid formula. The microlithiasis was defined as small, 1 to 3 millimeter bright echogenic spot, and it was graded in no lithiasis, less than 5, 5 to 10, and more than 10. The epididymis was measured at 2 levels, head and tail. All the parameters were included to develop the Praman model. And we have divided into 80-20 ratio in the training set and the testing validation set. This is the usual steps of construction of the Praman model by XGBoost. And we have also compared our Praman model to other existing 5 machine learning model. Now come to the results. So we have found that in Klinefelter syndrome patient, the 54% of the patient have absence of secondary sexual characteristics, and 46% of the patient was consulted for the primary infertility. Interestingly, we didn't have any cryptorchidism in hypo patient, but the Western literature shows around 20% of the patient with CHH have cryptorchidism. Till now, we have able to done whole exome sequencing around 27 patients with CHH, and our data shows the COL1 gene mutation was the most common, and it's corroborated with the KEM data. Now, if we go to the baseline characteristics, the hashtags parameter showed significant difference between the CHH and Klinefelter. All the patients were age matched. The arm span, height to arm span, LH and FSH obviously, and total testosterone are significantly different between the CHH and KS group. Regarding the second to fourth digit ratio, CHH has a higher second to fourth digit ratio compared to the control, and also in the Klinefelter syndrome patient. Now come to the ultrasonographic characteristics. Interestingly, we have found that in Klinefelter syndrome patient, majority of the patient, around 87% hypoechoic testes, both right and left. And also the microlithiasis was found in Klinefelter syndrome patient. However, in congenital hypo, we have found both hypoechogenicity around 75% of the patient and microlithiasis around 35% of the patient. So this is the ultrasonographic characteristics, and we have interestingly found the craniocaudal dimension of the epididymis is much larger in CHH or Klinefelter syndrome patient. So we have predicted the Praman model, and we have found the significant sensitivity and specificity to predict the CHH, and also it have found the significant sensitivity and specificity in predicting the Klinefelter syndrome. And we have found the 10 most important parameters which have significant weighted coefficient. This is the sub-analysis. And we have also compared our Praman model to other model and shown that the Praman-C has significant sensitivity and specificity both in predicting the Klinefelter and CHH group. But when we have removed the LHFSH, the sensitivity and specificity was reduced, but it was around 83 to 85%. So we have found 4 most important parameters: height to arm span more than 6.3 to predict CHH, epididymal head diameter more than 0.87 predict CHH, stretched penile length more than 9.1 centimeter predict Klinefelter syndrome, and second to 4 digit ratio more than 0.967 predict CHH. So this is our significance. The second to 4 digit ratio usually established in the first trimester, and it has a sex dimorphism. And also the importance of the epididymal findings. The epididymis is structurally important parameter, important organ for the sperm transport, and decreased androgen level is associated with abnormal epididymis and abnormal sperm. Summarizing, this is the first study. We have shown that second 4 to 4 digit ratio, and also this shows the sensitivity of 97% and specificity 95%. The strength is, it is the largest single center data set of CHH and KS in adult Indians, and the limitation, external validation is required. Semen analysis, we have incomplete, it is ongoing collection, and ongoing research on second to 4 digit ratio in a larger population is required. So this is my team. I acknowledge all my fellow participants here. Thank you.
So Arijit, what was the age group study?
More than 18 years.
So all of them were treatment naive?
This parameter that I have included all are treatment naive.
Okay, because you have mentioned SPL. So you said that when you remove the FSH and LH, the sensitivity is going to drop.
Drop by around 83%, ma'am.
Okay. So how does this model help us clinically? A simple FSH will tell you whether this is hypo or Klinefelters. What is this model going to add to our clinical knowledge?
Actually, this model, if we, this is a small sample size, if we collect more the data, and probably, definitely where the LH-FSH is much more, but in some situation, there may be discrepancy in the LH-FSH level, particularly to differentiate Klinefelter and Coleman patient. And there is assay variability maybe in case of biochemical assay variability of LH-FSH. So definitely biochemical parameter is important, and we often diagnose these LH-FSH to differentiate Klinefelter and Coleman. But probably in the near future we may use this model without any LH-FSH parameter, but it is important. Testosterone, yes. Several studies have found that, see, the 4 digit is depends on the, this length is usually much more compared to second digit, because the 4 digit is more manly. So in several studies, they have shown that in normal patient with seemingly normal testosterone level, if the 4-digit ratio is altered, they have low testosterone level, and some of the studies have found they are more having infertility in 2nd to 4-digit ratio.
So what I can understand from your study that particularly if Beatrice may think in that way also, particularly a patient, a newborn or in the pediatric age group, where a patient presented with say micropenis. So we are not, we are thinking about hypogonadism, but at that time there are no hormonal tests can assure you.
Exactly.
And there are no other features. In that case, if you think that the 2D/40 ratio is high, that means it is there is a little bit effeminate.
So this is
so that could be another important phenomenon. Above 18 years of age, if we go for this anthropometric measurement, how can it be helpful for our day-to-day clinical practice? That is a little bit questionable.
So in that case, sir, definitely before going to the LHFSH measurement or biochemical measurement, if we at least do the 2nd to 4-digit ratio, we can have some an idea that this patient may have hypo, this patient may have hyper, particularly Klinefelter syndrome.
Intrauterine period, if androgen level is low, then the ratio will be high, 2D/40 ratio. So in that way we can assume. Okay, thank you.
Thank you.
Okay, thank you so much. Thank you, respected judges. Moving to our next session, Responsible Research, Ethics at Core. I would like to invite Chairperson Dr. Ashish Kumar Basu sir to join the stage and invite our speaker. Thank you.
At the outset, let me express my sincere gratitude to the organizing committee ASHICON for giving me this opportunity to chair a very important session, which I feel should be very much talked about and should be also be included in the curriculum. So without wasting time, I would invite our speaker, Dr. Choitali Dottorai. She is Professor of Obstetrics and Gynecology, IPGMER. So she will take us through the topic assigned for her. Thank you. Over to Dr. Choitali Dottorai.
Thank you, sir, for a lovely introduction. Good afternoon, ladies and gentlemen. At the onset, I'd like to thank the organizers for inviting me here today. So, can any of you recognize what these are on the screen? Any idea, anyone? These are called HeLa cells, and they are named after this lady, Henrietta Lacks. Henrietta Lacks was an impoverished tobacco farmer in Virginia, USA, and she had discovered a lump in her abdomen in the 1950s. So Henrietta visited Johns Hopkins Hospital, and there the doctors took some tissue from her and they biopsied it, and they found that she has carcinoma cervix. She had. Now, unknown to her, some of those cells were also taken to a lab down the corridor, and those cells were cultured, and it was found that those cells kept on repeating and dividing, and they did not die, and that is when the first immortal cell line was found. So why is this immortal cell line important? It's important because these cells have been used for producing vaccines. In fact, the polio vaccine was made from them. They've been used for HIV research, cancer research, and as a result of all this, even in the cosmetics industry, people have minted millions over the years. Pharmaceuticals, industries have all minted millions. What about Henrietta herself? Henrietta died within the next 3 to 4 months. And she was so poor that there was initially no tombstone above her grave either. So now none of this would have come to public notice or even her family's notice, because they didn't know her cells were being used. It was only in the 70s when this HeLa cell line got contaminated by other cell lines. And that's when people started ringing up the descendants of Henrietta to take samples of their blood. And as a result, they wondered why their blood was being asked for. So then it came out that their grandmother's cells had been used for the last 20, 30 years, and people had minted millions, whereas their grandmother neither knew, had never consented to this being used. Now, the pharmaceutical companies, obviously, this gave rise to a lot of lawsuits. The pharmaceutical companies and other industries, they argued that at that time there was no need for consent to be taken when patients' tissues were being used after they had been taken out of their body. So this brings us to the moot thought for now. Whether scientific research will only be there for improving society, for minting money, or should we also consider the patients from whom we will be for whom will be used in that research. So this, and in fact, Henrietta ultimately, her family got a financial compensation, and one of her descendants was included in the groups who decide what will be done with the HeLa cells. So I will be talking about good clinical practice, especially with respect to the ethical aspect, and we will be walking through the principles of good clinical practice. We will be talking about ethical issues related to health research, as well as the key regulations which are guiding this research. So what is good clinical practice? It's an internationally agreed standard that ensures ethical and scientific quality in designing, recording, and reporting of trials that involve humans. And so it stands on 3 pillars. What are the 3 pillars it stands on? Ethical conduct, participant safety, as well as scientific integrity. I think the scientific rigor part was to be dealt by my next speaker, while I will be talking more about the ethical part. So when you think of ethics regarding human subjects, in research in human subjects, you think of bioethics, which is a study of ethical, social, and legal issues that arise in biomedical and biomedicine research. Let me take you back to the 1930s to Europe. I think many of you will be recognizing this little mustachioed man. This man had a dream. He wanted to conquer the world. And he had another dream. He felt that his race was the superior most. So what did he do? He made these camps. And what did he do there? He packed people he considered inferior, to him the Jews were inferior, into those camps like a tin of sardines. So they were called concentration camps. And what he did was, now the old and the frail were gassed and murdered in those camps. Some were used to do hard labor, and some were used for human experimentation. Why the experimentation? They wanted 3 things. They wanted to know what would happen to their soldiers who were fighting for them, for their pilots in their aircrafts, for their for their navy, if something happened to them during war. Secondly, they wanted to test drugs, procedures on these prisoners. And thirdly, they wanted to find out a way to increase their genetic superiority. So what they would do was, they would take prisoners, submerge them in ice cold water to see the effects of hypothermia, how long it took them to die. They would take them to high altitudes and just release them to see at which altitude say a pilot could later come down and parachute to safety. And then they would inject diseases into the blood of those prisoners just to see how long they lasted, whether they could make any effective medicines for them. And the most notorious of all, there was Dr. Engle, who was called the Angel of Death. He did studies on twins. Why twins? Because apparently the genetic structure would be very similar. And he would again inject disease into one twin. When that twin died, he would kill off the other and take the organs for comparative analysis. He would even amputate parts of one and stick them to the other. And in one incident, he had sewn up two twins back to back to see if he could produce conjoined twins. So anyway, when the World War II ended, before this, no one knew this was going on. After the World War II came to an end, all these stories started coming out. And these doctors, these notorious doctors, were taken to a military tribunal held in a place called Nuremberg. And what did their lawyers argue? Their lawyers argued that there was no law existing at that time which would differentiate between what is a legal experiment and what is an illegal one. And that led the judges to formulate a set of guidelines. And this came to be called the Nuremberg Code. And what is the very first tenet that this code mentions? There should be voluntary, well-informed and understanding consent of the participant. It should aim at positive results for society. It should be based on previous knowledge. That's why we do pilot studies with a small sample size. It should be set up to avoid unnecessary physical and mental suffering. And it should not be conducted if there is a risk of death. If there is a risk, that should be proportionate to the benefits. It should have preparations ready to protect its subjects against these risks. The staff should be fully trained, and the subjects should be free to quit immediately if they wanted to. It's not that you're a prisoner, you have to be part of it. And the people who are conducting the trial should also stop if they see there are significant risks. So this brought forward the first pillar of bioethics, which is the principle of autonomy. What is autonomy? I have the right over what is to be done to my body. No one else can dictate that. That is autonomy. Now, well and good. At the same time, the World Medical Association also formulated the International Code of Medical Ethics and the Declaration of Geneva. It was held in Geneva just a year after Nuremberg. And here they sort of gave a modern take to the Hippocratic Oath. So they mentioned what are the duties of physicians in general to their patients and to their colleagues. So well and good, everyone thought that yes, these guidelines are in place, so everyone's going to do research in an ethical manner. But where there is law, there are loopholes also. So, and then this study, the Willowbrook hepatitis study, came to everyone's notice. This was being held in the mid-1950s. What was Willowbrook? Willowbrook was an institution in, I think it was New York, which was for the specially abled children, the differently abled children. And the authorities there discovered that hepatitis A outbreaks were happening. They wanted to study them. So they would recruit the children of that institute. Now what they did to get more subjects was intentionally feed those differently able children with food contaminated with the feces of the already hepatitis infected children. And this led to more participants for their experiments. Now ultimately, as happens, we always say bad things about journalists because they are always at our back. But it was a journalist who broke the story. And that's when this stopped. The Willowbrook study ended. But this led people all over, right-thinking people, to decide to frame a set of ethical principles which will guide any sort of medical research. And so in Helsinki, everyone came together, and in 1964, the Declaration of Helsinki, the first one, was formed. And this tied the tenets of the Nuremberg Code with the Declaration of Geneva. And from now on, it was not called human experimentation. It was called clinical research. And no study could be done without consent. Even if the person was unable to give consent, a proxy consent had to be taken from a legal guardian. This came to the second tenet, the second pillar on which bioethics stands, which is non-maleficence. Do no harm. In the interests of scientific research, do not do harm. Then another story. This started way back in the 1930s in a place called Tuskegee. Again, this is in the southern states of America. And here too, who were recruited? African Americans. So you can see that people, I know Abhijit would be asking, wanting me to say this, people who don't have the ability to talk back, the vulnerable population. Repeatedly, these vulnerable people are being included in these studies. So the Tuskegee syphilis study recruited African American men with syphilis from the 1930s. And the US Department of Public Health wanted to see the effects of syphilis, the long-term effects. So well and good, these farmers, poor farmers, they were over the moon. The government's paying us some attention at least. Their blood was being taken, their small ailments were being taken care of. So they thought, yes, something good is being done. Well, maybe it was. Anyway, somebody in the audience, please tell me, what is the drug of choice for syphilis? Anyone? Penicillin. Thank you, madam. So when did penicillin start coming into use? During the Second World War. So from the 1940s, early 1940s, penicillin was there, available for human use. So you'd think these poor fellows would get that penicillin, did they? No. This study continued for 40 long years. Many of the participants died because of these long-term effects of syphilis. They infected their wives. Some of their unborn children were infected and were born with congenital syphilis. It was only again after a whistleblower leaked the news that the Public Health Department stopped it. Similarly, in the 1960s, again, this was a study conducted by the US Department of Defense. Pentagon started the study. There were I shouldn't say black, African American cancer patients. Again, vulnerable population, African Americans, and those with cancer were given whole body irradiation. Now, what is whole body irradiation? Has it ever been a treatment for any sort of cancer? In fact, the equivalent of 20,000 X-rays were given to those recruits within a span of a couple of hours. And within 6 months, maybe 3/4 had died. They thought they were being looked after, but what was the reason for this study? This study was done because the US Defense wanted to know if a soldier faced a nuclear bomb, then how much would he be affected? This was the sole reason for doing this study. So all these together brought about what came to be known as a Belmont report, which led to, in the US, what is called the common rule, that there should be institutional regulatory bodies which will regulate research. In India, what are they called? They are our ethical committees. So from this time on, you could not just decide to do a study and do it. You had to get the permission of your ethical committee. They had to say, yes, the interests of the participants are also being taken into consideration. And this brought about the third pillar of bioethics, which is the principle of beneficence. So if you're doing a study, do not make it an act of omission, not giving penicillin, or commission, giving too much of a treatment. Just do enough which will be helpful for the patient. Now this Helsinki Declaration underwent a couple of revisions, and these, the initial ones, brought about again this oversight by an independent committee. Publication ethics were included. The second one included consent, or we should call it assent, by minors. And then we come to the 1984, an event which rocked the world again. Rock Hudson, handsome matinee Hollywood idol, heartthrob of many all over the world, suddenly diagnosed with HIV, AIDS. And at that time, the world panicked again. This seemed to be a disease which had no cure, nothing to help those who suffered from it. So lots of trials went on. And in fact, it was also seen that this disease was transmitted perinatally. So there were trials on with drugs which might prevent this perinatal transmission, Zirovidine. And it was seen that yes, it is effective. So well and good. Now, it was known that placebo-controlled trials offered a better and valid assessment of antiretroviral therapy. So, okay, what did Big Brother the US do? It started this trial, and all the patients in the US got the Zirovidine, and all the patients in sub-Saharan Africa got the placebo. So, as a result of this, more than 70% of the children born to those women were born with HIV. They were already infected in utero, which could have been prevented if they had gotten this drug, which was already known to be effective to control perinatal transmission. So this led to the 4th and 5th revisions, where it came that the ethical standards applied should be no less exacting than they would be in the case of research carried out in the initiating country, and ethical problems of experimenting on those who would not benefit from that sort of research were also there. This led to the 4th pillar of bioethics, which is the principle of justice. Whatever research you do, it should be just for whoever you are including it, not good for one and bad for the other. Now, Big Brother US did not want to follow these last revisions. Now, in the meantime, good clinical practice rules had also been formulated by the WHO, by the FDA, and they were there to also look after scientific rigor in your research. So, ultimately, these were all conglomerated into the International Conference on Harmonization, but Big Brother US decided to follow its own rules in certain areas. Now, Helsinki underwent a few more revisions, and here treatment and compensation for injuries related to research were touched upon. And every time a revision came, it was reiterated that subjects' welfare must always take precedence over the interests of science and society. In 2024, the last revision has come, and here an important part is that they have also included that these principles should be upheld not only by the individuals or teams, but also by the organizations who are involved in that research. So if we want to see the difference of the revisions of the last one from the previous, one is involvement of all the organizations, everyone involved. Next, there is a new term, it's called research participant now. This makes it a more dignified terminology. Then there's more protection for those vulnerable populations. The concept of electronic consent has now been introduced, and there is guidelines for future use of data or samples of any person who has been part of that research. No more HeLa cell controversies. Scientific integrity statements are there, and there's also an emphasis on social values where environmental safety has been touched upon. So as you can see, these bioethics and good clinical practice go hand in hand. One maybe deals more with the scientific rigor, while the other deals with the morals of the thing. Is this right in your mind or not? Now, before I end, I just want to tell you one more little story. This lady in the middle is Anarcha. She was an African-American slave girl in the mid-1800s. And Anarcha, as African slave women of those days, worked in a plantation. They had to undergo very hard labor. And as was usually routine at that time, they usually delivered their first child by the age of 14. And at that time, their pelvises were rather narrow, undeveloped. And so what was the outcome? A vesicovaginal fistula, rectovaginal fistula. So Anarcha and a few more of her friends all developed RVFs and VVFs, and as a result, they had to be kept separately. not with the other slaves. So the slave owners, the masters, decided these people are not useful for work anymore. So what they wanted to do was cure them. So they leased them off to this fellow who had been doing, he just recently shifted to Alabama, and he had been doing experimental surgery for many gynecological conditions. And this fellow decided to try out his methods. So he would bring these women onto his operating table. They were naked. They were tied down to the table. Since he was doing new surgeries, other people were there to all watch. And they were tied down because they were not given any anesthesia. White women at that time were given anesthesia for a surgery, but these poor slaves weren't. Why? When asked, this fellow said, they're Negroes. They don't feel pain. And Anarcha was operated on 30 times in this way before this condition was repaired or cured. And her friends, Betsy, Lucy, all these, there were 12 women in all on whom these experiments had taken place. They were all slaves now leased out to this fellow. And so they had no control over no power to say no. They had no control over their own bodies. And this fellow, I think many of you can recognize him, because you have been using this speculum maybe in your MBBS. You had to use it at least to give your exams, I suppose. This was J. Marion Sims. He is known as a father of gynecology because obviously the instruments he made, the positions he invented, the operations he perfected, definitely have revolutionized gynecological surgery. But now this memorial is there. It's called the Mothers of Gynecology. This is made in respect to Anarcha and her friends. And the thing here is, what we must think about is, okay, agreed, during Sims' time, it was not necessary to take consent. It was not legal to take consent before you do a surgery. But yes, it was necessary to give anesthesia. It was necessary to give privacy. You could not just tie up a lady down naked and have 30 men watching while you operated on her vagina. So it's that decision we have to come to, a tightrope which has to be very cautiously negotiated, that I might develop a lot of things with my research. I might improve the world a lot, but I also have to remember what is right and what is not. So this, I think, I usually tell people, this is something which really epitomizes what I think all of us should feel. Our prime purpose in this life is to help others. If you can't help them, at least don't hurt them. Thank you.
Thank you, Dr. Choitali Dottorai, for excellent eye-opener presentation and giving us a lot of historical inputs. And through her presentation, we have been appraised of how research should be amalgamated with proper ethics. And in the history, lot of tortures, lot of undue endeavor were taken. But now we'll have to be very alert, cautious. So we have been largely enriched by her presentation. So we can invite a couple of questions, because already there is paucity of audience. So may I invite Professor Abhijit Hajra? Have you got any question, or can you provide any input? Because I know Professor Hajra for a pretty long time. He has been also a pioneer in the ethical part regarding any research. So I will ask Hajra to give us input.
May I just add one thing here, sir?
Yeah, yeah.
Yes, I just want to tell you all one incident. Obviously, just 1 minute. I attended a conference of infertility, fetal medicine specialists. And one of them, they work in private setups because we don't have much of fetal medicine work in the government institutes. And they were presenting a paper on fetal reduction and they had done it on retrospective data. So I was made one of the judges in that conference for that paper. And so I just asked him, because it was a very controversial topic he was presenting, which ethics committee had given you permission for this? And he said, oh, but it's retrospective data. I don't need ethical permission. So as you can see, even very, very learned people all over still have this misimpression that ethical permission is not required. If you're taking retrospective data from dead people, you don't need the consent. But you will always, always, always need ethical permission. That is something which people still don't realize. Yes, Obijit, please.
Dr. Haji. Thank you, Professor Rai, for giving us a very broad and very interesting overview, drawing from historical incidents, highlighting the 4 fundamental tenets of bioethics: autonomy, non-maleficence, beneficence, and justice. I'd just like to add that in the context of further, may I say, trial and errors that the whole research community in the world has learned, we have added 2 more ethical principles. One is that of confidentiality, and the other is that of integrity. Now, these should have been obvious, but now they have to be stated as specifically separate principles, because things are not always above board in the entire research community. Now, the situation in India is that theoretically we are more or less familiar with these topics everywhere. Our individual researchers, our research scholars, our organizations that support research, all of us are aware of this thing. But now the time is very much come to get this percolated to down to our students.
Exactly.
Who are in the early stages of the careers. These are not only philosophical things. These are something which is day to day in research. So that job remains to be done.
Exactly.
And all of us here, all the faculty, all the guides must take part in this important job.
Very correctly said.
I think Professor Hajra and Professor Choitali Datta Rai will agree with me that these sort of ethics research should be incorporated in the curriculum of the undergraduate as well as the postgraduate students. I think
it is already there.
It's already there.
It's already there in the curriculum. Now we have to take it in the heart.
Yeah.
It is now mechanical. Okay, you have to make a participant information sheet. You have to get an informed consent form fill up. Now this has to touch our hearts. That job is remaining.
It should be in the study. Is it in the study subject?
Yes, sir. Mandatorily.
Yes, sir.
Mandatorily,
it's
these
mandatory now.
are there.
It's mandatory. So that's a good news. So I think Professor Rai has given us very valuable input. So let us give a big round of applause.
Thank you.
And with this, I declare this session closed because another speaker will not be coming. Okay.
For this, I would like to invite on stage Dr. Professor Sanjay Bhadada sir, and also Dr. Mandip Singla sir. Bhadada sir needs no introduction. He is our all favorite teacher, our author of our best textbook, Williams Textbook on Endocrinology, the father figure of so-called osteocrinology, and also to introduce Dr. Mandip Singla sir. He is assistant professor of GMC Chandigarh with multiple publications in index journals. And sir.
Thank you. Very good afternoon. I think it is always tough to attend a session after lunch, which is delicious lunch in the Bengal. So I welcome you all for this today's session, and I believe this session is very, very important because this is related to our journal, and for any society, how big is the society, that is decided by always by the journal, how many journals they are bringing, what is the quality of journal and all. So today this session is related to IgM case report, and IgM case report is going very well, and those are in this hall. I am telling here also, and then after that, at the end of session, that IgM case report is going to be indexed very soon, and it is right now, there is no charges are available. So please use this facility and send as many as possible articles. And Dr. Mandip, my co-chair, is doing great job. So he is the executive editor for that. And we are trying to review the articles as early as possible. And we are happy to share that we have 2 edition advance material is available with us. So there is no problem, but I'll request those are in this hall, please submit as many as cases possible. Mandip, you want to say something?
So good afternoon all. So based on the publications for the last 1 year, so we have selected 3 case reports. So that will be discussed, and then we will choose 1 out of those 3. So this is just a encouragement for all those. I think all of them have done wonders. So the first case report will be discussed by Dr. Rahim Mahata. He is from Midnapur Medical College, and he will be discussing about a case of isolated Leydig cell dysfunction in adrenoleukodystrophy. So the case presentation timing is 15 minutes, and then afterwards we will have 5 minutes for discussion.
Thank you, moderators, for your kind introduction. Respected chairperson, respected audience, good afternoon to all. First of all, thanks to the ASICON 2025 Scientific Committee and Editorial Board of IgM for considering our case to present at this platform. Now I am going to the case, directly to the case. A 19-year-old male, married for 1 year, construction labor by occupation, admitted with complaint of frequent syncopal attack for last 4 years, and gradually progressive generalized skin hyperpigmentation that was noticed by her mother since his age of 7 years of age. He also complained of lethargy, generalized weakness, fatigability for the same duration, around 4 to 5 years. His neonatal period was uneventful. There is no history of crisis. There was no suggestion of alacrimia, dysphagia, and precocious puberty. He also complained of ill-sustained erection, lack of nocturnal penile tumescence, and decreased libido for last 1 year that led to marital separation. And for that reason, he came to our facility. Before that, even after repeated episode of frequent falls, frequent syncopal attack, he at that time took medical attention at the nearest local doctor, but he was not thoroughly worked up or evaluated. He attained developmental milestone as per age. Regarding secondary sexual characters, of development of secondary sexual characters that were normal, but for last 1 year there is gradually regression of the secondary sexual characters. His bile bladder habits were normal, family history that was unremarkable. There is no existing comorbidity, or there is no history of any addiction. Regarding physical examination, his height that is corroborating with the mid-parenteral height, BMI towards the lower side, At the time of admission, the patient was hypotensive with presence of postural drop, and there was extensive mucocutaneous pigmentation involving the generalized skin, especially over the knuckles, oral mucosa, and palmar and sole crease over the sole, as well as that is depicted by the images. Regarding secondary sexual characters, there is absence of beard and sparse axillary hair, pubic hair of P3, bilateral testicular volume around 25 ml, stretch penile length that was 11 centimeter, and there was no gynecomastia. Regarding systemic examination, especially the nervous system examination, regarding higher mental function was normal, speech get normal, there is no muscle wasting. Regarding tonicity, in the lower limb there is spasticity of bilateral lower limb, but upper limb tone was normal. In all 4 limbs, muscle power was normal. Bilateral plantar was extensor. In view of extensor plantar and upper lower limb tone spasticity, but the deep tendon reflex in the lower limb was absent. Regarding cranial nerve and sensory abnormality, there is no suggestion of sensory loss and cranial nerve abnormality. Other systemic examination was unremarkable. So keeping in mind of suggestion of primary adrenal insufficiency, including the glucocorticoid as well as the mineralocorticoid deficiency, as well as features of hypogonadism, we put the differentials regarding adrenal hypoplasia congenita, autoimmune polyglandular syndrome other than type 1, as well as keeping in mind of neurological abnormality, another differential that is the adrenoleukodystrophy. So regarding laboratory workup, there is eosinophilia, that is out of total leukocyte count, that is absolute eosinophil count that is more than 500 and proportion that is more than 10%, low normal serum sodium and hyperkalemia. Regarding hormonal workup, there is subclinical primary hypothyroidism with negative anti-TPO and serum cortisol basal 8 am, that is that is 2 microgram per dl with sky high ACTH. Plasma renin activity, that is the upper level of normal. Total testosterone, that is fasting 8 am, total testosterone around 153 nanogram per dl with elevated LH but normal FSH. Keeping in mind of neurological abnormality with plantar extension and bilateral lower limb spasticity, we do an MRI brain as well as MRI of spine. In MRI brain, that is T1 showing bilateral hypointense signal over the parieto-occipital region, that is bilaterally symmetrically, and T2 and T2 flare, that is hyperintense signal over the parieto-occipital, frontal and periventricular white matter without any involvement at the cortical level. On MRI spine, there is no signal changes. Regarding the absent bilateral lower limb jerk, we do an NCV study of all 4 limbs that suggested demyelinating type of motor polyneuropathy in both lower limbs. To look for the adrenals, we do CCT abdomen. In both coronal as well as axial cut, the adrenal glands are not clearly visible. So regarding final diagnosis, there is suggestion of primary adrenal insufficiency involving the glucocorticoid axis as well as the mineralocorticoid axis, primary hypogonadism solely involving the Leydig cell compartment, and suggestion of peripheral neuropathy as well as myelopathy, and on brain MRI there is suggestion of cerebral adrenoleukodystrophy. So we came to the final diagnosis of adrenoleukodystrophy, especially AMN phenotype that leading to that involving also the adrenoleukodystrophy within the brain also. We confirm our diagnosis by doing genetic study with the whole exome sequencing that revealed a hemizygous missense pathologic variant of ABCD1 gene. On treatment, we initially treated with intravenous IV fluid with normal saline and IV hydrocortisone with 100 mg IV TDS, and subsequently patient was put on oral hydrocortisone twicely, 10 mg at 8 am and 5 mg at 4 pm, along with oral fludrocortisone 100 microgram once daily and injection testosterone ester 200 milligram deep intramuscular every 2 weekly. And patient was counseled regarding the restriction of very large chain of long chain fatty acid restriction. Along with, she was advised to consult with regarding the allogenic stem cell transplantation, as there was involvement in the cerebral adrenoleukodystrophy. Follow up after 3 months, there is clearly improvement of the sense of well-being as well as clinical and biochemical parameter, from hypotensive to normotensive, as well as absence of postural drop, and from hyperkalemia to normokalemia, and he did not feel dizziness, no syncopal attack in last 3 months. There is showing clear improvement of the hyperpigmentation at 3 months after admission. So regarding adrenoleukodystrophy, this is an X-linked recessive paroxysmal metabolic disorder due to ABCD1 gene mutation that encodes the adrenoleukodystrophy protein, that is the paroxysmal membrane protein that transport the very long chain fatty acid across the paroxysmal membrane. Due to mutation in the ABCD1 gene, the very long chain fatty acid that accumulates within the cytoplasm, and it that is not degraded and accumulated and leads to oxidative stress and ultimately cellular damage. This is the proportion of the adrenoleukodystrophy phenotype, that is the childhood onset cerebral phenotype, that is the that occurs within the 10 years of age, adolescent that occurs 10 to 20 years of age, and adult cerebral type that occurs after the 20 years. And AMN phenotype, adenomyeloneuropathy, where there is no brain lesions, and the rare proportion that is the isolated adrenal insufficiency. Regarding adrenal gland involvement in case of X-linked adrenoleukodystrophy, there is apoptosis and atrophy of the adrenocortical cell, as well as there is impaired steroidogenesis, as the very long chain fatty acid that is esterified with the cholesterol, so there is lack of substrate for the steroidogenesis. It was also postulated that incorporation of the very long chain fatty acid within the paroxysmal membrane that leads to ACTH resistance, and in adrenal gland the toxicity mainly involving the zona fasciculata and reticularis with sparing the zona glomerulosa. But it has been seen that mineralocorticoid deficiency also occur in case of 40 to 50% cases. Regarding nervous system involvement, in myeloneuropathy, that is non-inflammatory type axonopathy, as well as in spinal cord, there is also non-inflammatory type of corticospinal tract degeneration. But in case of brain lesion, that is the demyelinating type of inflammatory involvement without any cortical matter involvement. And regarding adrenoleukodystrophy, in case of cerebral component, there is, if the cerebral adrenoleukodystrophy occurs earlier, then chance of adrenomyeloneuropathy is extremely rare. But if there is AMN occur first, then the chance of cerebral involvement around 20%. Regarding gonadal dysfunction, like the adrenocortical cell dysfunction, there is also leads to toxicity in the Leydig cells, leads to Leydig cell hypertrophy, ballooning, and at long run there is Leydig cell loss. Like the ACTH resistance, here is also gonadotropin resistance, and some literature it also has been mentioned that in presence of normal testosterone with elevated gonadotropin, there is features of suggestion of hypogonadism. So they postulated that there is also androgen resistance at the level of testosterone receptor as well as post receptor level, and also there is expression of the 5-alpha reductase type 2 expression within the tissue. Regarding other compartment of the gonads, other than Leydig cells, it has been also mentioned that there is aberrancy in the seminiferous tubules. In pathological abnormality, they have shown that there is hypospermatogenesis, hypocellularity, to almost Sertoli cell only syndrome. But regarding fertility, in most adrenoleukodystrophy patients, those who have the hypogonadism, but there is fertility was there normal. So regarding uniqueness of our cases, even though started at the age of 7 years. He was finally diagnosed at the age of 19 years. Regarding mineralocorticoid deficiency, it has been specifically involved the fasciculata and reticularis, but 40 to 50% cases mineralocorticoid deficiency may occur. In our cases, there is only isolated Leydig cell dysfunction that is rarely reported previously in the literature, and mostly the neuropathy that occurs, that is the axonopathy, but here it was demyelinating type of motor polyneuropathy in both lower limbs. So to conclude, X-linked adrenoleukodystrophy is a frequent but under-recognized cause of primary adrenal insufficiency and primary hypogonadism. In presence of primary adrenal insufficiency, if there is associated neurological abnormality, we have to think for adrenoleukodystrophy. And in case of adrenoleukodystrophy, impotency may be due to spinal cord involvement due to myelopathy, or maybe peripheral nerve involvement that is due to neuropathy other than primary hypogonadism. Thank you.
Questions from the house? Okay. So very nice presentation. It's very interesting that because LH and FSH both are secreted from the same cell actually, but it is isolated, affected the secretion of the LH. Do you have any explanation for that?
Sir, specifically steroidogenesis part that is occurs within the Leydig cells, and stratification of the cholesterol along with the very long chain fatty acid that is accumulated within the Leydig cell, that preferentially possibly leading to Leydig cell toxicity much more.
As compared to the other. Yes, sir. What is the testicular volume?
Testicular volume was, sir, 25 ml.
Why the testicular volume was not reduced?
These
are some of the questions we have to enjoy the discussions. I am just generating these questions. So very nice presentation, very interesting.
Yes.
Of course, it is accepted, so it is nice one only, but still to have some question answers. So why the, you said the 25 cc is the volume in spite of the atrophy of the Leydig cell?
As the sir, most of the proportion of the testicular volume is contributed by the seminiferous tubule, only around 10 to 20% that is contributed by the Leydig cells. So probably even after loss of the Leydig cell, the testicular size was normal.
So I think through this long chain fatty acids will inhibit the intake of cholesterol into
yes,
the
sir, yes, sir.
Enzymatic machinery, and that is why it will be toxic. So I have two just questions. So this patient has primarily presented with primary adrenal insufficiency. The first presentation, what the symptoms were there?
Symptoms, sir, that was even before that, but his main concern at this time was the suggestion of hypogonadism. For that purpose, he came to our facility.
So if a child presents with the primary adrenal insufficiency, so should we, how can we suspect that this is likely due to adrenoleukodystrophy if adrenal insufficiency is a presenting complaint?
It has been seen that those who are present within the even earlier period, if there is suggestion of primary adrenal insufficiency, at that time, usually if even it present before the 10 years, at that time, adrenoleukodystrophy, some of the features will be there, most of the time.
So as we have shown that 10% of the patients may have only adrenal insufficiency.
But in that case, that occurs usually in the later age group, adult age group, sir. Only isolated adrenal insufficiency, most of the cases that occur in the adult age group. But those who present within the usually earlier age group have some neurological component as well.
So I went to the literature. As it is X-linked, if any male individual or child presents with the adrenal insufficiency, you have ruled out all other causes. So then you may screen with the long chain fatty acids for adrenoleukodystrophy. So we have done long chain fatty acid level in this patient?
No, sir. Due to financial issue, we don't do it. Directly we go to the genetic study.
The second thing is, can there be any other cause of infertility if a patient is having primary adrenal insufficiency with the high ACTH? So chronic ACTH stimulation, what pathology will it lead to in testes?
Probability of
it is more common in congenital adrenal hyperplasia.
Yes, sir. Yes, sir. TAT cell, rest cell tumor.
And then thirdly, what about the treatment of this condition? So adrenal insufficiency, yes, we can treat with.
Yes, sir. Primary hypogonadism part also can be treatable, but cerebral component, that is the progressive one, and rapidly patient may progress. So we try to counsel her regarding higher center to regarding the allogenic stem cell transplantation, sir.
So any questions, comments from the audience? So I think.
So what was the problems you are facing in the management of this particular patient? Though it is very rare, and I think we have few other earlier publications also on the adrenal leukodystrophy. Earlier also the publication on the adrenal leukodystrophy. So what was the problem you were facing while managing this patient? What is the prognosis? In other words, let me ask in form. What is the prognosis of this disease?
If there is cerebral involvement, so most of the time there is mortality will be very high.
So it is not a good disease to have actually.
Yes, sir.
Mortality is very high and is very crippling also after some time. Thank you very much. Please give a big hand for his nice presentation and sharing. Thank you.
Thank you, sir.
Good afternoon, respected faculty and dear colleagues. I am going to present the case titled When Skin Speaks, Unmasking Xanthoma disseminatum in a case of arginine vasopressin deficiency. To begin, it's a case of a 33-year-old male, resident of Aligarh. He is chemical engineer by profession and he was referred from Department of Medicine, and his main concern was increased frequency of urination. The symptoms began 6 months ago, and initially the frequency of urination was 5 to 6 times per day, and at present the frequency has increased to 2 to 3 times per hour. And also there is increased frequency of urination at night 3 to 4 times, which is compromising with his sleep. There is no history of burning during urination, no history of hematuria, and no history of diabetes mellitus. There is also history of excessive thirst. Initial it was 1 or 2 glasses of water 4 to 5 times a day, but this has again progressed over a period of 6 months, and now the frequency is 2 to 3 glasses at a time and 2 to 3 times per hour. There is no history of any intake of drugs such as anticholinergic or antipsychotic drugs which can cause dry mouth and increased thirst, and there is no history of compulsive drinking behavior in the past. There is no history of head injury, any neurosurgical intervention in the past, no history of chronic cough, shortness of breath for sarcoidosis, no history of drug intake, lithium and other nephrotoxic drugs such as amphotericin B, no history of muscle weakness, renal stones, just for hypokalemia and hypercalcemia, and there is no history of visual disturbances, loss of libido, history of constipation, just for history suggestive of hypopituitarism. The past history, treatment history and family history was not significant, and in personal history, his sleep is compromised, that is due to nocturia. In physical examination, height 178 centimeters, weight was 78 kilograms with a BMI of 24.7 kilogram per meter square, and his vitals were normal. There were no signs of dehydration. There was no pallor, icterus, clubbing, cyanosis, no lymphadenopathy, but there was multiple hyperpigmented nodulo-papular lesions in the perineum, axilla and oral cavity. So these are the lesions. We can see these lesions, they are symmetrical. They are papulonodular, and they are classical at the flexural sites such as axilla, groin, perineum, and the size ranged from 2 to 2 millimeters to 3 to 5 centimeters in diameter. And also we can see papules on the antecubital fossa. So the lesions were symmetrical and they were classical. They had flexural predilection. They were also seen in the mucosal sites, such as in the mouth. We can see there were edematous papules at the corners of mouth, and there were nodular lesions in the buccal mucosa as well. The systemic examination, cardiovascular, respiratory, abdominal, neurological examination, all were normal. There were no significant findings. Just to summarize, it's a case of a 33-year-old male who presented to us with with polyuria and polydipsia with characteristic skin lesions involving the flexural sites. And the vitals were normal. There were no signs of dehydration, and there was no history of diabetes, any medication use, or any history suggestive of urinary tract infection. So coming to differential diagnosis, we had two clues. The first was polyuria polydipsia syndrome, which can be due to diabetes insipidus, or it can be due to primary polydipsia. Secondary, there were skin lesions which were mucocutaneous, and they specifically involved flexural areas. So on the basis of these two findings, we had few differentials. The first, Langerhansel's histiocytosis. They classically present as papulonodular lesions. However, the peak age is usually 1 to 5 years of age. And the point which was going against were the lesions, they usually have ulceration. And they usually involve scalp and can present as seborrheic-like dermatitis. The second differential was non-LCH, this is non-Langerhansel's histiocytosis. Again, they present as papulonodular lesions with flexural predilection, but the point against was that they are very rare. Sarcoidosis, it can cause polyuria due to various mechanisms, and it can have skin lesions as well. The polyuria can be due to central diabetes insipidus or arginine vasopressin deficiency. It can be due to arginine vasopressin resistance, and it can be due to abnormal thirst mechanism as well. But the lesions, they are not flexural. Similarly, the fourth differential was systemic amyloidosis. It can present as polyuria and waxy papules and nodules, but the classical pathognomic sign for amyloidosis is, we can see pinch purpura, that is periorbital purpura, also known as raccoon eyes, due to fragility of blood vessels. Lastly, we had few other differentials such as cutaneous T-cell lymphoma, xanthomatosis. They can present similarly, but polyuria and polydipsia is absent. So coming to investigations, the important investigations, the serum sodium was 138 millimoles per liter, serum potassium and serum calcium to rule out hypokalemia and hypercalcemia. We ruled out, and also his blood glucose levels fasting and postprandial, as well as his HbA1c was normal, ruling out diabetes mellitus. The 24-hour urine volume was 6 liters per day, suggestive of polyuria, and his urine osmolarity was less than 300, suggestive of hypotonic polyuria. So a diagnosis of hypotonic polyuria was made, and since serum sodium was in the range of 135 to 145, we went with water deprivation test. We started the test at 9 a.m. in the morning. The baseline parameters, serum sodium was 138, urine osmolarity was 81 milliosmol per kg, and the test was terminated at 1 o'clock in the afternoon when the serum sodium rose to 147 millimoles per liter. At that time, the urine osmolarity was 179, which suggested that it's a case of diabetes insipidus. We gave 5 units of vasopressin, and the urine osmolarity rose by more than 50%, and also the urine volume, it decreased to 50 ml per hour. So a diagnosis of arginine vasopressin deficiency was made, which was formerly known as central diabetes insipidus. So coming to the anterior pituitary function, which needs to be evaluated once we have evidence of posterior pituitary dysfunction. So the total T4 TSH was normal. Prolactin was 12.4 nanogram per ml. Serum cortisol basal was 12.6 microgram per deciliter, and the patient had intact hypothalamic pituitary gonadal axis. All these tests were performed by CLIA on the Beckman-Coulter platform. So coming to lipid profile was absolutely normal, and skeletal survey was performed, which lytic lesions can be seen in patients with histiocytosis. So we went with skeletal survey, and there was no lytic lesions found anywhere. So this is the MRI pituitary of the patient, and we can see we have sagittal section T1, and we have T1 contrast. So in T1 non-contrast, we can see there is absence of posterior pituitary bright spot. Posterior pituitary bright spot is looked in T1 non-contrast image, and in the contrast image we can see the pituitary stalk thickening. It was 3.5 millimeters, and at the proximal site, a cutoff of 3 millimeters is used for pituitary stalk thickening. So it was 3 millimeters. So there was pituitary stalk thickening, and there was absence of posterior pituitary bright spot. We went with the histopathology of the skin lesions. The HE stain, it showed nodular proliferation of foamy histiocytes with giant cells. And the immunohistochemistry, which is very important when we are evaluating a case of histiocytosis, and we can see the stain was positive for CD68 and CD163. And it was negative for S100 and CD1A. So with differential, again, with giant cells and S100 negative, CD1A negative, and positive for CD68 and CD163, we had other differentials now, and sarcoidosis, amyloidosis, they were all ruled out. So now we were left with these, on the basis of immunohistochemistry, we were able to rule out Langerhans histiocytosis, and we were just left with non-Langerhans histiocytosis, which can have different etiology. So the first was juvenile xanthogranuloma, but the negatives, point against was that the lesions are usually solitary, and it involves children. Second was benign cephalic histiocytosis. It can present as papules over head and neck region, but mucosal involvement is not seen. The third was progressive nodal histiocytosis. The point against was there is no flexural predilection. The fourth was generalized eruptive histiocytosis. Again, the flexures are spared, and diabetes insipidus is very rare. Lastly was xanthoma disseminatum. The lesions, they were flexural, that was point in favor, and diabetes insipidus can present in 40% of cases. So that went in favor, and finally the diagnosis of xanthoma disseminatum was made on the basis of histopathology and the characteristic skin lesions. So for the management of polyuria and polydipsia, we gave oral desmopressin, and the symptoms resolved. For skin lesions, we started with cyclophosphamide and atorvastatin. The oral lesions, they resolved, and no new lesions developed, but the lesions in axilla and perineum remain unchanged. And arginine vasopressin deficiency persisted. So coming to discussion, the differential diagnosis of polyuria, it's solute versus water diuresis, which can be differentiated on the basis of urine osmolarity at baseline. Central diabetes insipidus, it has various causes, including granulomatous disorders. And coming to histiocytosis, there are a group of rare disorders in which there is proliferation of histiocytes, and it can be broadly classified into LCH and non-LCH on the basis of immunohistochemistry. LCH, they stain positively for S100 and CD1A, whereas non-LCH for CD68 and CD163. So xanthoma disseminatum, it's a rare form of non-Langerhans histiocytosis. It typically affects young adults with male predominance. However, the etiology remains unknown. There are three manifestations. It can cause cutaneous lesions, it can involve mucosa, and in systemic involvement, it can cause diabetes insipidus. So there are three forms: the self-limiting form, which is the least common variant. The second is persistent cutaneous form, and the last one is progressive systemic form, which was in our case. So diagnosis on the basis of histology, immunohistochemistry, and when they are different on the basis of symptoms, we can look for systemic evaluation. Treatment options, physical treatments, especially for patients who have lesions confined to skin. in which we can use surgical removal, laser therapy. Then there is lipid lowering therapies in which combination of treatment has been used, rosiglitazone, simvastatin, niacin derivatives, either as alone or as combination. Immunosuppressive therapies, systemic glucocorticoids, azathioprine, anakinra, and interferon gamma, and cytostatic-based therapies such as cladribine, imatinib, and cyclophosphamide. In our patient, we use cyclophosphamide plus atorvastatin. So few case reports, there are only few case reports and case series, so the clear-cut management, it's still it's ambiguous, and our treatment depends upon those individual case reports and case series. So this is a case report in which xanthoma disseminatum was treated with cyclophosphamide. Patient had mucocutaneous, ocular, laryngeal, and CNS involvement, and the dose used was 50 to 100 milligram, and there was improvement in clinical outcomes. Second case report, another patient who had xanthoma disseminatum, but in this case, cyclophosphamide failed to show a clinical response. And in this patient, rosiglitazone, simvastatin, fenofibrate was used in combination. And the proposed mechanism is that these lipid-lowering therapies, they prevent the entry of lipids into the histiocytes, thereby decreasing the inflammation and reducing the foam cell formation. And lastly, a recent literature review, it has shown that the most evidence-based treatment is cladribine. However, we did not use this in our patient because of we were not comfortable. We have not used this before, but it has been the most efficacious treatment which has been seen across few case series. And in this, the protocol is 0.14 milligram per kg per day, which is administered over a period of 5 days and each month for 5 to 9 cycles, depending upon disease severity and patient response. So conclusion, just to summarize, arginine vasopressin deficiency can be due to various systemic conditions, and dermatological findings can be a crucial, you can say, indicator for underlying systemic disease. And xanthoma disseminatum, it's a rare non-LCH characterized by symmetric skin lesions with flagellal predilection. Thank you.
Bone lesions, how did you screen for the bone lesions?
So we went with the skeletal survey. We went for the skull X-ray. We went for the X-rays of the long bones, and we went for the X-rays of the vertebrae.
Okay, so there's no lesion was there. And is in imaging there was anything else in the ultrasonography, this hydroureter or bladder megaly, anything else was there?
There was no visceromegaly as such, sir. The lungs, the liver, in the USG, and as well as in the X-rays, we didn't find any lesions as such, which is characteristic for Langerhans histiocytosis. But visceral involvement is quite rare in xanthoma disseminatums.
No, I am looking for any hydroureter or anything was there, because this patient has a very high urine output for a long period of time.
So we didn't find it, sir. For dilation of pelvic pelvis system, we didn't,
It was not there.
Not there, yes.
Okay. So, what was the treatment plan?
So treatment, after discussion, there were many dermatologists were also involved in this case, and after discussing with them, we came up with a treatment regimen of using cyclophosphamide plus statins. Statins were used for two purposes. They have been shown to decrease the size of lesions, and also statins can ameliorate the toxicity of cyclophosphamide. So that was the two reasons why we went with statins as well along with cyclophosphamide.
Audience?
So I think very well presented, comprehensive presentation. Cutaneous examination is very, very important in any patient of diabetes insipidus. So in sarcoidosis, we can have erythema nodosum. Sometimes the patient may not come up, and we have to look for these lesions in the shin area. So my only question is that lipids are normal in these patients, and they are having foamy macrophages having lipids, and statin have shown to be beneficial.
All the lipid lowering therapies, so statins, fenofibrates, even they have used rosiglitazone, which was used earlier in diabetes, but they have tried in these patients.
So what is the primary pathophysiology? Like we are using cyclophosphamide cytotoxic drugs. So what is the pathophysiology of this disease?
It's basically the proliferation of the histiocytes. Histiocytes can be seen anywhere in the body. They are basically derived from macrophages and dendritic cells. So they have shown some mutations as well, but not in xanthoma disseminatum, but other histiocytes such as BRAF mutation has been seen. So they say that there is clonal proliferation of histiocytes. So one theory is that it's just you can say proliferative disorder, but another theory is that it can be a neoplastic disorder as well. So neoplastic agents, they have been shown to be to have some form of efficacy in management of xanthoma disseminatum as well.
Okay, so basically it is a proliferative disease.
Yeah.
And what about the prognosis of these patients?
Prognosis, see the arginine, the diabetes insipidus, it persists. So patient would be on long-term desmopressin. In terms of skin lesions, if it doesn't involve the, for example, larynx, it can cause stridor. It can involve the, you can say eyes. It can cause blindness. So apart from that, the prognosis is good, sir. Unless it involves the, you can say, sites which can compromise with the important functioning.
Did you do bone marrow aspiration?
No, sir. Bone marrow aspiration was not done.
Yeah, might be helpful to understand that from where the cells are coming.
Yes, sir.
Did you do the genetic study?
No, genetic study was not done, sir.
I think you can do that also, because ultimately you have to understand what is the actual mechanism.
Right, sir. Yes.
So it was very nice case, very nice presentation, but overall we have to understand that from where it is coming, and that might give you some information. Any questions from the house? Okay, if there is no more question, thank you. Very nice presentation.
Thank you,
really
sir.
enjoyed. You can call next one.
So we will move to the third presentation, and the presenter is Dr. Harini from AJ Institute of Medical Sciences, Bangalore, and she will be discussing an interesting case of vanishing hypothyroidism.
Good afternoon, sir. I'm going to be presenting today on the curious case of vanishing hypothyroidism. Proceeding to the case presentation. So this was a 36-year-old lady, married, resident of Udupi, who presented with the complaints of localized swelling, gradually progressive in the right proximal thigh since the last 5 years. She's noticed an increase in the swelling since the last 6 months, and it is associated with pain since the last 6 months, which was mild, intermittent, dull aching, non-radiating. The swelling was not associated with trauma or any symptoms such as fever, chills, constitutional symptoms, discharge, skin discoloration, ulceration, bleeding, any prior abscess, prior surgery or procedure. So she was diagnosed with hypothyroidism 6 years prior. At present, she is on levothyroxine 100 microgram daily. She is compliant and regular to the same with no symptoms pertaining to the above at present. Her family history is not significant for any thyroid disorders or vascular malformations. There are no associated comorbidities such as diabetes, hypertension, cardiovascular disease or malignancy, and her personal history is within normal limits. On examination, general examination, vitals and systemic examination were within normal limits. There was no goiter. The local examination of the swelling was a well-defined swelling measuring 12 into 8 centimeters on the medial aspect of the right proximal thigh with no venous prominence, no ulceration, non-pulsatile in nature, firm in consistency and non-tender. So an ultrasound local of the soft tissue lesion was obtained from outside. This was a mixed echoic soft tissue lesion measuring 8.9 into 7.6 centimeters located in the right proximal thigh. The lesion is limited to the subcutaneous plane associated with thickening of the local fat planes, superficial to the muscular plane. There are extensive dilated vascular channels and all vessels showed low velocity venous type of flow. It was reported as a case of cavernous hemangioma. Investigations done at our center prior to surgery. TSH was 2.12, T4 was 6.14, anti-TPO antibodies were negative, hemoglobin was slightly on the lower side. The other investigations were well within normal limits, including a USG abdomen. The patient was on levothyroxine supplementation, 100 microgram, empty stomach in the morning at the time of the investigation. Subsequently, she underwent an excision biopsy under general anesthesia. The gross specimen measures 15 into 8 into 5 centimeters with an elliptical skin flap that's measuring 13 into 4 centimeters. There was a hyperpigmented nodule noted in the center of the skin surface. The cut surface was suggestive of multiple dilated vessels corresponding to the nodule. On histopathology, the section showed skin with subcutaneous tissue having thick-walled muscular arteries as well as veins and clusters of capillary-sized blood vessels. There were thrombi seen in some of the blood vessels. These features were consistent with the arteriovenous malformation. We noticed that the thyroid profile post-surgery over a period of 11 months, the thyroxine dosage titration was such that she had required diminished thyroxine from about 100 mcg till about 11 months post-operative, where she was on 25 mcg of thyroxine, and subsequently the medications were stopped on the basis of clinical grounds and her euthyroid status. She is off medication since then and following up with us. This is a graphical representation of the same, where we can see a thyroxine dosage titration with the corresponding TSH and T4 levels post-excision of the lesion. Post 11 months, she's been off medications and euthyroid. The patient at present is clinically and biochemically euthyroid. So type 3 deiodinase is a physiological inactivator of thyroid hormones. In the endosome, it catalyzes the inner ring deiodination and converts T4 into RT3 and T3 into T2. So this is a selenoenzyme which is encoded by DIO3 gene located in chromosome number 14q32 and has a catalytic domain that's facing the extracellular space for capturing of T4 and T3. The amplification occurs to this endosomal clathrin-coated vesicle action where it takes in the T4 and T3 and causes degradation in the endosomal region. It has a half-life of about 12 hours. D3 is expressed in uterus, placenta, skin, embryonic tissue, and brain, predominantly in the placenta, as a protective mechanism to protect the fetus from the maternal influence of thyroid hormones. In the placenta, it's present in syncytial trophoblast, cytotrophoblast, maternal decidua, the fetal endothelial vessels. In the embryonic tissue, it's located in the cerebral cortex, CVS apparatus, urinary tract, liver, gut, skin, and gonads. So D3 is upregulated by retinoic acid, growth factors such as VEGF, EGF, FGF, estrogen, progesterone, hypoxia, by WNT beta-catenin pathway, by the sonic hedgehog pathway, the MAP ERK signaling pathway. It is diminished with glucocorticoids and growth hormones. Certain conditions where reactivation of D3 occurs are malignancy, infarct, cardiac hypertrophy, liver regeneration, and inflammation. Tumors with overexpression of D3 are oligodendromas, GBMs, basal cell carcinomas, and hemangiomas. To explain further, so this is a proliferating mass such noted in hemangiomas or the extensive abundance of endothelium seen in AVMs under the influence of FGF, VEGF, and hypoxia lead to expression of D3 molecules. These D3 molecules increase in number and ultimately lead to inner ring deiodination, converting the T4 into reverse T3. Because of the overwhelming response, the quantity of RT3 increases and T4 decreases, which signifies the degradation of thyroid hormones exceeding the synthetic capacity of the thyroid gland. This produces a condition called as consumptive hypothyroidism. So the D3 expression is directly proportional to the size of the mass and the duration of the proliferative phase in hemangiomas. Consumptive hypothyroidism ultimately leads to degradation of the thyroid hormone that overwhelms the exogenous replacement of the thyroxine. It is characterized by high TSH, low T4, T3, and high reverse T3. The literature review done worldwide, there were about 65 plus cases reported in the pediatric group with predominantly hepatic hemangiomas and hemangioendotheliomas. 7 cases only reported worldwide in the adult population. Predominantly, they are non-vascular tumors, such as fibrous tumors and GISTs. This is a small comparative table of the adult consumptive hypothyroidism group. The first report case being in 2002 by Huang et al., which was a case of hemangioendothelioma with a wide spectrum that we can see with vascular tumors such as hemangiomas, hemangioendotheliomas, and non-vascular tumors such as the fibrous tumors in GIST. The age ranged from about 21 years of presentation to 60 years, with a TSH ranging from 10.2 to 81. 5 patients underwent surgical line of management. 3, including our patients, were euthyroid, and 3 of them required no post-op LT4 requirement. The resolution time period of the consumptive hypothyroidism ranged from 3 weeks to about 11 months. What is very characteristic to note here was that the size of the lesion directly correlated with the degree of levothyroxine requirement. So the pediatric consumptive hypothyroidism is far more dramatic, associated with vascular tumors, infantile hepatic hemangiomas, is often severe, rapid hypothyroidism, and requires high-dose thyroxine and propranolol. The adult consumptive hypothyroidism cases are very rare. They're generally associated with large solid tumors such as fibrosarcomas and GISTs, gradual and very mild form of hypothyroidism, and the prognosis depends upon the tumor-directed therapy. The literature review across India revealed there were a lot of pediatric consumptive hypothyroidism cases reported by AFMC and ROTAC on hepatic hemangioendotheliomas and multiple hepatic hemangiomas. The first adult case was reported by the Department of General Surgery and Radiation Oncology from IGM Shimla, where they described a 42-year-old male with a case of GIST associated with consumptive hypothyroidism. Dr. Chakraborty recently had reported a case of consumptive hypothyroidism occurring secondary to a solitary cutaneous hemangioma in a patient who was misdiagnosed as primary hypothyroidism. So in the pediatric group, it's quite a dilemma because with a closer differential of consumptive hypothyroidism, what we need to observe here is the classical presentation that would occur probably around 12 weeks, which is coinciding with the proliferative phase of the hemangiomas. There would be an elevated RT3, large multiple cutaneous hemangiomas, so skin examination is very essential, hepatomegaly, cholestasis, and a high output cardiac failure with rapid progressive hypothyroid signs despite the LT4 therapy. The requirement of LT4 is also more. It needs about 20 microgram per kg per day or higher, and the response is refractory till there is going to be a reduction in the tumor burden. Tumor-directed therapy is very essential, and monitoring of the TFT is far more frequent, especially in the proliferative phase. So reverse T3 testing is available at Mayo Clinic in Arup in US, and tumoral D3 is available at Cambridge, Japan, and China, and by Thermo Fisher in the US and Novus Biologicals. The management of consumptive hypothyroidism because of hemangiomas, most of them over a period of time undergo spontaneous involution from 1 year onwards, so careful observation is required. The cornerstone principles for tackling a case of consumptive hypothyroidism is levothyroxine replacement. We must remember that a higher than a regular dosage of levothyroxine is required, and careful titration of doses with periodic monitoring. The tumor-targeted therapy could be classified into surgical, which is the most definitive form in adult cases of consumptive hypothyroidism, and medical, which is very widely used in the pediatric group, which consists of propranolol, that is gold standard, corticosteroids, interferon alpha, and vincristine. So they halt the tumor growth, promote rapid involution, and reduce the LT4 requirement. The therapeutic targets, so any mass which is proliferating in the background of VEGF and angiogenic cytokines, lead to angiogenesis and endothelial proliferation. So that will lead to an increase in size and D3 production. So blocking the angiogenesis is propranolol, corticosteroids, and vincristine, and blocking the endothelial proliferation is propranolol, cyclophosphamide, and vincristine. They will reduce the tumor size and the D3 expression. So propranolol is considered to be the gold standard. In 2008, it was introduced and it revolutionized the treatment, used at a dosage of 1 to 3 mg per kg per day in divided doses, dual effect of reducing the hemangioma size and levothyroxine requirement. Corticosteroids are useful, but they're slower in onset and have a modest efficacy. In refractory cases in hemangiomas associated with consumptive hypothyroidism, interferon alpha and vincristine were used. So this is a literature review on the medical treatment in consumptive hypothyroidism. So we have 6 cases in an infant reported throughout the world where propranolol was useful for regression and attaining the euthyroid status. Liothyronine, interestingly, used in Higuchi, Osada, and Yumawaza et al. Study. I'd like to conclude by saying that in adults, consumptive hypothyroidism is rare. It should be suspected in individuals with vascular or non-vascular lesions such as fibrous and GIST tumors who develop new onset hypothyroidism, rapid fluctuations in the thyroid profile, and require a higher than regular dosage of levothyroxine. The tumoral D3 expression correlates positively and strongly with the size, dimension of the lesion and the duration of the proliferative phase of the lesion. Thyroid function should be monitored more frequently in patients with consumptive hypothyroidism as there are rapid fluctuations during the proliferative phase of the tumor and resolution post-treatment. So this is imperative in optimizing the levothyroxine dosage titrations. In infants with large hepatic hemangiomas, monthly thyroid profile is recommended in the first year of life as they can proliferate exponentially. The key learnings from my case were that Unexplained hypothyroidism in an asymptomatic individual should be an indicator to search for a vascular or a solid tumor in an infant or an adult. The above mandates the importance of thorough clinical examination and good quality imaging to clinch the foci of consumptive hypothyroidism. AVM, composed of dysplastic arteries and veins that's lined by abundant endothelial surface because of the dilated vascular channels, can overexpress D3 due to hypoxia, VEGF signaling, and vascular remodeling. This suggests that the endothelial-derived lesions, whether neoplastic or malformative, can reactivate D3. While hemangiomas demonstrate diffuse and strong D3 staining, the AVMs demonstrate patchy yet significant D3 expression, which is sufficient to cause systemic hormone inactivation. The RT3 levels and levothyroxine requirement is variable and elevated in AVM, though not as markedly high as observed in hemangiomas. In our case, post-excision biopsy of the lesion, the diminishing levothyroxine requirement, followed by subsequent stoppage of the medication and achievement of the euthyroid status, is aligned with consumptive hypothyroidism. Prompt diagnosis, adequate thyroid replacement, tumor-directed therapies are keys to optimizing the outcomes. Recognition of consumptive hypothyroidism, which is a rare entity, is important as the patients can be off thyroxine after definitive treatment of the primary etiology. These are my references. And I'd like to thank my teachers and my colleagues at the Department of Endocrinology at AJ Institute of Medical Sciences, Mangalore. Thank you to the SECON 2025 and the IGM Case Reports team as well for giving me an opportunity. Thank you so much.
Very interesting case and very lucid presentation. So, I probably missed that. How you suspected this is conjunctive hypothyroidism? What was the suspicion? Because we don't generally think about that.
Yes, sir.
Maybe it is. So, what was in your case?
As the patient followed up with us, so she had presented to plastic surgery with her primary complaints and was following up with us for the thyroxine titration dosage adjustments. We observed that post-surgery, over a period of 11 months, there was an absolute diminishment in the requirement of thyroxine. And it had rapidly come down from requiring 100 mcg, which she was on for the past 6 years of her life, had dramatically come down to 25 mcg post 11 months, and thereafter she had become euthyroid. So she still continues to follow up with us with a normal TFT. Her anti-TPO values were negative, and so this gave us a clue that this could be a case of consumptive hypothyroidism with histopathology that was proving it to be a case of AVM.
So do you suspect any other deficiency or any other hormone? Why only the thyroid hormone? Do you think any? This is a very hypothetical question,
yes,
but
sir.
Since it is mainly reducing the thyroid hormone, so is there anything else can be utilized by these hemangiomas and that can cause the deficiency some of the hormones? No.
To the literature review, I could understand just pertaining to thyroid because of the endothelial proliferation, which is signaled by the growth factors and hypoxia, predominantly affecting the thyroid degradation and increasing the D3 overexpression that would ultimately lead to increase in reverse D3.
I think nice presentation. Doctor, I have 3 points.
Yeah.
The patient had hypothyroidism for 6 years.
Yes, sir.
And she had swelling and pain for the last 5 years.
Yes, sir.
As per the history.
Yes, sir.
So this hypothyroidism we are attributing to the hemangioma that has
Yes,
been
sir.
excised.
Yes, sir.
So possibly the history of swelling must have been
Even
more than 6
prior
years.
to that, even more than 6 years as well,
Sometimes
sir.
patients
Yes, sir.
may not report
Sure,
that.
sir. Yes.
Second important point is they require high doses of levothyroxine.
Yes,
so
sir.
as has been highlighted, they may require more than 20 microgram.
Yes, sir.
So the conventional teaching is that you require high dose in congenital hypothyroidism due to agenesis.
Yes, sir.
As compared to autoimmune and as compared to post-radioactive ablation.
Yes,
so because if even you keep on supplementing, the enzyme which is present there in the hemangioma will metabolize it, and you require, even in the 6 cases of adults, they have used 200, 300, 500
Yes, sir.
microgram of
Ranging from 88 microgram till 1000 micrograms. So it would also depend upon the primary nature of the tumor as to how much of endothelial proliferation is happening. Would depend upon the duration of the proliferative phase, as any tumor would have a proliferative phase, a plateau phase, and a stabilization phase. So the D3 overexpression characteristically occurs predominantly in the proliferative phase, sir. So as we had observed in the comparative study with the adult consumptive hypothyroidism, there was a case with a rhabdoid mass that had a huge dimension, and the patient was requiring almost up to 1000 microgram per day supplementations.
So that is another pointer that
Yes,
the
sir.
lesion can be the etiology.
thirdly, even the non-vascular regions, now they
Yes,
can
sir.
also, like particularly the gastrointestinal stoma tumors.
Yes, sir.
So they have also
So
been
in adults, it is reported that it is more likely to be the non-vascular tumors that would present with consumptive hypothyroidism, sir. And that's why the hypothyroidism being far more gradual and milder, and so it would not be as dramatic as in a case of a pediatric hypothyroidism where we would pick up on consumptive hypothyroidism earlier. So we require a high index of suspicion in patients who are presenting to us with rapid fluctuations or new onset hypothyroidism in the background of a tumor.
Any question from the house? Well, so that the dose was increasing over a period of time in this particular patient. One is maybe his weight is increasing with growth,
Yes.
requirement increases, that's fine.
Yes, sir.
But otherwise also our dose was increasing more.
So not in comparison to the other cases that we've observed. So when she was diagnosed with hypothyroidism and initiated by a GP on a dosage of 75 mcg of thyroxine, which had eventually come down to 100. Then she had stabilized on the dosage of 100. But however, her diminishment in the requirement post-surgery was far more dramatic than the escalation that we had seen in this particular case.
So you went back for the histopathology also?
Yes, sir. We went back for the histopathology. That was suggestive of AVM. And so that gives us a clue. If it was hemangioma and it was a highly vascular proliferative tumor, we noticed that the D3 overexpression is strong and diffuse and would see a more dramatic rise in escalation of the levothyroxine requirement and de-escalation. AVM, with the amount of dysplastic arteries and veins that they have, their endothelial proliferation and expression of D3 is far lesser compared to that of an hemangioma, which corroborated with our case.
She had goiter?
No goiter, sir. On examination, there was no goiter.
So, well, very nice. So, any question or comments from the house? Yeah.
I'm so sorry, I couldn't hear.
Please come out to the mic.
Any role of combination therapy of T3 and T4 in such kind of patients?
Yes, there have been 3 cases reported in the pediatric group, sir, where LT4 and LT3 combination was used because of low T3 levels. There are only 3 cases that have been reported worldwide. One where they had used only LT3, one in combination with LT4, and one LT4 and LT3 in divided doses.
Yes,
during follow-up, at what interval TSH should be estimated in adult with conjunctive hypothyroidism?
So the TSH would be high. That would be dependent upon the size of the lesion and the duration of symptoms, sir.
Thank you. Very nice
Thank you,
presentation, Dr. Harini.
Thank you so
very
much, sir. Thank you so much,
and
sir.
thank you, organizers, for the opportunity.
Now moving on to the next session. Next session is on pituitary practice pearls. For this, I would like to invite on stage our 2 respected chairpersons. First of all, Professor Dr. Pradeep Rai Chaudhary. He was Professor and Head in Department of Endocrinology of Medical College, Kolkata. And also Dr. Vaigankar Devi Prasad. He is the consultant endocrinologist and in Bharati Hospital and Research Center with many accolades in his name.
In this session of practicing pearls, first speaker is Dr. Basubra Surgonda. His present designation is he is Senior Consultant Obesity, Diabetes and Endocrinology, present affiliation Narayana Health Hospital, Bangalore, Shoshi Advanced Health, Bangalore. Major achievements, bronze medal, academic excellence, PGI, Chandigarh, 2019, 10 trials, Young Investigator Award, member Research Committee Narayana Foundation, founder and organizer and secretary flagship annual Bacon Conference, Yes, I remember. Publications more than 50 in national and international journals. I call upon Dr. Basubraj Suragonda.
Sir, thank you, sir. Thank you, organizers, for the opportunity. Thank you, Pradeep sir. And yeah, so today what we'll be trying to understand is about the post-operative polyuria and approach. How do we do that? And we have had a very nice IG's case report journal. Dr. Ahmed presented a very rare LCH diagnosis, xanthomas disseminatum, causing this diabetes insipidus, but not so rare. But we'll be trying to talk about the post-operative impact on the diabetes insipidus. So we understand this is a fairly water balance disorders in post-operative conditions are a fairly common occurrence, and they do complicate the journey of the patient's admission a lot. And post-operative polyuria, or rather DI per se can occur up to 45%. The data is again heterogeneous, can vary from 5-10% to 45%. The highest is 45%, and SIAD can properly occur in up to 20 to 28%. And all of these the water balance disorders are one of the major cause for the readmissions to occur in these post-operative patients. And what we also should understand that the reporting across the globe has been very variable, and the numbers have been quite all across the board, as less as single digit to almost as good as double digits, ranging up to 40 to 45%. So what we also have to understand that the whole nomenclature of diabetes insipidus, we have also heard in the morning in the main hall also, that probably we are moving away from the word diabetes insipidus and calling it as AVP deficiency. So what does it mean? The AVP deficiency, or the central DI, what we used to call, is basically the hypotonic polyuria, resulting from insufficient AVP secretion due to hypothalamic neurophyseal dysfunction following surgical manipulation or injury, or it can be de novo also. Now we'll be talking about the post-operative stances there. The AVP resistance, the renal insensitivity to circulating AVP, that's your AVP resistance, or the nephrogenic DI, which we used to call, because with mutations of the V2 receptor of the AQP2 pathway functions also, though this is very less common, close to 2 to 5% there. And then we know the classical triphasic response also. So how must, what's the problem statement here? Post-operative and post-traumatic AVP deficiencies can occur. The transient DI can occur anywhere from 5 to 25%, and the permanent DI, which is again lesser, which can occur in the pituitary adenomas close to 3%, less than 3%, and craniopharyngiomas, a bit of larger tumors, and more invasive tumors like craniopharyngiomas can go up to 10 to 25%. The triphasic response, the classical triphasic response, which is again a very difficult course to be handled in the IPD, is close to 3 to 5% is what we understand. Then again, does histology matters? Yes, definitely histology specific risk stratification. If you see, overall there is 17% transient and 3% overall permanent cases of the pituitary surgeries, or basically the transpinodal surgeries. Adenomas as close to 3%, Rathke's clefts close to 14%, and craniopharyngiomas can go up to permanent DI. This is talking about permanent DI, can go up to 30%. And why does this occur? Because of the pituitary stalk section. So what happens is the interruption of the axons prevents the stimulation of AVP release from the nerve ending, leading on to AVP deficiency. Then again, because of the degeneration of the posterior pituitary, releases stored AVP non-specifically, leading on to SIAD. Once all the stored AVP is released, AVP synthesis is impaired or absent in the damaged neurons. That again leads on to the permanent DI, or the AVP deficiency. So again, similarly, the temporal patterns will be early DI phase, that is hours to 48 hours post-operatively, because of the direct stalk or posterior pituitary injury or neurogenic stunning of the surgical from the surgical manipulation. And then the delayed SIAD phase can occur from 4 to 10 days and requires intensive sodium monitoring and representing a peak admission readmission period. This is the typical period where most of our post-operative patients are at home, discharged, and then they are at home. So this is again becomes a very pressing point, or a crucial point for them to follow up and have a proper protocol for them to follow up. Recovery or the recurrence, the potential for the DI to return is also there, or then they normalize. Anticipating phase transitions and avoiding premature therapeutic anchoring becomes very crucial. A standardized diagnostic criteria for post-operative AVP deficiency is what is required. Uniform definition requirements, which includes a polyuria threshold. Then again, there are various definitions. Typical definitions are urine output more than 300 ml per hour sustained for at least 3 hours post, 3 consecutive hours post-operative. Urine concentration, that's your hypotonic urine. Urine specific gravity less than 1.005, confirming hypotonic nature of the polyuria and excluding the osmotic diuresis or other causes. And then the additional criteria, which includes at least one of the excessive thirst sensation, serum osmolality more than 300 or serum sodium of more than 145. All of this to be definitely considered in the clinical context of the patient wherein we are seeing. Then again, the similar thing which I have put in a tabular form, various definitions again, 4 ml per kg per hour, or rather some papers have also mentioned as 250 to 300 ml per hour for 3 consecutive hours. Thirst, which will be usually in most of the patients preserved and it will be excessive, and definitely visual analog score or rather a numerical score of more than 6 out of 10 has been used in some of these papers to tell that what is excessive thirst. NMS score is available. A score of more than or equal to 6 out of 10 is considered as excessive thirst, and urine specific gravity of less than 1.005, which is again we can definitely have some of this point of care device, though we don't have any. Serum sodium of more than 145, 147, some of these studies. Serum osmolality of more than 300, urine osmolality less than 200 to 300 milliosmoles. They vary, but definitely the whole idea is very clear that it has to be an hypotonic urine with hyponatremia, and it has to be a polyuria also. So exclude other causes definitely like your hypoglycemia, diuretics, preoperative fluid, for primary polydipsia, and in certain cases Cushing syndrome and even acromegaly can also present with polyuria. Basically the essential monitoring parameters includes your close monitoring of urine assessment, serum monitoring of your sodium and osmolality, clinical parameters which includes your daily weight monitoring, and systematic thirst assessment documentation is also important. So are there any risk factors through which can we predict some of these patients for going for polyuria or AVP deficiencies? Intraoperative factors such as your CSF leak occurrence and direct stalk or posterior lobe manipulations can definitely increase, have been shown to be a predictive risk factor for neurohypophyseal injury and future occurrence of DI. Lesion characteristics, large tumors, craniopharyngiomas, suprasellar extension, rapid pituitary adenoma extension, such as your partial pituitary apoplexis, can definitely cause higher risk of post-operative DI. Clinical integration, detailed neurosurgical operative notes have to be used regarding how the manipulations have been done. All those things lead on to the predictors. Now, a very comprehensive list of factors which increase the risk of post-operative DI. Young age, these are all very small studies, but to make it a very comprehensive list, typically patients who are younger have got higher risk of higher DI. Male sex has been in couple of studies. Tumor size, higher the tumor sizes, large intracellular masses and macroadenomas, and definitely rapid, what I told, partial pituitary apoplexis and even pituitary abscesses can also cause the DI, rapidly increasing pituitary abscesses. Intraoperative CSF fistulas or leakages, histological type which we always already discussed, your RCCs and the craniopharyngiomas. ACTH secreting adenomas are also mentioned, though not consistently across all the studies. Definitely craniotomy approach increases the risk of DI. Preoperative panhypopituitarism, current smoking, high perioperative doses of steroids, and even within the percentage change in the sodium and the preoperative sodium. That's within the normal range also. This was a very unique, innovative study that within the normal range, a rise in the serum sodium percentage told that they had higher risk of post-operative DI. Factors associated with decreased incidence of DI, meningioma on histopathology. One of the study did mention that percentage change in the urine specific gravity, endoscopic transperineal surgery as compared to the microscopic approach was mentioned in couple of the studies to have lesser risk of DI. So then coming to copeptin, then basically biochemical fundamentals or the basis for why copeptin is useful is basically it is stable, it is because of its superior stability and a longer half-life as compared to AVP itself, and a clinical advantage with early post-operative copeptin can definitely predict the occurrence of DI in the post-operative phase. Roll-in or roll-out strategies can be used with this copeptin. Low copeptin strongly suggests AVP deficiency. POD1 cutoff of less than 2.5 picomole. This is usually between 1 to 12 hours, which has been done, and for rule-in thresholds. And then the rule-out thresholds, which includes high copeptin, argues against the AVP deficiency of more than 30 picomoles per liter for rule-out threshold. And then there have been a couple of studies examining at the post-extubation levels of copeptin also. Copeptin predicting performance, day 2 also some people have seen, less than 3.1 picomole predicts a permanent AVP. At 3-month threshold of more than 3.5 picomole and a permanence cutoff, 3-month copeptin of less than 1.9 picomole suggests permanent AVP deficiency. This is again a tabular form, which I think you can keep it so that we understand what are the cutoffs for all of these levels. So is there a grading system for the post-operative AVP deficiency? I think this is visible, yeah. So there are 5 grades basically. Grade 0, 1, 2, 3, 4, 5, 3, 4. Grade 0 is AVP is unlikely on clinical and biochemical assessment. Grade 1 is where the DI is less than 48 hours, early transient dysfunction. Grade 2 is duration of less than 2 weeks. Short-term impairment is definitely there. Grade 3 is duration of 2 weeks to 6 months, prolonged dysfunction. And grade 4 is duration of more than 6 months, leading on to a permanent AVP deficiency. So the early monitoring protocol framework, initial 48 to 72 hours, very close monitoring of the patient is required. Early input-output monitoring, transitioning to every 3 to 6 hours once clinical stability is achieved with continuous bedside specific gravity, urine specific gravity, lab schedules every 6 hours at least of serum sodium, and if required serum osmolality, and clinical assessment of daily weight monitoring is required. So now coming to the differential diagnosis of polyuria, out of all of this, we understand that the fluid overload causes polyuria with a normal urine specific gravity with almost nil or low thirst. Hyperosmolality or hyponatremia is nil. Osmotic diuresis, we understand that the urine specific gravity will be higher. Diabetes insipidus, urine specific gravity is lesser. Polyuria with whatever we have discussed. Adipsic DI, one of a grave prognosis or a dangerous form of DI, where basically the dipsogenic or rather the thirst is knocked off, and then you'll have to take almost all of the fluid control balance in your hand and put the patient on those things. So quickly rushing through, this is your differential diagnosis, the physiological water diuresis or because of the IV fluids. The levels will be usually normal or mildly reduced, and they are not elevated. Thirst is usually absent, no polydipsia also, self-limiting and typically transient and just monitor. Osmotic diuresis, there is this hypoglycemia or glycosuria because of the elevated blood glucose levels. IV mannitol administration and high solute loads like your urea or other solute concentrations from nutritional or therapeutic sources produce osmotic diuresis requiring careful medication and nutrition review. So again, there are very rarely we might need a couple of these advanced tests to require differentiation of primary polydipsia and AVP deficiencies, and there are definitely, I think this is visible, yeah, there is diagnosis scores also which are available to differentiate the DI from the primary polydipsia. A practical diagnostic workflow, initial assessment followed by risk stratification immediately on POD1 or 2, and then trying to manage them based on the patient risk factors, and then predominantly looking at the differential exclusion. Then again, we must understand about delayed hyponatremia impact and protocols which are very local and which will definitely help in following up these patients and for avoiding the readmissions and better care is what we understand. So now the treatment principles, basically if the thirst is intact, then add libidum, let the patient drink water. Mild AVP deficiencies, drink to thirst strategy with close monitoring may suffice, avoiding unnecessary pharmacological interventions. Hyponatremia and water deficit management, calculate the deficits, correct the rate targets around 8 to 10 depending on the onset of the hyponatremia, and then individualized monitoring might also be required. Then again, there are various school of thoughts which talk about the correction rate targets, that probably the correction rate doesn't matter, but yes, for now we'll stick on to the classical thing of 8 to 10 millimoles per liter per 24 hours of correction. Desmopressin therapy in AVP deficiency, we all understand this. Early post-operative period, utilize as and when needed. Usually nasal sprays are less preferred because of the nasal congestion and the surgical transpineural route. Oral or subcutaneous vasopressins are usually preferred there. And persistent AVP D deficiency transition to individualized oral regimens acknowledging the wide interpatient dose variability, which can go from quite high to low requirements, and then discharging the patient with a good education that they might have to follow depending on the duration post-operative day. Then there might be this chance of SIAD during POD 4 to 10, and then we need to have individualized institutional-based safe hyponatremia correction protocols which will help us in managing these patients. With this I'll end. These are my references, and I think we can move on. Thank you, Chairperson.
Thank you, Mr. President.
Thank you.
Ending up within time. One thing I want to ask you. Oh, sure. We will keep discussion later.
For next topic, I will like to invite on stage Dr. Jay Chordia. He is a DM endocrinologist and working as senior consultant endocrinologist at Paras Health Hospital, Udaipur. He has been faculty in various endocrine and diabetes related conferences. He is a member of AAC, ESI, RSSDI, and I would like to hand over the session.
Thank you, Gar. And thank you, Endocrine Society of India, specifically Bengal, for giving me an invitation to come to this city after almost 34 years. So it's a big lapse. So before I start, just raise your hand. How many of do you know what is Nelson syndrome all about? Partially. How many have seen Nelson syndrome? Only one or two. So that is a difficult thing, basically, to convince that this syndrome happens, because on a day-to-day practice we see diabetes, we see endocrinology, we don't see Nelson syndrome. We may see what Vasuraj told about. So this is how Nelson syndrome came in a picture. Basically, it was thought to be as a post-adenectomy tumor syndrome, rather you can say, because initially when there was no access for MRI in 1990s, after MRI came, before, just by the X-ray of the sella, they used to determine that, okay, the sella is enlarged, the patient is having hyperpigmentation, so that stands for Nelson. And this was when Nelson did his study, being a fellow. He was not an author, he was just a fellow studying endocrinology, and he found this hyperpigmentation associated with, and he subsequently quoted this, that this might be a different syndrome, followed by multitude of other doctors added to it. Incidence and prevalence, I would not say it's very common. If you see, it's a rare complication. Specifically when I talk in our day-to-day practice in Cushing syndrome, rarely we see a bilateral adenectomy being done. So we will not see Nelson syndrome, because Nelson syndrome is a triad where if you see the percent before, it can occur, suppose a patient of resistant Cushing's get a bilateral adenectomy, it can get as early as within half years of the post-adenectomy case, or how much time you have to follow. It may be around 24 years, 30 years. Post-adenectomy, the patient may develop Nelson syndrome. So the cause behind this Nelson syndrome, or the definition behind Nelson syndrome, is very clear, that a patient should have a corticotrope secreting tumor. That means the cortisol, the ACTH part is very high. One. Second, very important thing is hyperpigmentation. So that's another very important point, and the measurement of ACTH, which should be very high. Rarely some persons have told that, okay, if the ACTH is very high and if you don't see a tumor also, you can label the patient as Nelson syndrome. So this HP axis is very clear. We all know that if there is no adrenal, there is no cortisol in your circulation, whatever is from outside, you are giving a replacement, and if that replacement is not perfect, the patient will have an unrestrained axis, or CRH will be high, and ultimately the tumor, if there is a chance anyhow to develop a tumor, the patient will develop because of the unrestrained effect of CRH. So this is CRH and AVP leading to, you have a corticotrope secreting tumor which comes in the pituitary, and then it rapidly rises, and there are certain prognostic factors by which how we can determine. Other than that, hyperpigmentation. Whether hyperpigmentation is essential, hyperpigmentation is because of more of secretion of pro-opiomelanocortins because of the unrestrained CRH, and that leads to This hyperpigmentation, this is not Addisonian hyperpigmentation, this is classical of Nelson syndrome, and this is needed because of high plasma ACTH. And generalized, it can be on the mucosal surface, it can be in a face, it can be on the surgical scars. This all what we have seen classically in basically you can say Addison's cases also. This is, you just know that how the hyperpigmentation happen. If I see on my left hand is a female who is a mother, and on the right is a younger daughter. So the younger daughter is white, the mother used to be white, but post adrenalectomy she developed Nelson syndrome, and that Nelson syndrome led to the texture what you can see. So this is how hyperpigmentation is noted, and it can be prolonged and it can be presenting at any point of time. So this is the first of the cases which was found by Dr. Nelson, and this was patient CR. On the right side you can say this is basically more of a classical Cushing's, moon facies, typical obesity of Cushing's, and she was treated at that point of time with bilateral adrenalectomy, because at that point of time Cushing's was not thought to be a pituitary tumor disorder. It was thought to be that if you remove adrenal you will cure Cushing's, and ultimately the adrenals were removed. On the right you can see how she developed severe hyperpigmentation. A person who was white became black because of this hypersecretion of ACTH, ultimately Nelson syndrome. So before labeling Nelson syndrome, you should have certain biochemical criteria, certain radiological and ophthalmological data, because it's a corticotrope secreting tumor. So biochemical diagnosis is very clear. If you are having a morning elevated ACTH, whoever is doing an post DM, basically you can see, or doing a DM endocrinology, the very important thing is the timing of measurement of ACTH is a very important thing. It should be early in the morning, 8 AM. The sample should be immediately centrifuged. The lab should be perfect, that okay, it should be centrifuged and separated. The timing, because these all patients of bilateral adrenalectomy are on steroid replacement. So if they are on steroid replacement, what should be the timing? Because if you are giving, suppose, a super dose of steroid, the ACTH might itself go low down. So the measurement of ACTH is 20 hours after the last dose of steroid early in the morning. So that means you have to skip whatever physiological dose of steroid you are giving as a replacement post adrenalectomy, stop it for 20 hours. In the morning 8 AM you take the sample. Another way is after taking an 8 AM sample of ACTH, 2 hours after giving the dose of steroid, again take a sample. So if your morning ACTH is more than 200, and if post steroid your ACTH is more than 100, that is sufficient to label that this patient might be having Nelson syndrome. And then now we have an easy accessibility of MRI. Definitely MRI, according to the various criteria, the corticotrope tumor per se, presence of a pituitary tumor might not be a confirmative diagnosis that the patient is having Nelson syndrome. It is graded as, suppose you have a more than 10% of, suppose you have a microadenoma and there is again a growth of more than 10%, that might be a Nelson syndrome. If on various points of cut you have more than 2 mm of elevation in the pituitary tumor, that may be Nelson syndrome. So that is how these things are judged, and definitely if the tumor is very large enough, there will be definitely formal visual testing is needed. So these are the diagnostic criteria what I was talking about. You need biochemical as well as radiological investigations and certain secondary criteria which are non-mandatory, which labels suppose as hyperpigmentation. Still we are in a confusion part that what exactly there should be a definition for Nelson syndrome. But my role was basically pertaining to the prediction and the prevention. Suppose you have a resistant case of Cushing's where everything you have done, pituitary surgery has been done, the radiotherapy has been done, followed by the adrenalectomy is the last option basically, so that remove the source and the Cushing's may improve. So how can you predict that which patient whom you are subjecting to bilateral adrenalectomy will develop Nelson syndrome? So there are certain predictable factors by which, suppose a pituitary tumor is still there after post pituitary surgery, that is one criteria where the patient may develop Nelson syndrome. A patient having a very high ACTH before adrenalectomy is another very, very important criteria for prediction of Nelson syndrome. This is what I was talking about, the presence of ACTH. Suppose if the ACTH is very, very high, post adrenalectomy also, and before that also, that may predict young age. young age, if the patient is having a very younger age at diagnosis of Cushing, he might be more having a chance of Nelson syndrome. Then a shorter duration of Cushing's disease. That means within 6 months, the Cushing's happened very rapidly and you have to subject the patient to post-adenectomy. These are the scenarios where Nelson may be there. And there are the certain genetic factors. I was studying while in my flight. There's a molecule or substance known as E-cadherin, which binds the membrane. If there is deficiency of that, the membranes are not bound, so the corticotropes grow, and this is how the genetics come in play. Glucocorticoid substitution, another very, very important thing. Suppose a patient has adrenal removed. We are standardly talked about that we replace via hydrocortisone 30 mg dose. So that is what we think might be a standard dose for post-adenectomy patient as glucocorticoid substitution. There is a question that whether that replacement is sufficient or not. So that may be a factor which may aggravate or cause Nelson syndrome. Pertaining to radiotherapy, so if a patient of Cushing's had undergone a radiotherapy procedure, it might be that the Nelson might be lesser on the part. MRI is very, very important, and MRI should be seen by an expert pertaining to this. And you can see on the above, there was a giant macroadenoma, and just after that, post-surgery and endoscopic transforaminal surgery, you can remove that tumor very beautifully. So it is up to the surgeon. Ruling out mimics, definitely when you have clear-cut bilateral adenectomy, I don't think you need any differential diagnosis, but still some people may say ectopic ACTH might be there. It might be rarely adescence because adrenals is out, adrenocortical CA and drug-induced hyperpigmentation, which doesn't appear to be so classical what Nelson is all about. Another very important thing, you remove the tumor, you should know how to follow. So there are various ways to follow. Suppose a patient should be followed after say 3 months, then 6 months, every yearly till 2 years, 6 years according to duration. Then the follow-up appointment should be according to the clinical scenario also, according to the ACTH measurement. Suppose if the baseline ACTH is okay, follow-up after 3 months, follow-up after 6 months, and accordingly till year. If the ACTH post 1 year is okay, then you can go for a yearly estimate. And there are certain diagnostic criteria like expanding pituitary mass, either ACTH which is high, either the hyperpigmentation which is high, or the markedly rising ACTH. What I labeled is, suppose you give a steroid dose, 2 hours later you get an ACTH which is again elevated, that may mark that Nelson syndrome is there. So this doesn't need to be seen. Okay, you have diagnosed Nelson syndrome and you think that this patient should be treated because the tumor is very aggressive, it is causing bilateral bitemporal hemianopia, it is causing visual field defects, it is causing hyper secretion of ACTH. So what should be the primary goal? Ideally the tumor growth, ideally the clinical remission. Treatment modalities, definitely if you have a tumor, first and the foremost you will go for a pituitary surgery, followed by radiation therapies, followed by certain medical therapies. So I'll be very quick on this part because only I have 4 minutes left. Transfemoral surgery is a very, very important thing, but it should be in the expert hand. If you do a proper surgery, if the tumor is controlled, I think you are 90% safe. The residual task can be taken by radiotherapy or like that. So on the radiotherapy part, now we are lucky enough, we are having not only stereotactic, we are having basically all forms of radiotherapy. You can have LINAC machines, you have SRS, you have gamma knife. Most commonly in Indian scenario, if you see Nelson syndrome is very high centers, generally gamma knife is the preferred option because it is very precise. Stereotactic radiotherapy is very, very precise. And these are all the databases, how the radiotherapy benefit with the recurrence. Basically, there was almost 92% of radiological tumor control and 62% reduction in ACTH. So you follow post-radiotherapy and you see benefits. Specifically, the data is more on gamma knife, which is a very good thing and a very precise thing for these category of patients. Medical management, we all know for like suppose acromegaly, we give dopamine agonist. So dopamine agonist is there, cabergoline is there. Somatostatin analog, SSTR5 is basically what is most expressed in the corticotrope secreting adenomas. So only drug which can inhibit that specifically somatostatin 5 receptor is the pasireotide. So that is very, very precise for Nelson syndrome. Otherwise, there are good amount of agents which may help. So these are somatostatin analogs. There is dopamine agonist, the valproate, sodium valproate. It may be a paroxysm rosiglitazone which is out, not in the market because papar gamma is expressed. Sodium valproate via gamma, the GABA butyric acid control. So these are things, but they are not very classical. They may be supportive for your patients. So I will not go much into detail of each of the medical therapies, seeing the paucity of time, but these important agents can be supportive if suppose you have given everything to the patient, still the patient is not responding. Pertaining to the glucocorticoid replacement, definitely I think hydrocortisone 20 milligram in the morning and 10 milligram in the evening or afternoon time is basically what we think about. Mineralocorticoids are also required and fludrocortisone standard dose is given. Post-treatment monitoring, you have given radiotherapy, you have given surgery, what next? So biochemical monitoring, the plasma ACTH should be measured every 3 to 6 months initially, then annually. A rising trend again is a red flag. Radiologically, a pituitary MRI performed around 6 to 12 months for the first 3 to 5 years, then less frequently if the tumor is stable. Clinical monitoring is always open, regular assessment of visual changes, headache and sign of hypopituitarism. What about the next generation diagnostics? There may be molecular markers by which you can easily determine that which patients may develop Nelson. There may be genetic testing, there may be advanced imagings which may help. Targeted therapies. You may in near future see targeted therapy, but why the research is not much? Because Nelson is a very, very low category of syndromes, very rarely seen. Then immunotherapy and the gene therapy. So if I summarize, early diagnosis and management of Nelson is crucial, otherwise it can be life-threatening. Thanks to the advanced technology now we are having, when Dr. Nelson saw Nelson syndrome, he just adjusted it with an X-ray, with a SALA X-ray and with just 17 hydroxysteroid in the circulation when the cortisol was not so determined. Now we are lucky enough, within 3 hours we get a cortisol and everything is in hand. And definitely a multidisciplinary approach is needed for treating such kind of syndromes. With this, a big thank you. I am on time.
Thank you, Dr. Joy. Please be seated. The last lecture is adult growth hormone deficiency, treat or not to treat. This will be delivered by Dr. Altama Sheikh. He is MBBS DNB medicine, DNB endocrinology, MNMS endocrinology. Professional role, consultant endocrinologist, diabetologist, metabolic specialist, associated with hospitals, clinics in Mumbai, Safi Hospital, Masina Hospital, Raheja Hospital, Prince Ali Khan Hospital, etc. Scientific contribution member, scientific committee, ISBMR, Thyroid Society ASICON, joint treasurer, Maharashtra Endocrine Society. Awards, first RSSD award for excellence in diabetic care, Maharashtra Rising Star 2020, state ranker, best paper, academic contribution, second editor, Sadikot International Textbook of Diabetes, speaker at national international conferences. Dr. Sheikh, please go ahead.
Thank you, Chairpersons. Good evening, everybody. First of all, a big congratulations to the team Kolkata for arranging such a grand scale of ESICON. And I think all my friends have been really working very hard. Congratulations to all of you. A very happy Teachers' Day to everybody in the auditorium and my chairpersons. Happy Onam and happy Eid Milad to everybody. I've been given a quite difficult topic of adult growth hormone deficiency. And we should be deciding by the end of 10 minutes or so whether we should treat or not to treat. I think we just saw two great endocrinologists talking about two other pituitary sections, and we saw how difficult it was to see those cases. I think we saw only 1 or 2 hands with Nelson syndrome. I'm sure there will be no hand raised with this particular section of adult GHD because of these are the following problems that we look into. People usually kind of feel growth hormone, do we really need it? But I am talking, walking, doing everything. Why do I need the doc? Now, the problem comes with growth hormone deficiency in adults especially. If you've had something in the past as a child, or there is a trauma as an adult or a child, or when you want to clear a medical exam, either for your aviation industry, or for army, or something else where either your height, or your body weight, or something else is a problem, and that's how these people present in adulthood as adult GHD. And that's where it is seen. And let me also clear this in the first slide itself, that it is not only men, women also can have adult GHD. So it's seen in both. Now, this is not just the disease of the West, it is very much seen in India, and it is very likely underdiagnosed because people do not know how to pick this up. And similar kind of an awareness which is there across the globe in different continents that we look into. So what happens? What causes this? Pituitary adenomas, what my previous two friends have shown, are the most important cause. When they compress the pituitary, they eat up the pituitary, and the cella becomes either partial empty or others, or completely empty. Or as a child, you've had a craniopharyngioma or radiation to the brain for some other reason it was given, and you've had a decrease in pituitary size and decrease in function. Or otherwise, either a surgical insult or an infiltrative thing, or an autoimmune disease, or Sheehan syndrome because of multiparity that can happen, also present with adult GHD. These are the usual causes that we see with this. Now again the question is, so what if growth hormone is not there? This is the next slide. I'll show you what can happen if vitality, how it goes. The metabolic function of a man and a woman both go. The ovarian function, the testicular function goes. The lipid metabolism, insulin sensitivity goes. A different difficult type of central obesity that comes, insulin resistance that comes, metabolic syndrome, cardiovascular disease, osteoporosis. Now you will say most of us get this. Of course, yes, most of us get this. But if you have growth hormone deficiency, it is 10 to 30 times multiplied by that. And that's the reason we need to really look into this. And people with GHD have got 3 to 5 times more metabolic syndrome, 10 to 15 times more mental status issues, lapses of attention, difficulty in concentration, forgetfulness, depression, anxiety, reduced quality of life. I'll tell you how my different patients presented in the clinic. So one patient came of adult GHD. His complaint was, doctor, I am not able to carry my backpack, which I used to carry to my office daily. I am lately feeling very low. What will we think as physicians and endocrinologists? Vitamin D deficiency, B12 deficiency, has lost weight, is drugging, is taking some alcohol, or is not interested, or got depression. Possible that all of these things, when you treat, still the patient will have that symptom there. And for a lady, if the lady says, I have difficulty in climbing my stair when I used to work earlier, now I'm not able to do, we also add is a thyroid. Now, supposing the lady actually got a thyroid and you've treated, still the symptoms remain. Second point where you should be thinking about that something is more than, because even if you've treated with thyroxine, something is missing. Third complaint, usually how these people present, struggling with feeling of persistent cold. You thought it is thyroid, you diagnose it as thyroid, you've treated, but still that persistent cold has not gone. Choosing loose clothes because the body shape, body image is changing, because the muscles are not holding, because growth hormone is not there. Do not feel like going outings to social gatherings because the changes in face also is there. Now, all these things are also confused with depression for a lot of us. Forgetting simple tasks. I don't know where I kept my keys. I don't know where I kept my household kitchen utensils or something else. Drivers also can present like that, forgetting keys a lot of times, and needing frequent breaks in the office. I am not really myself. I need to take a short break of 5 to 10 minutes. And this is how they present. So, it affects not only physical issues, but also has got mental issues. We've discussed nearly all of this, including this. So how do you diagnose GHD? Who is the right candidate for evaluation? From childhood, I will not going to speak because we need to concentrate on that. So some history of in the past that patient was on growth hormone or was having multiple pituitary hormone deficiency. Maybe growth hormone was not low at that particular time, or something else has happened and now the patient has come with some other presentation, either hypothyroidism or hypocortisolism or hypogonadism, depending on that. Also, some people can come with low sperm count or unexplained fertility, recurrent miscarriages, which is both possible with this. So how do we test is the question. How do we test growth hormone deficiency? Can anybody tell me? Either right side or left side? By doing easily we remember it as IGF-1 testing, but IGF-1 is not the first test to be done for adult GHD because it may be low. It may be low even in a very light or mild cases of adult GHD. Also, we do not use IGF-BP3 for adult GHD because of very low sensitivity and specificity. We use this criteria. There are more than 3 adult pituitary deficiencies and a low IGF-1 in that cases, then we say that yes, this is properly an adult GHD, or otherwise we need to do a confirmatory test. How do you do confirmatory test? I'll show you in the next few slides. The first one here shown is insulin tolerance test, which we do in India also for children and in some adults. The other ones are very difficult to do. Glucagon stimulation test in cities where it is available, it is done. So that's how we look into the diagnosis of adult GHD. And as I said, IGF-1 may be just a screening tool, but when it is normal, it does not rule out adult GHD still. So which means we need to reconfirm with something else. Those were the caveats that we just discussed, that how you will avoid these things to test in specific situation and to test specific limitations and come to a diagnosis with a very happy note. You just see the first section of ITT, that is insulin tolerance test, and as per the latest one, any GH less than 5 microgram per liter after 1 hour of ITT is diagnostic and confirmatory for your adult GHD. These others are not available. Masimorelin is a newer oral tablet that we give with GH levels less than 2.8, but however availability, cost, etc. are going to be a problem in that. Now, there is a shift towards modern stimulation test and clinical criteria very easily. Low IGF-1 with other 3 pituitary deficiencies, or a low IGF-1 with an insulin tolerance test. And normal IGF-1 does not rule out these things. Masimorelin, as I said, not available in a lot of places. But however, we have seen in the last 40 years, from 1995, 1985 to 2019 and 2024, the updated guidelines, they talk about doing minimal investigations and giving maximum output. The reason is because the treatment of adult GHD is more difficult, is more comprehensive, is more qualitative, is more about cost of that particular thing. We all know how this is available in grey market, but for an adult GHD, the dose is going to be nearly half of what we give it to the children, and that's how you treat it. And it's a very important thing that this is the time you're going to treat when there is no contraindication, there are no signs and symptoms of GHD, and you want to give a good quality of life by different assessments. Of course, these are long appointments. These are not very easy like diabetes, thyroid, obesity, and others. This is a proper endocrine diagnosis and a treatment, and that's how we start with a low dose and up titrate to give the best range of body composition. We need to do body composition maybe 3 monthly or 6 monthly, depending upon that clinical indication that we've used. Start low, stay low, individualized dosing, and do a regular monitoring. And that's how we would take it in certain specific situations. And you may have also difficulties with a heart ailment or a kidney ailment or a liver ailment when you are giving this particular thing. As I said, this is how you would monitor and discontinue or re-evaluate after 1 year, depending on that particular condition. So this is one way to talk about how you increase the dose, how you decrease the dose, and take it from there. I think there are a lot of variables also when we look at the monitoring, depending upon which test or which drug you have chosen in the start. And the most important, I've shown you 10 symptoms earlier of 10 patient stories from the clinic. This is how you would see that basically patients' quality of life has to change. If that doesn't change, I think we are not going to be doing justice at all and monitor side effects at every time. This is going to be a difficult thing otherwise. And I think we also need to look at contraindications and other things, look into it, and I think I'll try to take questions in the question answer session. Over to chairpersons. Thank you so much, ladies and gentlemen, for your patient hearing.
Thank you so much, Dr. Altamash. So now the session is open for questions.
Dr. Basavaraj, you have mainly you go for planned surgery and polyuria post-planned surgery. Globally, traumatic brain injury is the most commonest insult on brain, surgical insult. Is there any difference in management of, say, cold surgery and emergency surgery, like emergency situation like traumatic brain injury? Management aspect or diagnostic aspect or overall clinical course eventuality?
Yeah, I think emergency would be probably in this planned events. We can basically look at the preparation of the patient, number one, and plan a copeptin. Copeptins, again, though it is not easily available for most of our research purposes, but where it is available, it gives us a good idea. But TBI, yes sir, what you have told, probably again a very common source of post-operative polyuria and post-traumatic polyuria. The extent of the tumor and all of these, the predicting risk factors, actually they tell us can predict us the risk of polyuria in this planned surgical patient so that we can be a little bit more alert and be prepared? As in cranios, we can be a little bit more alert because the chances are high. Rapidly expanding tumors, we can be alert, but traumatic brain injury, again, we have to be probably be at a alert for a longer time, and probably those low risk patients might not be there, and we have to be extra cautious in dealing them.
Realistically, how much rapport you have got with this trauma care center on day-to-day basis? How much referral you get?
I think traumatic, fairly okay, matlab, sort of decent.
Just to add for that, I agree, sir. Most of the patients are not referred. They give them some Minrin or they give them fluids and they discharge them on for 5 days, and the patient stops it. Some of them improve within 2 weeks. Some of them have prolonged and they end up not coming back to us.
What you are calling that is already told that is most of these are readmission.
Yeah.
You want to tell them.
If they don't refer, then it becomes a huge problem.
Not referred. Private setups probably not referred. Private setups probably not referred, and the trauma care center themselves trying to treat this polyuria as that's what I think Dr. Mahesh is wanting to tell you.
Dr. Altamash, once we diagnose the patient with GH deficiency, because we are not measuring IGF-1, how do we monitor if we want to start the treatment? What are the parameters we look at when we start them on GH, and what is the dose you would recommend? Because nowadays in children we have once a week. Can we use the same preparation for the adults?
So I think the first slide that I showed about the diagnosis, that you will do a body composition. So that is what will tell us the fat mass, the fat-free mass, and the lean muscle mass. That will be the first thing that we would monitor. So that's why it becomes a more specialized disease and a more specialized center where we would be monitoring. So 2 slides we had shown. Also the dose would be easy to calculate, nearly half the dose of what we give to children. And once in a week, etc., can be tried. In fact, people are trying to give adult GHD growth hormone once in 10 days also. Like for Denosumab now we had till 6 months, but there are some studies who are talking about 9.5 months or so. So I think, sir, the duration may be a little more ahead depending upon what the target is. But however, I think in the long run, if the patient hasn't responded within 3 months of GH therapy, even though it is diagnosed fully, I think then we should withdraw and look at other scenarios. The most difficult patients are the ones, those whose career depends on the growth hormone during the adulthood. Especially, we had some pilots and air hostesses who came with GHD. So although they had good amount of height, but they did not have that amount of muscle, and the body shape and image was an issue to them. But we've had some patients, even though with the documented GHDs also, it just did not work. So is there also kind of a GH resistance, whether you've given daily, weekly, or otherwise? We need to see the patient in a whole as a total and always look at the quality of life. If it was for career-based or it was a non-career-based. Why we are starting, our why to initiate has to be very, very clear on paper, because this is a costly affair in treatment, and avoid using any generic growth hormones. I think that is what is one message I would like to give. Thanks.
Sir, when we measure the ACTH and it is high, when we do the MRI it is normal. How frequently, because ACTH is high, how frequently should we ask for an MRI? Because sometimes we think that the ACTH is high, MRI is normal, and we also forget patient is also okay, patient is taking the supplements regularly.
Yes.
How do we decide whether we should recheck ACTH, and when do we do the MRI again?
Yes. So during my presentation itself, I told that there is a cutoff. Suppose you have an ACTH, suppose you have given glucocorticoid replacement also post-adenectomy, and you are suspicious that the patient is having Nelson or not. So if the cutoff of ACTH 20 hours after stopping the last dose of steroid, early morning 8 AM ACTH is more than 200, that is generally a standard cutoff where you may have a high probability of Nelson. But there has been literature that because Nelson syndrome is a triad of tumor plus ACTH plus hyperpigmentation, so you may have corticotrope secreting tumor, you may somehow in MRI may not have a tumor. So there comes a glitch. There you have to monitor the ACTH. And another way, what I was talking, that suppose you have a basal ACTH which is not so 200 also, then you are confused. You give a steroid dose, post 2 hours, take again an ACTH sample. If it is more than 100, then the probability is more that the steroid is not suppressing the ACTH, so it may be a case of Nelson syndrome.
Thank you, sir. Altavas, one thing. Suppose a person at 45 requires growth hormone therapy. Dose may vary. What will be approximate cost, say, for another 30 years?
Cost for another 30 years. I think the current cost as on today with the Trump tariffs and others, it should be around 40 to 75,000 depending on the weight and a good brand of growth hormone. Thank you, sir.
And any insurance or reimbursement?
Wishful thinking, sir. I wish we really have that.
I only told that you were practicing it. That's why I'm telling you.
Yes, sir. So we have people, those affording people, those who take it. We offer it to everybody. Those who are willingly taking it, they are taking, but not giving more than 3 months if there is no result. I think that's, we have to take our pen back if there is no result.
Quality matters. Jindagi na milega dobara.
Absolutely, sir.
So, if the patient is on physiological dose of steroid, for example, 5 mg of prednisolone, 20 mg of hydrocortisone, and we are suspecting Nelson's and we want to estimate plasma ACTH, do we still need to stop for 24 hours prior to estimating plasma ACTH for physiological dose?
Yes, generally when we do a post-adrenalectomy replacement also, generally steroids are never given in a higher dose. They are generally given in a physiological dose. But what is the pathogenesis behind Nelson is certain genetics, certain etiological. Suppose you have a residual corticotrope still remaining. These are the resistant cases which are not suppressed by the physiological replacement. And we don't go supraphysiologically in every practical case. So these kind of cases reboot, and ultimately that suppression of steroid doesn't happen, and then the corticotrope secreting tumor comes into play. So clearly every post-adrenalectomy patient receives definitely the physiological replacement doses. We don't give supraphysiological doses just to presume that the patient may develop Nelson syndrome. That doesn't stand that you should go for a very high dose of glucocorticoid. But giving the physiological replacement, still you see the cutoff, and the criteria is very clear that if you do an ACTH not stopping steroid for last 20 hours and in the morning, you may have false results. Because many a time if you are not seeing the tumor also in MRI and you are just diagnosing clinically, you should have that cutoff of ACTH of 200 oblique post-steroid 100, which may clarify that this may be a case of Nelson syndrome.
So my question to Dr. Jay Chopra, sir. So what is the role of prophylactic radiation in before going for surgery or just after surgery?
Yes. So there comes the role of prediction. That's why, because prevention is always better than cure, as we understand in our medical practice. So there are certain predictive factors. If you see that the tumor is very aggressive, the tumor might not have been removed. Partially it was removed, there is certain residual tumor, and you have a chance that this patient may have prediction of, and the ACTH before adrenalectomy or post adrenalectomy, the ACTH levels have not so suppressed. They are still on a very high side. Also the ACTH was very high. So these predictive factors definitely give a hint that this may enter into Nelson syndrome. In those cases only prophylactic radiotherapy has been tried, but there is no any long-term dedicated data, but they have found it to be beneficial.
Okay, thank you very much speakers for such an excellent discussion. Now the session is closed. I will hand over the mic to organizers.
Last session of the day, innovations and controversies in diabetes and metabolism. For this, I would like to call upon stage our respected chairpersons, Dr. Diwakar Biswas sir and Dr. Kaushik Biswas sir. Dr. Diwakar Biswas is an ex-assistant professor of Department of Endocrinology in IPGMER and SSM Hospital. Dr. Kaushik Biswas sir is a senior consultant in Medica Superspecialty Hospital with multiple accolades in his name.
afternoon. First topic. Our first speaker is Dr. Rajiv Singla. He is actually medical director and consultant endocrinologist of Kalpavrika Healthcare, Dharoka. He has multiple publications and awards, and his main interest is in type 1 diabetes, and he is actually course director of type 1 diabetes education, so we eager to hear from him. And his topic is also on the recent advancements in the machine in management of type 1 diabetes. Please, Dr. Rajiv Singla.
Okay, yeah, so very good evening to all of you. First of all, my thanks to organizing committee for asking me to come here. I think I was given time of 20 minutes, or it's 15. Okay, I'll try to cover it in 15 minutes today. Thank you. Okay, so my role today here is to talk about machine learning in field of type 1 diabetes. So but it could also prune those factors. The machine told us, okay, so you don't need to look at 200 all of them. This is going to be a mess. Look only at 42. So upper bars are 42 parameters and below ones are all features. So what this gives us, not only insight as to who's going to go develop autoantibodies, but now you know these are the factors which are going to be significant in development of autoantibodies. It gives you a peek into pathogenesis. If we look at it further studies, these are preliminary studies because these fields are all just opening up. Maybe we would have a pathway designed for us. Okay, look at these metabolites. These are the ones which are changing, which can actually also make us reach a pathogenesis of type 1 diabetes as to why would somebody with higher genetic risk score goes on to develop autoantibodies while other ones don't. So looking at further clinical application, NHS data, large NHS data, almost of 14 lakh children. They're routine data which NHS generally collects. So machine crunching was done to see whether somebody is diagnosed the day it is diagnosed with type 1 diabetes by a clinician. If we look at data, can we identify those children earlier? Can system create a prompt? Okay, now this child is going towards type 1 diabetes. So everything is there, blood glucose data is there and everything is there. But it's a clinical routine data. These researchers looked at known 26 parameters which are associated with type 1 diabetes: antibiotic exposure, probiotic given, what was the gestational age, what their blood glucose values in serial normal routines are. They could predict 9 days earlier than the physician. Okay, now these are the children of subset who can develop type 1 diabetes. Not all of them with an accuracy, but all children were covered. So you might have to screen 50 children to catch that child, but for that child it may mean not going into decay and they can be managed even before decay. So our power or our capacity to look at the way we predict type 1 diabetes is going to change in the near future. Now what has really been game changer is how do we manage type 1 diabetes. I can tell you that in next 5 years, the type 1 diabetes which we believe any of us is able to control, I don't think so those outcomes are going to be as dismal as we believe them to be. So if we look at machine learning to manage type 1 diabetes, we broadly need to look at two things. How do we manage basal dose and how do we manage bolus dose? They're two different things. So for basal dose, simple thing is what people have done is connect your blood glucose values to the insulin pump and then let them talk to each other. Let's not interfere. We put in an algorithm. If your blood glucose levels goes more, pump gives you more insulin. If your blood glucose level goes low, then pumps give you less insulin, as simple as that. We don't do anything about it, and then machine, it's an algorithm based, and for each child the algorithm learns on its own, and that's what your what we call as hybrid closed loop systems, which are this 780G, the insulin pump that we do, right? Only caveat is it still does not solve the bolus problem, but the results have been phenomenal. HbA1c coming down from 8.9 to 7.5, time in range increasing from 50% to 70%, results that we've not looked at have been replicated multiple times again and again and again. And then going one step ahead, now we've got closed loop system. The FDA has approved one closed loop system which is commercially available, at least in US. What this system also tries to do is it not only tries to solve your basal, but it also tries to solve your bolus dose. Now you don't have to enter carbs anymore like you do in a system. You just tell them, okay, so I'm going to eat my usual meal, I'm going to eat more than my usual meal, and I'm going to eat less than my usual meal, that's it. And then the system learns how much insulin did you require in your last usual meal, and the bolus dose is automated by the system itself. System gives the dose itself, and then it does. Similarly, paper published in NEGM, similar results, time in range reaching around 65 to 70, HbA1c is going down from 7.9 to 7.3% consistently, and it's commercially available, it's being used. And and the ease of managing with these systems is like takes lot of stress away from everything. Now, as far as technology development in type 1 diabetes is concerned, I can tell you that the community development is way beyond the companies that they've done. So we've seen Medtronic, we've seen Beta Bionics, but actual innovation is happening at the patient community level. Because their numbers are so less, nobody is commercially so interested in solving their problem as their priority. So the community has taken it in their own hands. Now what they do is they connect their pump with their CGM by doing, as we Indians called it, jugaad. So your CGM is connected to your phone is connected to your pump through two different devices, and whatever the Beta Bionics or 780G is trying to do, now system does is much better. Because now it's an open system, people worldwide are trying to improve it every day, and it does wonders, If you look at this, again, similar results, time in range going to 70% of the time, HbA1c going down tremendously. And this is a slide from one of my patients who presented in Delhi Endocrine Society just a couple of months back. So 22 years old, IIT graduate, and was not able to accept for a long time diabetes, hit by retinopathy diagnosis. And that was at the day that she just thought that I had to do something. If you look at time in range 51%, time in range 52%, she put herself on a loop connected with this. Now you look at time in range is 95.6%, and if I look at further data, all 95%, HbA1c 6%. And the mental stress, it's gone, because now system manages itself. She doesn't have to manage any of her things. When compared to 780G, the open loop compares as good as it is. Only thing is, caveat is that there are no inbuilt hypoglycemia mitigation managed, because FDA would mandate people to put in safeguards for hypoglycemia. It's a community driven now. Child can do whatever, they can set their own targets, there is nobody who's stopping them. So the incidence of hypoglycemia is little higher than the commercially available systems. Now, solving the bolus dose, which I feel, at least for in our context, is even much more important, especially with MSII, because even in UK, the penetration of insulin pump in type 1 diabetes is around 12% or so. In US, it's much higher at 65%, and in India, we know that it may be at 1% or 2%. So while all those systems sound good, but we still have a way to go. So and this is where our area of work lies. This is just a review published in 2023, where they try to look at people who are working to develop an adaptive bolus calculator in which patients have to do the minimum thing. And then one of our paper, which we published a couple of years back, so there are only 6 groups, or maybe perhaps 5, because 2 of them are from same group. So there are 5 group of people who are actually working on this system, and one of them is ours, and I'm just going to take you through our system. So what we did in this was, we developed our own Indian food database, validated it with our own set of dietitians. We put that in the system. Now what the system does is, it basically automates your workflow. So child enters the food item that they're going to have for a meal. System auto calculates their carbs in there. If they know their ICR, we put that in the ICR in the system. System gives them what the bolus dose looks like. If they do not know what their ICR is, we start them with simple 500 by total daily dose, or whatever the physician feels, I feel is good for them. We put that in the start. Now that's only the initiation. Now every week, the machine learning component runs in the back and tries to see whether this particular child is reaching its target or not. If the targets are not reached, then the system changes their ICR automatically. If the hypoglycemias are there, then the ICR goes up, so the dose comes down, and vice versa. And then we again published this paper a couple of years back, and then we did a pilot study in 5 children. You can look at that. The dose that app suggested was accepted by almost 90% of people. One child has a 46% acceptance rate, but median difference in the dose that was taken was half unit, 0.5 units. What we suggested and what the child took, the median difference was 0.5 units. What we learned, however, was that the ICR is not same throughout the day. For most of the children, your dose of insulin requirement is much lower in the evening as compared to at breakfast and lunch. And if we look at the results, the follow-up, we started with an 7.8. If you look at the graph going up, down, and then gradually coming down. February 2019, May 2019, and then if you look at November 19, curve with the graph. And then if I show you the, from same index patient, if I show you the data over 3 years, you see the glycemic variability is gradually still coming down as long as we keep on, because system keep on improving the data. So for management, I think we just going to the way it's going to be there is going to change in a very, very good way. As far as prediction of complication is concerned, you look at this: age, duration of diabetes, which center children are following up, their BMI, HbA1c, CGM use, and past history of decay. Gives you fairly good prediction whether this child is going to develop decay in near future or not. So now you've got a selected group of people whom you need to look at and then follow their clinical features. So you don't have to wait for them to develop decay, but you can actually try and look at, predict it. Okay, these are the children who need my help. Looking at microvascular complications in this subset. Now, I'll skip these and then show you this. What in this paper, what researchers did was they looked at serial HbA1c over the years. That's it. What was the gap between those HbA1cs, which also was a marker of did they follow up with the clinician or not. So non-follow-up period, serial HbA1c records, age of diabetes onset, what their sex looks like, gender looks like, and then they could predict as to who's going to have retinopathy just by that. No other data required. So gives it's a great tool. And then looking at, again, another study which tried to look at other features. So if you look at here, when people followed up, the markers were diabetes duration, whether they did a glucose monitoring, positive dietary habits, psychological status, and diabetes education. We can just predict who's going to develop retinopathy, who's going to develop nephropathy, and who's going to develop neuropathy. So these are all very, very great tools. These are all, at least for prediction and for complications, these are still being developed. They need to be validated. I'm not saying we are there, but then in near future, at least for type 1 diabetes care, we would be very, very near to where we would be able to save a lot of lives by predicting their onset of disease and prevent a lot of morbidity from them developing, because now we would be able to identify children who are at risk for those complications. So AI is innovating the ways we analyze known factors and also discovering new ways and factors for predicting onset of diabetes, type 1 diabetes and its complications. And AI is on cusp of revolution for type 1 diabetes care as far as managing is concerned. In rich people, in resource-rich settings, the pumps, the loop systems are just going to be amazing. For resource-poor countries like ours, we are still working on. I hope more people start working on developing bolus dose calculators and automating these resources, but we have still made good strides. Thank you.
Thank you for your nice presentation, because he has flight, so he has to left. So if you have any question, you can ask now.
Yeah, sir. Yeah. Yeah, of course, sir. For basal, yeah, for that loop system, of course, you need to have pump. Only thing is that the latest pumps don't work because company doesn't want you to use Jugaad.
Nice talk, Rajiv.
Thank you, sir.
I was thinking about AI and the variables you gave and the
right, sir.
way we can predict.
Ji, sir.
I think you can comment on that. What am I going to say?
Ji, sir.
Because sometimes what we think, the AI works and it goes beyond our thought process also. So this is one thing, and that bolus calculator and this app is available to everyone.
Sir, it is available now. We're rolling it out very slowly. It's working at the moment. We've 4 or 5 people who are working it. We are talking to.
I came to know about it, but I was very curious. And you're doing good because we have done a lot of work on AI in pediatric endocrinology.
Right, sir.
DK algorithm and all those things we have done.
Yeah, but it is available. It is working. It's fully functional. It's there.
What you can do, you can sell to, charge some respectable amount to people, and so that it reaches to more and more number of people. We can save many lives from DK and all this. Give a thought.
Type 1 diabetes is a social cause for us, sir. So everybody has to choose one thing. So it's free.
And from type 1. And give to type 1.
It's
from
free.
Type 2 and give to type 1.
We're just trying to do some kind of a clinical trial before pushing it beyond to the larger community. So selected people we've given, but we're just thinking that maybe if we can do a 6 months clinical trial before we roll it out to everybody. So that's the thinking is. Ji ma'am.
Thank you. Because if we are seeing gestational diabetes, the transgenerational impact, you understand. So if the gestational diabetics are well controlled, I don't know. I'm just trying to think ahead.
No, so your point is very valid. I think, and I recently had this discussion with Yashdeep because he works in a GDM area. So we thought that app like ours because it's just based on reinforcement model. So if you're not at target, your dose can be tweaked, given with safety parameters and everything. So this has a potential to work very well in GDM. So we were thinking that maybe we are going to use that in GDM as well.
Great idea to control them. And then I think there is option of loaning them pumps from during that period itself. And then excellent control, and then maybe what does the future hold? It's very difficult to say.
Thank you.
Thank you. Lovely talk.
Thank you.
So, thank you, Rajiv sir. Hope to meet you soon. Now I am very happy to invite Dr. Sunil Kumar Kota, who is an eminent endocrinologist from Odisha, who has multiple accolades and laurels in the field of endocrinology, and he had published multiple original papers. Dr. Kota, stage is yours.
Thank you so much. Very good evening to the respected chairpersons, to the august audience, and thanks to the organizers for having me here and asking me to talk about the role of gut microbiota in metabolic syndrome. And when I was going through the literature, one thing was very surprising to me. The concept dates back to 360 BC, when Hippocrates first time told that yes, gut houses a number of microbiota, and all the disorders have their origin in gut. And these are also funnily called as forgotten organ, the invisible organ, the software of our body. And over the last 2 decades, there has been a growing interest in the part of the scientific community to understand its role in physiology, nutrition. You talk about metabolism, and alteration in its structure and function is associated with some sort of low-grade chronic inflammation, immune dysregulation, and also the breach in the intestinal barrier function, giving rise to a lot of disorders associated with metabolic syndrome and a number of others that I'm going to tell you in my due presentation. So with this brief preamble, I'm going to start off with the topic proper, which would take all of us through the points mentioned on the slide. First of all, the gut microbiota. We all understand that these are a group of commensal pathogens which populate the gut, and these are called the gut microbiota, and there are a number of factors which do influence, like our diet, our physical activity, usage of antibiotics, and also the genetics has a role to play, which are called exposomes. And if you look at the biomass, it is around 10 to the power 2 to 3 cells per milliliter at stomach, going up to 10 to the power 11 cells per milliliter in the colon, and it is host to around more than 100 trillion bacteria, contains more than 1,000 species and more than 7,000 strains, with 99% belonging to 40 species. Thankfully, we did not know about the rest all as of now. And if you look at the bacteria, they constitute to around 90% of the entire ecosystem, and predominantly they hail the ones which hail are bacteroids and firmicutes, and also the other ones are like actinobacteria and proteobacteria. You can see the firmicutes contributing to around 60 to 80% cases, bacteroids 20 to 30%, actinobacteria less than 10%, the proteobacteria less than 1%. Of late, there are talks about verrucobacteria and a number of other names, those keep on following. And we also need to differentiate between the good and the bad bacteria. The good bacteria are the Bifidobacterium, Lactobacillus, Akkermansia, Faecalibacterium, Ruminococcus, and the ones which are labeled as bad are Escherichia, Clostridium difficile, Campylobacter jejuni, Staphylococcus, Enterococcus, and the H. pylori. And a number of factors they do influence. If you look at a birth from the uterus itself, the oral inoculation happens with both maternal intestinal and the vaginal microbiota. You can see a number of bacteria are there, the Bifidobacteria, Enterobacteriaceae, Bacteroides. But what is important, there is a difference when the child is born vaginally versus the child which is born by cesarean section. The one which is born vaginally, there is a predominant of Lactobacillus prevotella, and the one which is delivered by cesarean section, you see a number of other, the not so useful or the good bacteria populating the gut. And if the baby is entirely breastfed, again, it is found to be associated with a good gut microbiota population of Bifidobacteria, Lactobacilli. If it is a formula-fed infant, it is more diverse with less of the beneficial bacteria like the Bifidobacteria. And impact of diet. As we all know, the diet has been changing, and we see more of animal meat, more of fat, more of fast foods, more of processed carbohydrates, and less of whole whole vegetables, grains, and fruits. So this is a study. The A talks about BF, that is a Burkina Faso diet, the preliminary kind of diet which is taken by the Africans, and it is predominantly consisting of fiber. There you can see more of bacteroides is there, more of these SCFA, the short chain fatty acids, which are the mediators of the beneficial impact, more of it is there, and the less of the enterobacterias is there, whereas the Europeans, they do behave exactly opposite, and the bacteroids tend to be lesser in number, and the SCFA production is lesser, and more of enterobacterias is there. And if you look at the functions, a number of those, as I've already stated, it has impact on energy and substrate metabolism. It has trophic effects on the intestinal epithelium, thereby maintaining the intestinal barrier integrity. It acts on the immune system. It also acts on the absorption of fat and fat-soluble vitamins, lipid and protein metabolism, a number of those. Very importantly, the production of short-chain fatty acid and reduced production of the damaging molecule, that is the TMA, trimethylamine. And these are mediated by, again, the short-chain fatty acids through its action on adipose tissue, liver tissue, small intestine, brain, genes, at the gene level also, the large intestine and the muscle. And it is very important to understand that all the effects attributed to SCFAs are beneficial. And then comes the term eubiosis and a dysbiosis. Eubiosis is a term where you see a increased population of the gut microbiota, diverse population, more of the short-chain fatty acid production, more of intestinal epithelial integrity, and in the state of dysbiosis, you see the balance between the host and the microbiome is lost, giving rise to a disordered metabolism state. And look at the number of disorders those are associated with the human microbial dysbiosis. You can see, I'm not going to read out the entire slide. It affects the lungs, the metabolism, the brain, heart, skin, the allergic disorders, type 1 diabetes, rheumatoid arthritis, so the list goes on. Linked with metabolic syndrome, how is it linked? So here it is stated, the main component is the short-chain fatty acid. There is a reduced production because of the reduction in the number of the good bacteria, and that gives rise to increased monosaccharide absorption from the intestine, increased energy withdrawal from the carbohydrates, increase in lipogenesis both in the liver and the adipocytes, and also there is an increase in lipoprotein lipase activity. And these again, the mediators, again a number of factors are coming into the picture, where you see there is an inflammation going on, increase in adipogenesis, increase in appetite, glucose and lipid metabolism getting disordered. Also there is a bile acid metabolism disorder which sets in. This is an important slide to understand that the good bacteria populate the proximal portion of the colon, where they predominantly act on these saccharolytic methods, and they produce this SCFA, these short chain fatty acids. Those are the propionate, acetate and butyrate, succinate. These have all the beneficial impact. Whereas, so you can see the SCF, the mechanism of action, increase in IgA, inhibition of the inflammation, promotion of the regulatory cells, inflammasome activation, stimulation of GI mucus production. Whereas this is the one, the harmful bacteria predominantly populate the distal colon. They preferentially act on the proteolytic mechanism, and they give rise to a number of parameters. You can see the indole, phenol, cresol from the aromatic amino acids. Then the branch chain fatty acids like isobutyrate, isovalerate, and the number of gases are also being formed. The ammonia, hydrogen sulfide, methane, carbon dioxide. These all are detrimental to gut health. They promote inflammation. They give rise to breach of the intestinal barrier. And yes, the same mechanism does apply to type 2 diabetes as well. Here you can see there is a translocation of the bacterial lipopolysaccharide, reduction in butyrate producer species, and butyrate has been shown to be promoting GLP-1 mediated subsequent pathways. And by this, there is an increase in intestinal permeability and increase in inflammation, both paving way for the insulin resistance. So this slide probably sums up the saccharolytic versus from the proteolytic products. In normal people, the saccharolytic products on your left, they predominate. They have a beneficial impact on all the adipocytes, the liver and the pancreatic beta cells, whereas in the large colon populating bacteria where there is a proteolytic fermentation, it would be having negative impact on all these organs, giving rise to impairment in beta cell function and also insulin resistance. Type 1 diabetes also, there are few studies to suggest that the butyrate producing microbes are negatively correlated with the risk of type 1 diabetes, whereas the propionate, acetate, succinate producing bacteria are shown to be positively associated. Again, all these are mediated through these gut tight junction integrity and other factors. So this is one study of around 218 patients where the gut microbial profile in type 1 diabetes was studied, and they went on to find that there was a depletion of short chain fatty acid producing bacteria, especially the Eubacterium rectale. And in GDM, as we all know, yes, as the trimester progresses, there is an increase in insulin resistance, and that goes in synchrony with gradual increase in the population of all these bad bacteria, with increase in number of proteobacteria, actinobacteria, candida, clostridia, enterobacteria C, and a host number of others. And there is also evidence to suggest that the anti-diabetics that we all have been using, that also has a beneficial impact, especially the gold standard, the one which we all use rampantly, the gut microbiota, states that it increases the proportion of good bacteria like Escherichia, Akkermansia and the Lactobacillus. It decreases the bacteria which are harmful like the Rosiburia. It promotes short chain fatty acids, protects intestinal barrier. We also know that it increases GLP-1, and it also enhances bile acid mediated action on the FXR or PXR to give rise to better insulin sensitivity. This is a small study, intestine trial, published in 2023, gliptin plus metformin vis-a-vis sulfonylurea plus metformin, and the gliptin plus metformin combination was associated with reduction of the firmicutes to bacteroids ratio, giving rise to better control with the additional signs of weight gain and avoidance of hypoglycemia. So the gliptins, they also do have a role. This slide again somewhat is similar to the RSSDI, the wheel kind of treatment for type 2 diabetes. This circle tells you, the inner circle depicts the anti-diabetic molecules, the middle circle depicts the changes in the microbiota that we anticipate from the usage of these drugs, and the outer circle basically depicts the beneficial impacts arising out of the change arising out of the changes in that microbial pattern. Linked with NAFLD, again the same kind of mechanisms comes into the picture. There is an increase in intestinal permeability, the There is an alteration in the bile acid signaling, increased level of endogenous ethanol. There is a increased in production of pro-inflammatory cytokines, all of them converging upon pushing the patient towards more of an FLD kind of scenario. How does it get linked with the cardiovascular disorder? Here, as I've initially told you, there is a protective molecule called the short chain fatty acid, and then there is a damaging molecule which is also known as the TMA, trimethylamine, that gets subjected to the enzyme which is known as the flavin monooxygenase, which gets converted to TMAO, which is basically detrimental for the cardiovascular risk factor. In the dyslipidemia also, the same enzyme acts on the TMA to convert it into TMAO, giving rise to increase in liver fat production, increase in intestinal cholesterol production, and also the reverse cholesterol transport is negatively affected by this molecule. It also has a role in hypertension as well. It is stated that the increased use of salt is associated with decrease in lactobacillus, oscillobacter, and an increase in lactospiraceae, ruminococcus, and the pasturella. And the Mediterranean diet and the DASH diet, which is predominantly offered to these kind of patients, are also associated with increase in short chain fatty acid production. So lastly, I will take another 5-6 minutes or so to talk to you about the therapeutic value of microbiota and how these can be used as actually game-changing interventions, if not at least some kind of interventions. Yes, these are untargeted. Exercise does increase the diversity of the flora that we harbor. And apart from that, nutrition, obviously, the ones we have to go back and we have to take more of vegetables, the fruits, whole grains. Fecal microbiota transplantation, we must be hearing time and again. Then these are the 4 molecules, the prebiotics, probiotics, synbiotics, and postbiotics. I'm going to tell you a bit in detail. And on your right, there are some targeted therapy. Yes, these are for the future, but then these are also in the pipeline. So prebiotic is a non-digestible substance utilized by microbiota and confers a benefit to the host. So it basically promotes the growth of the good bacteria, inulin, the lactulose, galacto-oligosaccharides, and fructo-oligosaccharides. Probiotics are the live microorganisms like the bifidobacterium and the lactobacillus. They come under the good bacteria classification. Synbiotic, we use the combination of the pre and postbiotic, probiotic, and the postbiotic is inanimate strains with or without the byproducts that provide a benefit to the hosts. You can see the heat inactivated strains of Akkermansia, lactobacillus, and bifidobacterium. And how they help? Yes, again, the same mechanism which actually harms the metabolic health, all those get reversed. There is a restoration of the gut barrier, there is an inhibition of alpha glucosidase activity, there is immune modulation, regulation of bile acid metabolism, decrease in hepatic glucose production, and increase in intestinal gluconeogenesis. And just to take you through some of this, studies which are already there, it has been tried in NASH, it has been tried in appetite control. Basically, they act through the gut-derived peptides like GLP-1 and the peptide YY to suppress the appetite. And this is again a recent one in 2022. The low-energy diets, which we all know has been which has been flooding the market. It is also associated with the metabolic improvement. You can see 800 to 1200 kilocalorie a day. It is associated with metabolic improvement by increasing the Akkermansia and the Christians. I'm not able to spell that, but then there was a reduction in other damaging bacteria as well. And there are some studies in this Egyptian study, it's in around 58 obese Egyptian women, it states that it says the combination, the potential treatment with the probiotics and a high fiber diet is associated with amelioration of the criteria of the metabolic syndrome in obese Egyptian women. In fact, I was going through the literature on its usage in type 2 diabetes patients. There was a very recent meta-analysis in 2024, towards the end of the 2024, published in the journal Nutrients, and it has incorporated around 91 studies. Unfortunately, at the end, they go on to say that they are not able to conclude which kind of strains are ideal, what would be the dosage of the strains, and what would be the ideal duration for someone to get some kind of significant benefit out of these drugs. But then, yes, the studies are ongoing. Probably we would be having them on board very soon. So this is probably the summary slide to tell you that the the beneficial bacteria, the Akkermansia, the Faecalibacterium, the Bifidobacterium, they go down, Escherichia goes up, and with the pharmacotherapy and the bariatric surgery, you can see all these are getting reversed. So we have also studies with bariatric surgery. I have not shown them, but yes, they are also of tremendous benefit. So to conclude, known since ages, I have said that dating back to 360 BC, Hippocrates has told us, and over last 2 decades, we are evincing interest in this particular topic. It is affected by a number of factors, and yes, the same ones which the causation of the metabolic syndrome, the alteration in the diet and reduction of physical activity, these are 2 such predominant factors, and increased usage of antibiotics has also been touted to be associated with the bad metabolic flora coming to the picture. And it has importance in health and disorders, as we have stated that it has impact on the metabolism, it has impact on the physiology, nutrition, immune regulation, and disorders. If you go back to the slide which we have shown in the initial few slides, and that clearly tells us that yes, it is associated with a number of disorders, including the pediatric lung disorders as well. And metabolic dysfunction is widely associated. The obesity, type 2 diabetes, hypertension, dyslipidemia, cardiovascular disorder, hyperuricemia and whatnot. So, and there are some studies to suggest that yes, it would be a newer avenue to treat these disorders. Therapeutic role is there, but then yes, definitive studies to look at the doses, the strains and the duration, that is still a long way to go. So we need to choose wisely between probiotics and the antibiotics. Jai Jagannath, and thanks for the kind listening.
Thank you, Dr. Kota. Please stay with us. Now I will invite one of the esteemed endocrinologists from the city of Nellore in Andhra Pradesh, who happens to be my closest friend also, Dr. M.V. Ramamohan, who has a number of publications, and he is also currently a EC member of Endocrine Society of India. We will be discussing about dyslipidemia and pregnancy, a very difficult and less discussed. Dr. Mohan.
Yeah. Yeah. It's okay.
Thank you, madam.
Yeah. Good evening, all. Thank you for a great welcome. Thank you, Kolkata, for a warm hospitality. So today's my topic is management of dyslipidemia in pregnancy, benefits versus risks. We know that the recent data shows that there is a gap with respect to both screening for dyslipidemia and knowledge of dyslipidemia as a CV risk factor in pregnant women. We know that if the dyslipidemia is the main cause of all the peripheral vascular disease, cardiac mortality, all-cause mortality, MI, heart failure. So that if you miss a patient of dyslipidemia in pregnancy, it is going to affect the future of the mother. So coming to the what is the normal physiology of pregnancy and lipids, we know that in maternal blood there is a normal rise of physiological rise of lipids to have a good fetal development. So we know that the pregnancy is a catabolic phase where there is increased number of LDLC, increased HDLC and also triglycerides. We'll be surprised to know that the triglycerides in normal pregnant ladies can rise up to 4-fold, which is a normal. So like we know that T3, T4 rises in pregnancy like a physiological level. So LDL rising up to 50%, HDL rising up to 30% and TG may go up to 4-fold. So this is a normal physiology. Then what are the adverse pregnancy outcomes of a dyslipidemia, untreated dyslipidemia? So generally it's the lipids supports the fetal growth, but they are linked with increased risk of adverse pregnancy outcomes like preeclampsia, GDM, preterm birth, macrosomia and future risk of ASCVD. So more and more high TG also has a risk of pancreatitis, both maternal and fetal. So this is very important to remember that looking at lipids, a very high level lipids can have a abnormal pregnancy outcomes. So who needs extra attention? So who are the patients who should be careful enough to look for dyslipidemia, mainly women with familial hypercholesteremia, maybe heterozygous or homozygous. Then severe hypertriglyceridemia, TG levels more than 1000, and prior adverse outcomes of pregnancy, like known advanced, like patients who are already having preeclampsia, GDM and preterm birth, you should look for this, and some patients like elevated LPA. So coming to the treatment part, the best treatment should be lifestyle and nutrition. So the mainly the nutrition supplements or nutrition advices like Mediterranean or DASH diets with fruits and vegetables and whole grains and fish and plant oils. Then limited saturated fats and trans fats, and limit the refined carbs and added sugars, and very low fat diets helps in some patients with high TG and also familial diseases. Ensure essential fatty acids. Mainly the benefits are they are very safe. The dietary restrictions of fat is very safe in pregnant women, reduces the GDM risk and preeclampsia risk. Mainly you have to look for calorific deficiency. For example, if patient is not eating properly, there is a chance of the fetus is not going properly. That means that the caloric intake should be calculated so that you are not in a caloric deficit state in pregnancy. Then the next best thing should be in pregnancy is physical activity and weight, where more than 150 minutes a week moderate activity is safe in uncomplicated pregnancies and reduce risk of GDM, preeclampsia and postpartum depression. And excessive weight gain worsens the dyslipidemia and adverse pregnancy outcomes. That means that you should make your pregnant woman with dyslipidemia to work have a good exercise pattern. Then pharmacotherapy overview. The most lipid lowering drugs are avoided in pregnancy because of the adverse events. Expectations in high risk cases like exceptions in high risk cases like bile acid sequestrants, omega-3 fatty acids and fibrates. Then statins can be considered in case to case, and also LDL apheresis. I'll be explaining them in next slides. Coming to the bile acid sequestrants, they are not systemically absorbed, preferred for LDL lowering, safe in pregnancy and lactation. The risks are mainly GI side effects and decreases the absorption of fat absorbable vitamins like A, D, E and some vitamin K and folate. So may increase TG levels, if avoid if TG is more than 300. So these are the very safe in pregnancy. Then coming to omega-3 fatty acids, the first line therapy in high TG in pregnancy. Case report shows safety and efficacy, may rise LDLC in some patients, safe during lactation and monitoring. So the ALA, EP and DHA can be given to pregnant women with hyperlipidemia. Coming to the fibrates, fenofibrate and gemfibrozole for severe triglycerides if omega-3 fatty acids and diet are insufficient, only in selected cases. Can be used after first trimester if benefits outweigh the risk, and the data is very limited in fibrates. Then coming to the statins, we know that statins are teratogenic and we used to have a full contraindications, but in 2011 FDA removed blanket contraindications. Evidence says there is no strong teratogenic signal, but there is a limited data. So consider in very high risk cases like familial hypercholesteremia and ASCVD, known ASCVD patients. Parvastatin is hepatoselective, it has low placental transfer and it is studied for PE prevention. So avoid during breastfeeding. Coming to the other agents, ezetimibe, PCSK9 inhibitors, bempedoic acid and niacin, they are not recommended. There are no data or studies for this. So then coming to the very high risk cases where you need to do decrease your lipids in a rapid way, the LDL affairs is very safe and effective, and also in patients with progressive ASCVD risk, you can do this, and removes LDLC, LPA and reduces inflammation, used in hypertriglyceridemia with pancreatic risk. So for example, if TG is more than 2000 to 3000, you have to acutely reduce the TG so that your risk of pancreatitis comes down. So mainly invasive, costly and limited availability. Then in severe hypertriglyceridemia, as I told you, TG is more than 750, very low fat diet with omega-3 fatty acids can be given. Add a fibrate after first trimester if needed. Hospitalization if TG more than 2000 or pancreatitis. Insulin dextrose infusion with plasmapheresis. First start with plasmapheresis, within 1 or 2 days it settle down, continue insulin dextrose infusion. you can have a good reduced TG levels. Then breastfeeding considerations, avoid statins, BAS and omega-3 fatty acids are safe, monitor vitamins, fibrates avoid, and other drugs have a very limited data. So benefits versus risk summary, you can see that benefits are decrease in maternal adverse pregnancy outcomes, protects long-term ASCVD risk. The risks are drug teratogenicity, micronutrient deficiencies, and medication side effects. So mainly the lifestyle interventions are very safe, diet and exercise. Then pharmacotherapy is reserved for the only selective patients where you need to see in a case-based way so that the adverse events are very less. So same thing depicted in another picture, and these three, as I told you, summarizing. So pre-pregnancy, you should have awareness and appropriate assessment of ASCVD should be seen, healthy lifestyle and management. In pregnancy, appropriate patient care, treatment of ASCVD risk factors, healthy lifestyle, weight management and BP control. During high risk pregnancy, you should have a team care, look for other diseases and look for familial diseases. In lactation, look for safety of the drugs, and education is very important. Post pregnancy, the mother should be followed for long term ASCVD risk reduction. So thank you.
Thank you. Thank you for your nice and lucid presentation. Our next speaker is very senior person, Professor Madam Shorita Bajaj. He is well known to everyone. She is well known to everyone. She is actually founder president of CFS. She is actually first president of ITS, president of RSSDI. So many publications, so many books. I heard her from last 20-30 years. Next, welcome.
So thank you for this kind introduction. A very, very good evening, and thank you for being around for my talk. Of course, thank you to the organizers as well. So of course, there's a lot of material to be covered because it's really a vast topic. I really admire Sunil, the way he brought it in, everything he tried to cover, and very well as well. So what I will try to do is focus on the more recent aspects and just go through the ones that are already well established. This is the roadmap that I will be following. Now, this goes without saying. It's extremely well established by now, and this is a fact which is we have known not now, but for half a century at least, that hyperglycemia during pregnancy is a double-edged sword affecting both mothers and their offspring. So I'm going to be talking about the mother as well, and creating a vicious cycle that can affect multiple generations. So that is why you will understand the question that I had asked after Rajiv Singla's talk, as so that we can focus on gestational diabetes to actually curtail this pandemic of type 2 diabetes. And like I said, we always talk of the HARPO study, but the HARPO study is based on the Peterson hypothesis. Again, that was 50 years ago, half a century. And HARPO left queries in its wake that increasing the prevalence of obesity and diabetes in both adolescents and adults remains to be investigated. So what has now happened over the last half a century and closer to the last decade is what I will try to clarify. So this starts way, way, way before the child is conceived. So there is a genetic predisposition. You add to that maternal obesity, periconceptual influences, insulin resistance, impaired insulin secretion, early life epigenetic mechanisms, DNA methylation, histone modifications, non-coding RNAs, and there is leading to increased risk of metabolic disease, allergy, and neurodevelopmental deficits. Now, I'm sorry. So this is another way of representing it. You can see the epigenetic changes here. You can see the altered physiology, and you can see the increased risk of non-communicable diseases with an intergenerational effect. You add to that the nutrition, the smoking, the alcohol, the radiation, the stress, the sedentary life, and you have a perfect recipe for disaster, which is what is exactly unfolding today. Now, because I'm dealing with the complications to the offspring, I've tried to list it all in one slide, starting from the mother to the fetus, the infant, going on right through life, through adulthood as well. So in adulthood, we have the metabolic problems. In the infant, we have hypoglycemia, macrosomia, glucose intolerance, neonatal respiratory distress syndrome, asphyxia. In the fetus, there is hyperglycemia, hyperinsulinemia. So if we look at the long-term complications, there are enormous health outcomes from maternal pre-existing type 1 or type 2 or gestational, whenever it is diagnosed. Now coming to the more recent developments, focusing on dyslipidemia. See, Ram gave a brilliant talk just before mine, and he addressed the problem of dyslipidemia in pregnancy. But look at what happens. Maternal gestational diabetes increases the risk of dyslipidemia as early as 3 to 9 years, and it itself is a strong predictor of CVD risk in adulthood. Similarly, gestational diabetes in the mother gives an enormous disadvantage to her as far as CVD is concerned. So it's not just the offspring, it's the mother as well. Now these children have been followed up for 4 decades. So we have 40-year follow-up to show that offspring of these mothers, especially if there is a history of CVD or diabetes complications, they are at risk of early onset CVD. And you are seeing it again and again. Young doctors, young people just dying because of coronary artery disease. And it's actually happening. So this was predicted already. Well, again, non-alcoholic fatty liver disease is what Sunil referred to as well in his talk. So the origin of fatty liver, and all, I'm sorry for using this term, but I think I'm still justified to use this term. So even fatty liver per se, it is seen in the fetal period, already established. And this is one big precursor or warning of impending metabolic complications. And there are several reasons for this, which I've tried to highlight here. Now, what about follow-up as far as the weight gain and adiposity is concerned? We have data right from 0 to 6 years. In this study, the data is up to 1 year or 12 months. Here they showed that maternal insulin sensitivity independently is a negative predictor of offspring weight gain and adiposity, and the sooner you catch it. So catch them young as possible, and you can catch them even as young as 1 year of age, right? So obesity starts from birth, and this is well demonstrated here. Up to 6 years, this is the data from 1 to 6 years. Abnormal maternal glucose tolerance during pregnancy is independently associated with a higher BMI and overweight risk. Now, women with a positive glucose test but negative OGTT may be neglected by the health system. So the health services should also pay more attention to the health of these mothers and their offspring. So they should not be neglected under any circumstances. What about the eating behavior of the offspring? So this study provides evidence that exposure to GDM in utero may actually alter the eating behavior. So what we are blaming on the child may already have been programmed in utero. And of course, we know this will affect all the NCDs later in life. Now, this is a very, very important study which is almost completing 25, a quarter of a century. I'm sure you've heard of Dr. Yagnik and the Pune Maternal Nutrition Study. Like I said, it's in its 24th year, and it gives you the origin of the hypothesis, which was also told by David Barker. So you've heard of David Barker, you've heard of Dr. Yagnik, and this is what they have to say regarding the association between maternal B12 status and the child's neurocognitive status at the age of 9 years, as early as 9 years. And if we follow their data, right, the incident hyperglycemia 6 years after delivery in young rural Indian mothers, it suggests that compromised linear growth, adiposity, inflammation, and less physical activity predisposed to hyperglycemia in young rural Indian women. So we have data for children and we have data for the mothers as well. So they have looked into all aspects. They've looked into the exposures of the micronutrient, which I just referred to. They've looked at B12, folate, and homocysteine. They have looked at the neurocognitive performance, the temperament, common mental disorders. They've looked into brain imaging, and then the life course variables, that is from birth, later life growth and development, later life nutrition, and socio-environment. So they've covered everything over the course of a quarter of a century. Again, going back to Sunil, he was telling you about GDM and microbiota. So this is the data that yes, in GDM there is altered gut microbiota right from the first week, persisting into infancy. There's no difference in the overall diversity, which suggests specific compositional changes, not global microbial disruption. So Sunil showed it changing through the various trimesters. It is linked to reduced microbial richness, inflammation, and future metabolic dysfunction. So you need to monitor early, and the potential microbiota targeted interventions can also be considered to mitigate the long-term metabolic risks. You cannot talk anything without talking about vitamin D, and look at the whole entire list for the mother and the child, autism, multiple sclerosis, the changes in the bone, and the changes in the fetal outcomes as well. But it is important to note that vitamin D supplementation helps reduce this, improves fetal growth and bone development, and lowers the risk of respiratory and immune-mediated disorders. Early intervention is essential. Even reproductive health. Prenatal gestational diabetes exposure may impair gonadal development and hormonal milieu, raising the risk of subfertility in adulthood. We know this. I'm not going to tell you what are the ADA standards of care, except the counseling is important, glycemic targets well before conception, and screening universal. We know that. We know the importance for outcomes, optimizing health, early intervention. We know all this. We also know the treatment. Yes, lifestyle. Yes to insulin. Yes, several times, many-fold yes to insulin, and yes to metformin as well. But are there any differences in the offspring depending on what treatment modality is administered? That is the crux of the matter. Right, so I'm giving here the pros and the cons for metformin use in pregnancy. right? So there are a lot of pros and cons. But let me focus not on the 2022 data, but on the 2024 data. This is Indian data written by an Indian group, right? So we have Deep here, we have Saptarshi here, and we have Lakshmi. I'm sure they're all very much here. So this is their data, along with Dr. Yagnik, right? So this is very, very important. This is offspring 5 to 11 years, a systematic review and meta-analysis, metformin use in safe without adverse impact in children up to 11 years. This is what the data says. Children born to mothers who have received metformin or insulin during pregnancy at 9 years after birth had similar BMI, body composition, parameters, and liver fat percentage as well. So the occurrences of obesity and diabetes in mother and children were comparable. So this is very, very good data out there. What about use of CGM? What are the clinical implications? Yes, improved glycemic control, lower maternal weight gain, reduced infant birth weight, but the bottom line, no impact on major outcomes. So what do I recommend? See there is a limited evidence base. So we recommend targeted use, and therapeutic consideration is that it may complement pharmacological interventions, metformin and insulin, which I was talking about. So limited, targeted use here. The most important question now that needs to be addressed is after delivery, what about breastfeeding? Extremely good data again. Yes, support infant nutrition, growth, development, reduces chances of allergy, infection, and NCDs, depending on which are the species, which increase or decrease. And this is opposite to formula feeding. So breastfed infants have lower gut diversity, but more stable associations and beneficial bacteria linked to early nutrition and health. Right, this is the SWIFT data. This is it's a decade old, but they highlighted very well that the case control studies have reported that longer breastfeeding duration may lower the risk of NCDs. Coming to more recent data from 2024. Now look at this data, it's very important, just not exclusive breastfeeding. Even mixed milk feeding can help. So when exclusive breastfeeding is not possible for the mother, even mixed feeding, milk feeding should be encouraged in the first months postpartum, and women should be educated prenatally about the benefits. So exclusive and mixed are beneficial. Again, this is very recent data. Even short duration of exclusive breastfeeding in certain women who face challenges, and tailored support is required to breastfeed, especially those who live in the most deprived areas. So breastfeeding in any form is advantageous. What about the composition of breast milk in type 1 diabetics? So glucose levels at or prior to breastfeeding should not influence the decision to breastfeed, and we still need more research, we need more longitudinal studies, but this summarizes the main findings regarding the composition of milk. So if the blood glucose is increased about 90 to 120 minutes before breastfeeding, then the breast milk glucose and fructose both go up. So, but they've shown that infants, there is no excessive weight gain at 6 months. But there are a lot of gaps in this future research is warranted. Well, I would like to end my talk here. I've told you about the enormous risks, right? I've told you about early screening, proactive management, which are essential to reduce complications and improve outcomes, timely intervention. It is preventable, it is manageable, maternal health optimization. long before pregnancy is conceived, during pregnancy is crucial, and lifelong offspring health optimization is required. Thank you. Thank you very much.
Thank you, ma'am. Thank you. Very nice and practical aspects you have covered.
Sunil, yeah.
Now the forum is open for question and answer session.
Hello. Sir, you told that in hypertriglyceridemia in pregnancy from 750 you started treatment. So up to 750 you needn't.
So no, sir. The normal TG levels will be more than 4 times.
Yeah.
So if you take it, it goes around more than 500. So that means that if you want to start treatment, first part should be having a diet and exercise follow-up for 2 or 3 weeks, then you see, sir. So it's not the value which decides, sir. So you have to see the follow-up the patient, so that if it's coming down with diet and exercise.
Now, if the patient has high ASCVD risk, even then also.
So first 2 or 3 weeks you can take a chance of diet and exercise because you're not going to harm her then.
And whether EPA only, as we do use up to 4 gram EPA, instead of that you prefer omega-3 fatty acid.
Yes, sir. Sir, I don't have a basic experience. We never used it, sir. So these type of cases we don't see experience. I don't. You can add.
If you multiply that 4 times, I think you will get the number that he said, when we start treatment. But I think it would be rare to have a baseline triglyceride. So we're just taking the upper limit of normal. So I think possibly that would translate into 750, what he said. And the other thing with EPA, we don't have much data. We don't have much data out there. But yes, I'm so glad he gave that talk. Because a lot of times, the women come with very, very high LDL values, and as of now, it's only diet. But then, during pregnancy, even when you give them a trial of diet during diabetes, it's for 2 weeks only. So 2 weeks will be very short for lipid reduction, isn't it? But nevertheless, I'm afraid maximum I would go up to 4 weeks, not more than that, before taking a decision. But lifestyle first is very, very important.
So last month I had a patient sent from a gynecologist saying that TG was 550, sir. So I counseled her and sent home saying that we'll wait and see. So last week she came, it was around 320. So
yeah, I think the diet is important.
Thankfully, unlike the LDL, triglyceride is more amenable to diet and lifestyle.
Definitely, diet and exercise.
Yes,
yeah.
Thankfully that is more amenable. So probably yes.
And normally for statin use, we have a strong black box warning that it should never be used in pregnancy. But he was telling that from second trimester, if it's high ASCVD risk, can we use statin or not?
Sir, statins are the last option, last choice, because we don't have really data. So, and also you have to calculate the ASCVD risk at a pregnant woman. So the age and risk factors with any other familial hypercholesterolemia is there or not, you have to see. So then only as a last choice only you have to use statin.
Is there any separate calculator for pregnant persons?
I don't think the scores are validated for pregnant ladies. So probably the ones which we have been using for others, especially we have for the H-risk, Q-risk scores, probably that we can use, but then I don't know its validation in pregnant ladies.
Okay, thank you.
Just a comment. As far as I know, that icosapent pentanoic acid itself is the omega-3 fatty acid. So we are using omega-3 fatty acid itself.
No, icosapent pentanoic acid and the omega-3 fatty acid are different. Different. They are different actually. They are different.
In which way?
I think two isomers. It is the eicosapentaenoic and I think another one, the docosapentaenoic acid. Hexanoic acid. So the one which we get from the fish oil is a combination of these two, and the eicosapentaethyl only contains the ethyl. Only one isoform.
Hello, sir. Is there any? Yes, sir. For all of you. Sir, is there any recommendation to use saroglitazar in high TG in pregnancy?
No.
I'm glad you brought that out. I think the pharmaceutical house has already filed, I think even in US for saroglitazar. So I'm very proud of it to have an Indian molecule which is hopefully out there. Of course, a lot of good molecules are coming out in the context of non-alcoholic fatty liver disease or MASH, whatever, but not in pregnancy, that's for sure. That's for sure.
Okay, thank
But
you.
can you use long-acting insulin, GDM?
Yes, of course we can. Of course, and even Glargine, which was not approved earlier, if the patient has already been on it, we don't remove it. Most of the insulins are approved, yes.
Dr. Sunil. Dr. Sunil.
Yes, sir.
Here. One question.
मुझे लगा जगन्नाथ जी बुला रहे हैं. बताइए, please.
My question is the gut microbiota and alcohol intake, whether there is any interaction. There are so many alcoholics here.
Yeah, actually, I have not looked at that angle. So it itself was a vast topic. I had to take out so many slides, but I have not looked at. Yeah, very practical thing. But then probably it would. I have not gone through that aspect actually. Yeah, by virtue of its association with metabolic syndrome, obviously it should have some changes in the microbiota composition, but then the exact change in composition I am not very much aware. Obviously you can roughly say there is an increase in harmful bacteria, there is a decrease in protective bacteria, we can say that, but beyond what intake, so that again is, I am not very aware actually.
There was an article, a 1 hour program on Netflix about gut microbiota, and it has shown that in that maybe a less data, 30 types of fruits or vegetables in 10 days will increase your gut microbiota, double or triple.
Yeah.
So the variety of fruits and vegetables, how much you make the difference in between them. You take different types, it increases your gut microbiota.
Yeah, actually that I have also shown the Burkina Faso diet versus the ones who are on European diet, where yes, the diet rich in fiber which you are alluding to definitely has a beneficial impact.
Dr. Sunil, these days there is a talk regarding the fermented rice. There is a panta bhat or pakhal bhat. Does it have any effect on the gut microbiota?
Yes, actually I have come across this literature. I didn't deliberately show it because done on very few number of patients, but then yes, if you recollect one of my slides, these saccharolytic products are useful to the gut, the proteolytic products are harmful to the gut. So compared to rice, the rice which is stored overnight with water, that is pokhala, what we call as, so that definitely has an impact. That, see, I have come across a number of studies. So for some the numbers are even single digits, so I didn't quote them, but yes. So the purpose is, as of now, just now Sarita ma'am was also telling, like vitamin D, the gut microbiota alteration, is it a cause or it is an effect? That we do not know. Like the vitamin D data dates back to probably 5, 6 or 10 years back. It also is not very clear. The situation remains still dicey. What would be the dose, what would be the strains, what would be the duration, and how effectively we are going to monitor whether the patients are responding to that or not. But yes, that again is a mechanism of action of beneficial impact of the food that we are talking about. Fermented rice, yes.
There's one more regarding this increased incidence of cesarean section and the gut microbiota, the deficiency.
Yes, actually, yes, these all are postulations. I have clearly shown the difference between the gut microbiota population, between that of the ones subjected to vaginal delivery versus the ones who were subjected to cesarean. But then these are found to be the findings, but what implication will it have in the long run, that we need to know. Like the one showed by Madam, quarter century study. So I have not come across those kind of, so we have to prospectively look at them and see whether what kind of changes that are going to happen in those particular kids.
So, okay, thank you everyone. So nice to meet you.
Thank you all. We had some wonderful session in Hall D today, starting from the oral paper presentation in the morning and some very good talk in the afternoon session. Now we'll move to Hall A for the inauguration, and we call it a day for Hall D today. D. We have to go to A.
I